the darker, the worse. The more it goes red, the worst. Yes, as a reminder, this is the United States of America. Okay. This was just to show you that how the situation of obesity has moved, has drastically worsened from 1990 to 2006. That is over the course of 16 years. So now I'm going to discuss with you on the rising epidemics, not in the US, but in sub-Saharan Africa, especially in Cameroon. I don't have any conflict of interest, and I would like to acknowledge some slides received from Dr. Felix Assa. The objectives of this talk is to the target audience to be aware of the fact that obesity is rising steeply in sub-Saharan Africa, and especially in Cameroon, to be aware of the health risks of obesity, to be aware of the means to prevent obesity, and last but not the least, to adopt obesity preventing behaviors and spread around you. It's not a lecture on obesity because I'm sure you have great professors, my friends and colleagues have been teaching you about obesity. So I'm just going to raise some few points which will serve as a point for discussions during the exchange section. This is what I suggest to you as agenda. The first will be to answer the question, what is obesity, very briefly. Then secondly, I will answer the question, why, what is its burden? Then what is the situation in sub-Saharan Africa, especially in Cameroon? What should be done to control obesity in Cameroon and elsewhere? And we'll finish with some take-home messages. What is obesity? Very simply said, you have gotten this in your lectures. According to the Obesity Society, obesity, these are keywords: increase adipose mass in such an extent that it becomes a health problem. Three key terms. The fat mass is increased in the body in such a way that it becomes a serious problem, a serious health problem. This is the conceptual definition that will almost never change. But what can change is the operational definition. That's how we decide clinically that someone has obesity. And the parameters that's usually used is the body mass index. That's calculated by dividing the weight in kilograms by the square of the height in meters, which makes meter square, to define obesity, provided that you rule out any other situation in which the body mass or the body weight might increase without being caused by fat, pregnancy, ascites, or any other situation. And the distribution is assessed using the waist circumference. You have also gotten in your lectures that obesity is defined across a range of BMI ranges. We have, the BMI is normal when it's between 18.5 to 24.9. When it gets higher than 25 to 29.9, we call it obesity, not overweight, there's a problem. Then obesity class 1 between 30 and 34.9, class 2, 35 to 39.9, and class 3 also commonly called morbid obesity, when the BMI is equal or higher than 40 kilograms per meter square. What are the risk factors? Globally speaking, someone develops obesity because there is an imbalance between energy in and energy out. It is very simple. Obesity cannot come from nowhere. If at any point in time, your intake in energy is higher than your output energy, you will store. It's just like in this room. Let's say it is amphitheater 700. there should be 700 people or less. And let's just, there's an indoor and if at any point and there be people entering and people getting out, at any point in time, there are more than 700, that is, let's say 1,000, it means either more people enter than people who went out. It might be, let's say 10 people should enter at any point in time and 10 people should go out. If we have more than 700, maybe 20 entered and nobody got out, or 20 entered and just 2 went out, okay? Or 10 entered as normally, but nobody went out. This is how we should see obesity simply. So overeating, low energy expenditure, physical inactivity, these are the factors. And when you go around, you can understand what's happening. Yes, we say we are in sub-Saharan Africa, we don't have money, but the reality is that people have moved from an active lifestyle to a sedentary lifestyle. So what's the burden of obesity then? Let's start with the global figures. The global burden of obesity shows that if we consider adults age 18 years or above, 13% of them, that is 600 million people, are obese. 39%, that is 1.5 billion overweight, making a total of 2.5 billion people abnormal high weight. That is 1/3 of the overall humanity. But what is much more alarming is because one indicator that the future is either brighter or darker is to see what's happening in those who are younger. And when we get to children under 5, 6.7% are overweight or obese. That makes 43 million. This is just a way to show you, this is from the WHO website. It is exactly what I've just said, the key facts on obesity, to ring the alarm to people, all the people who go through the website. So obesity may concern even 8 billion people. It will never be a problem if there won't be any consequence. The problem with obesity is that being obese can lead to other health threats. And what are these health threats? Cancer, respiratory diseases, gallbladder diseases, kidney failure, stroke, heart failure, atherosclerosis, type 2 diabetes, hypertension, just to name a few. I'm not exhaustive. Here we have the same complications organized into systems with subheadings: cardiovascular, respiratory, neurological, endocrine, gastrointestinal, genitourinary, women health with infertility, cancers, musculoskeletal complications, skin and integuments, and psychological complications, especially depression, stigmatization, and image problems. I would like to substantiate my taking the example of diabetes. I'm a diabetologist, so you forgive me if I tend to focus on diabetes in relation with obesity. This was published more than 20 years ago, but the situation is exactly the same or even worse. See what's happening. The higher BMI, the higher the likelihood or the probability to have type 2 diabetes, either in women or in men. It seems to be worse in women, but the picture is almost the same, showing that the relationship between BMI or between obesity and type 2 diabetes, which is one of NCD, non-communicable disease, is almost a linear relationship. Why? Yes, why this rising burden? You see, I think when we look at this, we do not need any comment. Do we need any comment? Let me say some few things. Philosophically speaking, things seems to be like the Creator created us to move. So we are paying for our sins, not the other sin we were used to recite or repeat. Our sin is that we're supposed to move before getting our energy. So you move, you spend energy, you get food, you replace energy, and you are balanced. But the problem of humans is they have something that makes them different from other animals. They are neo brain. Yes, the brain specialist there. Please forgive me if I say rubbish. They have this, they are neo brain that has helped them to invent things, to create things. And one of their major focus has been to prevent themselves from moving to get their food. So we have to pay for that. We're condemned to move. We have stopped moving, so we pay by having obesity and then type 2 diabetes, hypertension, and others. This is the picture. I've just shown you the picture, globally speaking, the world, Africa, and elsewhere. So what's the situation? Because we might still think, okay, if it's a situation in US, France, Europe, and if Cameroon is spared, it's our business as well. Number one, let us move to this publication from Africa. Just to help you, let's focus on Central Africa. But globally speaking, you see from 1980 to 2010, that is 30 years, almost a linear and very steep increase. Let's focus on Central Africa. I think this is Central Africa. The situation is almost similar across Africa. North, Central, West, Southern Africa, Eastern Africa. Compare with the world. You even see that Southern Africa is above the world average, meaning that to the answer, is obesity in Africa? The answer is obviously yes. Is obesity pandemics worse in some areas of Africa than some other areas in the world? The answer is also yes. This is Africa. I said earlier that I want to know what focus on earlier stages of the development. Thank you. This is the situation in children in this meta-analysis systematic review from 1980 to 2015. You see that the prevalence, the burden of obesity has progressively increased from 1980 to 2015, almost tripled and even multiplied by 10 in some areas of Africa. This is showing exactly the same thing in a different way. Then let's get into Cameroon. The first thing I'm going to show you is this study by Eugene Sogwe, whom you know very well. 20 years ago, what was the situation? Because one of the risk factors of obesity is moving from the rural areas to the urban areas. In their team at that time, they compared the prevalence of obesity and overweight in rural versus urban. And you can easily see that. Rural men, urban men, almost 10 times. Urban women, almost 3, 4, 5 times prevalent in the rural, showing that the more we move from a natural environment to an artificial, let us use it this way, we will get more and more obesity. Then with my team, we have been focusing on obesity in various aspects over the past 10 years. In this first slide, I'm going to show you what we did here is that we screened uh, newly admitted students in some private universities. That is 2012 we screened, 11 we screened, 12, 13, 14, to see if over the years there is a change in the prevalence of people who have obesity. And what did we find? Number one, the prevalence of obesity, either in women or men, overweight and obesity, increasing from 13% to 21%, and from 25.9% to 33%. This was in Douala, in the university institutions, with a very significant P trend. Then focusing on the specific aspects, the worst type of subtype of obesity, which is abdominal obesity, the trend was almost similar. Then the next question in this same work was to see if having obesity of overweight had any relationship with having high blood pressure. And what happened, which we would have liked not to happen, is any 1.11 increase of kilogram per meter square of BMI any 1 point increase in BMI increased by 1.11 times the likelihood of having hypertension, and any 1 point increase in waist circumference increased by more than by 1.1 the likelihood of having hypertension, showing that, number one, obesity and overweight are increasing in that very young population, and number two, this increase is linked with a higher risk of having hypertension at that time and obviously in the future. Then getting back to earlier stages of the development, we focus on school children between 3 and 13 years. In this study, we compared in Douala the so-called rich with so-called poor neighborhood, because we wanted to assess the role of socioeconomic development level. And what we found was intriguing, because the prevalence was almost doubled in the high socioeconomic level neighborhood as compared with poor socioeconomic. And in analysis, we found out, which is much more interesting, and which calls to our attention on how we should prevent that in our children. This was mediated by free drink consumption, passive travel to school, and not doing sport at school. Then the next question was whether having obesity in children had any connection, as we just saw it in young adults, any connection with cardiometabolic profile. In this study, which we did with our collaborators, pediatric endocrinologists here in Yaoundé, what we found was not only comparing children around 8, 10 years, those obese with those without obesity, well matched. What we found was being obese or overweight increased likelihood of having hyperglycemia, higher total cholesterol, higher LDL cholesterol, higher triglyceride. The same was seen with systolic blood pressure, diastolic blood pressure. Then much more recently, I was invited to write the editorial in the Lancet, because I don't know if you saw that paper, it's probably going to change. We usually thought, yes, BMI from 25 increases the risk. But what's happening is there was this paper published in 2021, and they went across many countries in many continents. They took studies, and the question was whether the cutoff of 25 is really the one that should be used. And the findings are just not good because let us see this. Let me focus on sub-Saharan Africa. See, just for you, to ease your understanding, in blue, blue concerns those because blue concerns those who are upper normal, and upper normal here is 23 to 24.9, which is usually considered as part of the normal range. Then overweight is as usually defined, and obese is as usually defined. And you can see that in women, whereas in most other areas, being at that upper normal range didn't increase the risk of having type 2 diabetes. In sub-Saharan Africa, women 1.24 adjusted relative risk, and in men 1.43 relative risk of developing type 2 diabetes, which means our clinical practice, we should start thinking of shifting the norms, because the norms were usually set based on what? Based on the risk of developing complications. Now that one of these major complications, that is type 2 diabetes, is shown to start developing we should hope, we should act, we should think, we should act, and we should follow, because at the end of the path, if we keep going, we'll reach the result. Thank you very much.
Thank you, Professor Chukem. That was a real magistral lecture. And I believe we all know what is happening, risk factors of non-communicable diseases that we face in Cameroon, and what we need to do to improve on that. Our next keynote lecture is going to be delivered by Professor Alfred Jamshi. And this presentation is titled Perspectives and Challenges in Diagnosing and Managing NCD Emergencies in Cameroon.
First, I would like to thank my personal friend and brother, Prof. Theodore Achu. Not only are we classmates since Cast Bambly, that's many years ago, we were saying yesterday that this is the first time we're in the same classroom again after many years. But I should say here that if I'm a fellow of the Royal College, it's thanks to his catalysis and momentum. My dear brother, thank you for everything, and thank you for leading CamDoc to our faculty. I'll take a few minutes to talk with you. We already know a lot about this. Since yesterday, we've been discussing the challenges. So I'll spend more time on the perspectives. What should we do? And I'm glad that Professor Chukem has already done a good job in that direction. I have nothing to declare. We all know that from the womb to the tomb, we have only one brain. We may have 2 lungs, 2 kidneys, and 2 other things, but we have only one brain. So we need to take care of our brains, as Professor Chukem said. And if our brains do not work, the rest is not important. I'm going to give you a little background, and then the challenges in the diagnosis of management of NCDs. I have decided to classify them as NCDs. I'll also try to look at the perspectives under the acronym NCDs, and then we'll have a short conclusion. What is the background to this? Many of us are familiar with these risk factors, with these diagrams that have the risk factors for dementia 2017, 2024, the one on the left at the extreme right, that has been updated. Most of these risk factors for dementia are actually NCDs. And dementia itself is an NCD. So when we are talking about the challenges, NCDs are propelling NCDs. And most NCDs are risk factors for brain health. To an extent that the European Academy of Neurology, in its strategy that is just published on how to tackle brain health and promote brain health, you see that most of the action is around NCDs. You see things, diabetes, hypertension, obesity. Even when you're thinking of preserving the brain or protecting the brain, or planning on how to promote brain health so that you can have better economies, NCDs play an important part. Risk factors. This is a global burden of disease study we just conducted, and it's under review in global brain health. And you can see, just like for obesity, as Professor Chukem showed you, the trends are terrible. For most of Africa, for stroke, ischemic heart disease, and dementia. This is for ischemic heart disease, and you can see these trends: North Africa, Central Africa in red, taking the lead. Male and female, all involved, the trends are increasing. So it's an alarming problem. Since 1990 to 2021, you look at stroke in Africa, Cameroon is in the red, forms part of the Central African section on the right. So the trends are not good, have not been good for the past decades. So we need to invest. We need to invest to reverse our challenges into opportunities. How much should we invest? Prof. Chukem was asking. As much as it is needed is not too much, because time lost is brain lost. Because time is brain. The business model is investing in these things, investing in changing the economy, and we call it transforming the current economy that is producing fast foods, processed foods, as Prof. Chukem showed you in his last slide, into eating biological food, transforming the economy from this current economy into a green economy. And we've written several publications on that. And even the last summit discussed that significantly. The challenges, 3 categories, NCD. Category N, non-availability of resources and data. Prof. Chukem has showed you some data, but that's not enough. That was just for obesity. We have some data for hypertension. We don't have enough for other NCDs. There is a problem with coordination. The coordination of emergency services poses a real challenge in Cameroon and Africa. And then the disease conditions themselves are a challenge. They are chronic, and some of them are stigmatizing. And since everything is connected, whether we walk or not, what we eat is connected. The brain is important. Emergency means time. And when you are talking of time, time is not money, as we used to say. Time is brain. Because even the money, we make it with our brains. So brain health is essential for smooth economic transitions towards economic sustainability, productivity, and well-being. Well-being means pushing away the NCDs. Non-availability of resources and data. We don't have enough, even though this faculty is training many specialists, and we just have a new list again, we don't have enough trained specialists who are continuously capacitating themselves. And specialists here, I'm talking of physicians, general practitioners, specialized physicians, in all these aspects. Paramedical personnel are very important, but we don't have enough of them trained. Do we have ambulance personnel that are well trained? Lab personnel? Material resources. How many emergency services do we have that have equipment that are working for us to be able to take care of emergencies like stroke, CTs, MRIs, even diabetology? I know the ministry has bought several BP machines, 6,000, Professor Subway told us, and the BP and glucometers. But how many emergency services are going to have that? It's a real problem. We need data. We need information. We need statistics, because statistics will show us the trends, as we have learned again this morning, for coordination and planning. This is one of the very beautiful studies that Professor Mbanya, my elder brother, and others participated in that show, talk about abdominal adiposity and obesity, and we've been fed enough by Professor Chukem this morning on that. This study is in the whole world, but with this, we don't have this kind of data staggered for Cameroon and staggered for our different regions and our different districts. We need a lot of national data to be able to work on. And I know Prof. Chukem and Subway and Banya, my elder brother, and the rest are working on this, but we need more. The third category is coordination. Second, coordination. How do you get an emergency from the house to the hospital or to the health service? Do we have home care services that can take care of some emergencies at home? And in the ambulance, are ambulances equipped to be able to take care of emergencies? Then we have challenges with intra-hospital coordination and communication. Sometimes between the lab and the emergency service, there is no communication. Results are done in the morning, they sit there, and only in the evening are they passed on to. And then the results may be coming when the patient is already dead. Problem of communication. Inter-hospital facility coordination. I know that in Yaoundé we have one emergency hospital, but is the capacity of that unit enough for the city of Yaoundé? How does that unit connect with the different emergency services of the hospitals in the city? We all know. Do we have a place for telemedicine in NCD emergencies? Not well coordinated. Last category of the challenges, the disease conditions themselves. Diabetes, epilepsy, dementia, some of these are stigmatizing conditions. And that is why the diagnosis is usually late. Many times the patients present already with complications. Late diagnosis because there's insufficient screening for case detection, presenting as acute complications. And these present an acute economic and social burden on the families, and caregivers themselves will develop obesity and other complications because they have to stay away from work to take care of the sick patients, and the cycle continues. Many of these patients have other morbidities. High blood pressure and diabetes usually go together, and many other comorbidities, and all this aggravates the others. What about the perspectives? We are not here to paint a dark picture, as Prof. Shukem already said. There's something we can do. It is for each and every one of us to decide, each one according to the level of activity. Prof. Shukem already introduced to us that we need to look for African norms for BMI. We need to have norms. Norms exist, resources and data. We need to have norms, even training norms. Secondly, we need to create emergency coordination services and centers. And lastly, I said that my perspectives would still be NCD, so you can remember. Norms, creation of emergency services, dissolution of stigma so that we can increase screening activities and avoid them coming with late complications. For norms, human resources, we have to train emergency teams, not just for NCDs, but for all complications, for all emergencies. And if we do that for all emergencies, NCDs will be taken care of. Material resources, emergencies. It's like my hospital, we used to have a place for the helicopter to land, but now it is a building on it. No helicopter transports any patients anymore. But that is a norm in countries that want to be developed. Data, we need normative data. Thank you, Prof. Shukem, for your introductory work. Partnerships is a norm, and that's why CamDocUK is here. Creation of emergency coordination services at the national level. What about MINDEF? That's the only department in the country that has helicopters now, but can they be used for emergency purposes, starting with NCDs, like stroke? What about the idea of creating an emergency service dashboard with all of the IT that we have and all of the telemedicine potential that we have in Cameroon and Africa, and to bring this at the national level and then roll it down through our health system, through the regional and district levels, and taking care of the urban-rural divide that Prof. Shukem talked to you about, so that in the rural areas, we can have less sophisticated equipment connected to the urban area by telemedicine or new information technology, so that we can improve. We have enough resources, but we need people to do that and scale up. Lastly, dissolution of stigma. Stigma is a big problem in NCDs. If we reduce stigma, we will be able to increase screening activities. And if we screen early, we'll be able to treat. And if we treat, we will be able to reduce complications, which are the emergencies we are discussing. And for that, I gave you the ECG mnemonic to remember for dissolution. PQRST. Partner with patient associations. We cannot sing this story enough. Patients will help us. In Africa, it's mouth to mouth. They will help us to bring other patients. quadruple the qualified community NCD workers. Yesterday, Professor Subwe was talking about community workers. We need them for NCDs. They should not only be involved in malaria, AIDS, and HIV, they should also work for NCDs, the same people. Recruit and retain all participants in research so that we can follow them up, diagnose things early, and prevent them. Seek and serve the unreached populations. Our country has many remote areas. We need to be able to go and seek and serve them. Test and treat has been proven for HIV, for other filariasis. We should do that also for NCDs. So, in summary, NCDs present NCD challenges, and NCDs need an NCD approach as perspectives. We need to have a national NCD plan. I know we have it. Create a national brain health plan because, in my opinion, all NCDs are risk factors for brain health. So if we have a national brain health plan that is effective, it will take care of all NCDs plus other things. And we need to develop an emergency culture because time is brain. With Professor Mbanya, we developed an diabetes policy program in 2006. And in 2023, the ministry is working on an NCD program, which does not involve all NCDs. And we are saying that the ministry needs to go beyond this NCD strategic plan to have a brain health plan that will involve all of that. We need to plan beyond NCDs in Africa, because planning and taking care of NCDs will improve our economy. It's an economic drain to our country. Imagine in Cameroon a time when the incidence of NCD emergencies that we have been discussing for the past 2 days is significantly reduced in Cameroon. Imagine a time that the prevalence of NCD emergencies is stabilized, reduced by NCD-related death. Imagine a time when no medical evacuations out of Cameroon for NCDs or other emergencies will take place. A time when Cameroon will receive medical evacuations from other neighboring countries, not just for NCD management, but for other diseases. Imagine a time that Cameroon will be training NCD and brain health experts for neighboring countries. Imagine a time, and that time is now, when the Cameroon's diaspora can intervene. They don't need to come to Cameroon, but they can stay in London and through telemedicine and AI and other things, intervene in our rural areas to prevent NCDs and prevent NCD complications, which are the emergencies. We might need to develop an NCD index. I don't know if one exists. We need to have a brain capital index. And if we can be a leader in that, Cameroon leading Africa, that would be great. That time is now. We all need to plan because the time is now. We need to use our brains, not to destroy them, but to reduce NCDs and NCD emergencies. In conclusion, we need to transform all our challenges in NCD management into opportunities, because as one great personality that Africa gave to the world has said, a winner is a dreamer who never gives up. He never loses because he either wins or he learns. That's Mandela. And another person of the world of African ancestry said, the time is always right to do what is right. The time is now. I acknowledge the University of Western Ontario for the work we did, and our brain research initiative, and our hospital in Central Hospital, and a grant givers. I think that this is a continuation. This conference is a continuation of work that we started in July with Professor Mbanya and Professor Njoya Udu to talk about brain health and the promotion of brain health for economic reasons and even for political reasons, because we need our brains to be able to vote for leaders. Thank you very much.
Thank you very much, Professor Njamshi. I think that was a real magistral lecture again. I'm getting more and more emotional the more the speakers come up to actually give us some information on what we are talking about, NCDs and emergencies. So we've heard about significant emergency in obesity, emergency in diabetes, emergency in brain health, and all of that really puts what we consider emergency in non-communicable diseases, at least in Cameroon. I will have to apologize because I want to make an executive decision to alter the program. The British High Commissioner is running late and will be here in about 45 minutes. So I would like us to skip coffee break, move on to the next session, neurological emergencies, and then we merge the coffee break with our lunch. Please forgive me for making that switch. Thank you.
Are they ready? I would like to invite Doctors Ngarka and Banda to come up to the stage while waiting for Dr. Chokute, who are the three presenters in this session, while the technical team is putting the slides. They're just We'd invite, we'd invite the participants to sit down so that we can start. Thank you very much for staying back. And thank you, Prof. Ngachu, for passing on to us this session. We have 3 presentations. The first would be Principles and Management of Epileptic Emergencies in Sub-Saharan Africa. This presentation will be done by Dr. Mbanda Paul Cedric. Dr. Mbanda is a consultant neurologist and med assist in the General Hospital, Neurology Department of the General Hospital, Yaoundé, and med assistant, very soon agrégé in our faculty in neurology. Dr. Mbanda, you have the floor.
Merci, cher maître, de me passer la parole. Bonjour à tous. Nous sommes heureux d'être ce matin avec vous et nous sommes vraiment devant nos maîtres et c'est un honneur pour nous. Et merci vraiment à toute l'équipe du comité d'organisation. Dans quelques minutes, nous allons vous parler des principes et de la prise en charge de l'état de mal épileptique en Afrique subsaharienne. Donc, le but, les objectifs, c'est de pouvoir définir un état de mal épileptique. On va s'appuyer sur l'état de mal épileptique convulsivant, connaître les causes fréquentes dont on va parler rapidement, reconnaître les différents types d'états de mal et surtout, on va insister sur la prise en charge, donc initier le traitement d'urgence. Donc, nous allons parler de l'introduction. Le plan, c'est introduction. On va parler rapidement des mécanismes physiopathologiques, de la clinique des causes et on va insister sur la prise en charge parce que c'est ça qui nous réunit surtout. Donc, l'état de mal convulsif, EMEC, c'est pour état de mal épileptique convulsif. Dans la définition, ce sont des crises qui surviennent chez l'adulte ou l'enfant de plus de 5 ans, mais des crises continues d'au moins 5 minutes ou au moins 2 crises successives sans récupération complète de la conscience entre les 2 crises sur une période d'au moins 5 minutes. Donc, c'est vraiment pour l'adulte et l'enfant de plus de 5 ans, parce que l'enfant de moins de 5 ans, c'est autre chose. Donc, il faut retenir cette définition plus de 5 minutes, parce qu'au-delà de 5 minutes, il y a des dégâts neurologiques qui commencent à devenir irréversibles. Il y a d'autres définitions, on va aller rapidement, comme les crises subentrantes dont on a déjà entendu parler. En fait, ce sont des crises qui empiètent les unes sur les autres, avec l'une qui commence alors que l'autre ne s'est pas encore terminée. C'est un peu un synonyme d'état de mal. Et des crises sérielles sont des crises, des crises sérielles, c'est lorsque le patient fait plusieurs crises, mais peut reprendre la conscience entre celles-ci, mais ça peut annoncer un état de mal épileptique. Et l'état de mal réfractaire dont on va parler rapidement, c'est lorsqu'il y a une résistance à eux, c'est antiépileptique, aux antiépileptiques de première et deuxième ligne. Donc, tout état de mal épileptique mal traité va donner ce qu'on appelle un état de mal larvé. Ça aussi, il faut savoir à connaître, parce que le patient ne convulse plus de manière clinique, mais lorsqu'on lui fait un électroencéphalogramme, il y a des anomalies qui persistent, un état de mal larvé, lorsque l'état de mal épileptique convulsif a été maltraité. On va rapidement aller, parce que l'épidémiologie, on n'a pas beaucoup de temps. Il y a quand même une forte mortalité dans l'état de mal épileptique. Ça, il faut le savoir, 20 à 50% d'après les études. Et la morbidité, quand même, aussi, est assez importante. Le mécanisme, on ne peut pas vraiment insister dessus, mais il y a un dérèglement total entre le glutamate, qui est le neurotransmetteur excitateur par excellence, et le GABA, qui est le neurotransmetteur inhibiteur. Il y a un déséquilibre total avec des conséquences terribles. Il y aura œdème cérébral, hypertension intracrânienne. Il y a des conséquences systémiques terribles avec hyperthermie. Et tout cela, c'est un cycle. Ça va conduire à la mort neuronale, à une souffrance neuronale et même à la mort physique. Donc, l'état de mal épileptique, c'est une urgence parce que ça tue. Donc, les conséquences ici, il y a les conséquences neurologiques aiguës, systémiques, augmentation du métabolisme, hypoxie, souffrance neuronale, mort neuronale, avec les conséquences qu'il y a. Mais si rien n'est fait, le patient va, malheureusement, ce sera le décès. Et souvent, c'est ce qui arrive. Désolé si vous ne voyez pas bien. Alors, ici, c'est un tableau d'une étude qui révèle toutes les causes, qui montre toutes les causes que nous avons dans l'état de mal épileptique. Et quand même, une cause, les causes qu'on a très souvent, ce sont les AVC ou la mauvaise prise du traitement antiépileptique. C'est les 2 causes quand même les plus fréquentes qui ressortent beaucoup dans les études. Mais lorsqu'on s'intéresse un peu à l'Afrique subsaharienne et qu'on regroupe les études faites au Sénégal ou au Cameroun par nos maîtres, les AVC toujours viennent au premier plan. Mais puis en deuxième, ce sont les infections du système nerveux central. Et en troisième, les interruptions ou l'arrêt du traitement antiépileptique. Alors les manifestations cliniques, on doit savoir qu'il y a l'état de mal convulsif. il y a l'état de mal focal, des états de mal focaux. L'état de mal peut être non convulsif ou larvé, comme on l'a vu, mais on va vraiment plus, ce qui est le plus souvent présent. Alors, autant d'états de mal que d'épilepsie. L'état de mal convulsif. Les crises, très souvent, nous avons des crises généralisées. D'après les études, c'est plus des crises généralisées, mais on peut avoir une manifestation motrice après 30 minutes. Lorsqu'il n'y a plus de manifestation motrice, il faut voir, est-ce qu'on n'est pas dans un état de mal post-convulsif chez quelqu'un qui s'est totalement épuisé, et c'est l'intérêt de l'EEG. Il faut faire attention à l'état de mal psychogène ou factice. Très souvent, c'est chez la jeune femme, ce sont des crises très violentes, il n'y a pas d'ouverture des yeux, pas vraiment de perte de conscience. Elle est consciente, mais elle fait qu'enchaîner des crises et il n'y a pas de confusion post-critique. Donc, il faut faire attention à ce type d'état de mal-là. Psychogène, c'est il faut vraiment, c'est très, très délicat. Et l'EEG est presque toujours normal dans l'état de mal psychogène. L'appareil clinique dans l'état de mal, je vais vite avant d'arriver à la prise en charge. Il faudra l'électroencéphalogramme, c'est très important pour nous, surtout pour éliminer les états de mal qu'on vient de voir psychogènes ou voir les états de mal larvés. Le bilan étiologique est important, l'imagerie cérébrale, la ponction lombaire, toute la biologie, glycémie, l'ionogramme sanguin, une NFS, une CRP, même les fonctions rénales et hépatiques. Mais aucun bilan ne doit retarder la prise en charge. Ça, il faut le retenir. Le bilan se fait pendant la prise en charge, voire même après la prise en charge. Il n'y a aucune urgence à dire non, tant qu'on n'a pas tel examen, on ne prend pas en charge. Le plus important dans l'état de mal, vu que ça tue, c'est d'abord la prise en charge et on peut voir les bilans après, mais il faut arrêter les crises. C'est ça les messages qu'il faut retenir, c'est arrêter d'abord les crises avant toute prise en charge. Alors, concernant la prise en charge, justement, le but, c'est de préserver le pronostic vital, arrêter la crise et prévenir sa récidive, prévenir ou traiter les complications et traiter la cause. Parce que time is brain, parce que c'est une entité qui tue l'état de mal anti-épileptique, l'état de mal épileptique, pardon. Rapidement, quand ce patient arrive aux urgences, qu'est-ce qu'on fait? Position proclive, libération des voies aériennes. Euh, on met rapidement une voie veineuse. On essaie de contrôler si on peut tension artérielle, fréquence cardiaque, fréquence respiratoire. En fait, on prend tous les paramètres, mais il faut rapidement le mettre en position latérale de sécurité, rapidement libérer les voies respiratoires et une voie veineuse. Absolument. Et puis, par cette voie veineuse, on peut faire des prélèvements, mais on peut aussi mettre les médicaments. Alors, il faudra choisir un médicament. Il y a les médicaments de première ligne, de deuxième ligne, et on va voir qu'il y a l'état de mal réfractaire et c'est lui-même qui est très réfractaire. Alors, en s'appuyant sur des guidelines pour la prise en charge d'état de mal épileptique, ce tableau, ce n'est pas très facile à voir, mais ce qu'il faut retenir, c'est qu'en première ligne, ce que nous devons utiliser, c'est le... Okay. En première ligne sont les benzodiazépines et particulièrement, ce que nous avons le plus, c'est le diazépam. On peut commencer à 10 mg. On va revoir sur d'autres diapositives, mais c'est là au tableau. Et ça se répète une seule fois en première ligne. C'est le diazépam, 10 mg qu'on va faire passer en IVDL et ça se répète une seule fois. Si on a échoué sur la première ligne avec le diazépam, la deuxième ligne, c'est le phénobarbital. On peut aller à 15 mg kg en IVDL. On peut faire en 12 à 15 minutes et ça se répète maximum une fois également. Et si on a échoué à la deuxième ligne, c'est la troisième ligne. La troisième ligne sont les réanimateurs tels que le thiopin. Alors, je sais que cette diapo n'est pas très visible. On va aller sur une diapo plus explicite parce qu'on a des particularités dans nos pays. Et là, j'ai vraiment, sous la diapositive précédente, il y avait beaucoup de molécules, mais qui ne sont pas disponibles au Cameroun. Qu'est-ce que nous, on a avec nos moyens? Première ligne, diazépam injectable, 10 mg à passer en IVDL chez l'adulte, à répéter une seule fois. Très souvent, ce sont les malades qui sont déjà venus avec du diazépam qu'ils ont pris dans un centre de santé. Ce que nous, on conseille à ce moment-là, on peut tenter le clonazépam à 1 mg IVDL, mais une seule fois. Si le clonazépam, connu sous le nom de Rivotril, n'a pas marché dans cette première, on peut passer au phénobarbital injectable 10 à 15 mg kg IV chez l'adulte. On peut commencer à 600 mg. Parfois, on peut aller jusqu'à 1 g. C'est des lourdes doses qu'on met en 12-15 minutes. Et le relais, ensuite, c'est 200 mg par 24 heures en dose d'entretien dès le lendemain. Une fois que la crise s'est arrêtée. Si ça n'a pas marché, c'est là qu'il faut passer à la troisième ligne. Il faut appeler les réanimateurs. Alors, ce qu'il faut retenir donc, diazépam en première ligne, une ampoule, en 8 cc de sérum salé isotonique. Phénobarbital, si ça n'a pas marché, le diazépam ne marche pas. Nous, souvent, on tente directement le clonazépam. Si la première dose de diazépam n'a pas marché, au lieu de répéter une deuxième dose, on peut tenter le clonazépam, ça c'est des benzodiazépines, ou on peut directement aller avec le clonazépam en première ligne. Phénobarbital, c'est la deuxième ligne. On y va à 200 mg injectable, des ampoules de 200 mg. On peut commencer en dose de charge à 600 mg, voire 1 g en IVDL, et puis les doses de relais 200 mg en IV, des doses d'entretien. Si ça n'a pas marché, les deux lignes, mais très souvent, quand même, le phénobarbital marche très bien en IVDL. Si ça ne marche pas, il faut un transfert en soins intensifs avec des agents anesthésiques. Et lorsque ça a marché, il faudra introduire des antiépileptiques classiques. On peut introduire à partir de 48 heures après la rémission, on peut réintroduire des antiépileptiques classiques lorsque ça a marché après la rémission. Merci pour votre attention.
Thank you very much, Dr. Mbonda. We will keep your questions. We will take the second presenter. And the second talk is from Dr. Leonard Ngarka, who will talk on the challenges of acute stroke care in resource-limited settings like Cameroon. Dr. Ngarka is a consultant neurologist in the Central Hospital of Yaoundé, and he, like Mbonda, is a med assistant in this faculty in neurology, and looking forward to both of them becoming agrégés in neurology here in this faculty. So, Ngarka, you have 10 minutes for your presentation. His computer is probably having a seizure. Maybe Paul should give him an anti-epileptic drug. But the computer, yeah, diazepam is at least we followed.
Thank you very much, sir, for giving me the floor. I want to take this time to heartily appreciate the members of the organizing team for putting together for us to have this fruitful scientific exchange here on non-communicable disease. So without any much waste of time, we are going to be talking on managing strokes in resource-limited settings. So we have adopted the following outline for our presentation this morning. First of all, what is stroke? A stroke is a brain disease wherein there is rapid onset of neurological deficit. The symptoms could either be a face drop, arm weakness, speech, and all of these should be acted upon very fast because time is brain. Stroke can be divided to, we have three main types of stroke. We have ischemic, hemorrhagic stroke, and cerebral venous thrombosis. And under ischemic stroke, we could have transient ischemic attacks. And for hemorrhagic stroke, we have intracerebral bleed, subarachnoid hemorrhage. And like I said, the last one, we have cerebral venous thrombosis. Stroke, we can retain these for stroke, the number 1, 2, 3. Stroke is the first cause of acquired handicap in an adult. It's the second cause of dementia after Alzheimer's disease. And it is the third cause of death in the world. And most of these deaths do occur, 60% of them occur within 3 years after a stroke. Sometimes we may not see the patients die in the hospital, but they do die at home. And from the complications that we have from stroke, about 50% of them are due to direct brain lesions. Okay, concerning the incidence of stroke, we can see here that everywhere is red in Africa and Asia. So the incidence of stroke remains very high in Africa and East Asia, while the incidence, that's the number of new cases of stroke, is lower in developed countries. In Africa specifically, the burden of stroke is higher than we have in any other part of the world because a great percentage of mortality from stroke, we have it in sub-Saharan Africa. And talking about some of the risk factors for stroke, we have the Interstroke and the Siren study would bring out the main risk factors of stroke. We have hypertension and dyslipidemia, which are very high. And when we go further, we see that comparing this amongst different populations, we see that amongst indigenous Africans, these risk factors are higher in Africans, hypertension and dyslipidemia and diabetes, than we have in other populations. So it leads us to think that there are some risk factors, some population-based risk factors for stroke in Africa, which range from genetic risk factors. We have low birth weight, migration, like Professor Shukem already spoke about, population growth and increase in the number of old people. There are some of the factors that contribute to us having more and more cases of stroke in our population. In Cameroon, I would just like to say that stroke alone is responsible for about 6% of total deaths, and ischemic stroke and hemorrhagic stroke in Cameroon especially, the percent, it's about 50-50, unlike data we have in other parts of the world where 2/3 of stroke cases are ischemic and 1/3 is hemorrhagic. And the simple reason is because of the risk factors that we have. Abroad, smoking is very common, and so they have large vessel atherosclerosis. Meanwhile, in Africa, we have small vessel atherosclerosis. And that is why we have an almost equal number of ischemic cases as hemorrhagic cases. And coming to the cost of stroke, we see that to treat a stroke patient from when he's hospitalized to when he leaves the hospital, he spends an average of 800,000 francs CFA, and about 300,000, about a third of that goes for physiotherapy. And you can imagine in a country where the minimum wage is below 60,000 francs CFA. So it's actually something nobody is ever prepared for. So prevention is certainly better than cure. Another peculiarity in Cameroon is that most of our stroke cases are between the ages of 30 and less than 60 or early 60. So we see that the active population of our country are the ones who are disposed or who most of the time do come to our hospitals for stroke. And to say that we can see that even as young as 25, we have people with stroke. Not long ago, we received one of our colleagues, 28 years old, who has vascular risk factors and developed a stroke. So nobody is too young to have a stroke. And some of the complications of stroke that we have aspiration pneumonia. It goes from aspiration pneumonia to delirium, depression, and what have you. These are the most common complications of stroke, which explain death in most of our cases. One or two words about the pathophysiology. I think I'll just keep this very quickly. What happens in stroke is that when someone has a stroke, we have the center, the core, where we have a hypoperfusion. There is cell death around that part. But because as time goes on, we have some cells around that core which still remain viable because they are supplied by collateral circulation. So the purpose of management is to restrain or to bring to the minimum the extension of this core zone, because if we do that, we can minimize the complications that come from stroke. Because if nothing is done, over time, you can see it will continue growing. We have nothing, it grows until it becomes really huge like we have there. So what are the factors, therefore, that can aggravate these? We have hypertension in acute stroke, we have hyperglycemia, epileptic crisis, or raised intracranial pressure. So therefore, in managing strokes, we must do everything possible to minimize these factors that can increase or can lead to the extension of the core to the penumbra area, which we have hypoxia, hypoglycemia, hyperthermia, volemia, hypercapnia, and electrolyte imbalances. Therefore, for our management, we have the following objectives: to maintain vital parameters, treat the cause, restore neurological functions, prevent complications, prevent reoccurrence, and psychotherapy. And in the management of stroke, there are three main axes. We have pre-hospital, hospital, and post-hospital, because we saw already that 60% of our cases die after they leave the hospital. So much has to be done when they leave the hospital. And what are the things that needs to be done before the patient comes to the hospital is that we need to double sensitization. Thank God we are doing this here to sensitize our population. Okay, and the information we are getting from here needs to go to our communities. The ambulance services needs to be aware. The guard in the hospital needs to be aware. The general population needs to be. I'll give an example. On my way here this morning, the ambulance guy was horning and nobody was willing to give way to that person. So imagine somebody was there heading to be thrombolized, he will waste more time. And we have, okay, so in the management, we have general measures. That's for hospital management. These general measures contribute significantly in reducing mortality compared to specific treatments like thrombolysis. So even without thrombolysis, it is possible that we can preserve the lives of our patients. We can reduce the complications of stroke if our patients with this condition are given these general measures. And they cost very little. We have just providing them nursing services, mobilizing them every 2 hours, giving them a nasogastric tube if the patient has abolished gag reflexes. We can put measures of reanimation, prevent complications of decubitudes, screen for depression, and follow-up parameters. So for the specific treatments, we have thrombolysis, which we have available, which is not available here. But I would like to say that it's not available here, but it has been done here. We have the first case of thrombolysis, which we published a few years ago. And since then, a few of them have been done. And to say that even though we don't have all the plateau technique available, but something can be done even with very limited resources. Okay, very quickly. So in the management, apart from thrombolysis, we have thrombectomies, we have antithrombotics after the patient has been thrombolized, or if the patient hasn't been thrombolized, we have antithrombotics that can be given. We have aspirin that can be given at a dose of 75 to 325 milligrams a day, or we can give double antiplatelet aggregate in cases of minor strokes or transient ischemic attacks. These patients can also be put on lipid-lowering medications because they are also already at high risk of, they have high risk of other vascular events. So this, as treatment also, they can give an anticoagulant. The purpose of anticoagulants for them is to prevent the complications of decubitudes. You give it at prophylactic doses. But it's possible that in patients with stroke, they are given these anticoagulants at therapeutic doses. And what are those conditions in cases where we have ischemic strokes of cardioembolic causes, or someone who has repeated ischemic strokes without any obvious etiology? They could be considered for curative anticoagulation. So coming to hypertension, usually there is a mistake, or there's something which people say. I'll say it in French. On dit souvent que on a une urgence hypertensive absolue à type de l'AVC. I think it's not the right thing, because hypertension or lowering blood pressure is not an emergency in ischemic strokes. It is only an emergency in hemorrhagic stroke. The only cases in which blood pressure can be lowered in ischemic stroke is when we have either acute heart failure, we have dissection, or post-thrombolysis hemorrhage. And in this case, you can reduce 15% of the blood pressure within the first 24 hours. And the other case where blood pressure can be brought down is when we have the blood pressure is above 220 on 20 millimeters of mercury. And we follow the same protocol. So sorry for this bad slide. This is what we have. So these patients, sometimes they come with raised intracranial pressure. We manage that with mannitol 30% at 150 cc's every 6 hours. We give that in 30 minutes. Or the most common one which we have are derivatives of glycerol, like glycerotone, which we give 1 teaspoon or 1 eating spoon 3 times a day. In some cases, or sometimes we might give them, they might benefit from surgical treatment in some cases of raised intracranial pressure when we have complete middle cerebral artery infarct. So coming to hemorrhagic stroke, of course, general measures are capital. And in hemorrhagic stroke, blood pressure is an emergency. So we must and should bring down the blood pressure to about 140 on 190 within the first 24 hours in order to reduce complications from this. Sometimes we can also have surgical treatments, and the indication for surgical treatment we have it when the hemorrhage is less than 1 centimeter from the surface, and there is a deterioration of the patient's consciousness between less than 9, between 9 and 12. We are sure that if you can give the person some surgical treatment in order to improve outcomes. Okay, very quickly. Apart from that, glycemia, we already saw that raised blood glucose is a risk factor. It can extend the penumbra areas. So each time we have glycemia more than 180 milligrams per deciliters, they can be brought down using insulin to keep it less than this in order to preserve brain functions. And if the patient has hypoglycemia, he needs to be treated as soon as possible. There is no need to give antibiotics prophylaxis in a patient with stroke. But however, if he has a fever, it's important that we look for the cause and we treat the cause of the fever. So this is for hematoma. For intraventricular bleeds, we rehydrate the patient, we give antihypertensives. Nimodipine is not indicated in intraventricular bleed, except it is due to subarachnoid hemorrhage. Okay, so I'll go very quickly. So a part of the treatment, after you've done all your medical treatment, something which is very important, which we must integrate, is re-education. Re-education is very important because it helps this patient to recover the deficits. Remember that as part of our objectives was to restore the neurological function. So physiotherapy will help us a lot in that. And what about neuroprotectors? In some centers, you see people prescribe drugs like somazina, citicoline, and nootropill. These medications have no use in patients with stroke. Instead of spending huge amounts of money on these, they can rather use that money to do physiotherapy or to get other things which will be helpful in recovery. So what are some of the do's and don'ts? We say that these patients need constant skin examination. We need to do a swallow test, early mobilization, counseling, and monitoring vital signs. And what are the don'ts in strokes? Don't give them antibiotics prophylaxis. Don't keep indwelling catheters because they are routes for infections. Don't keep them in a lying position for long. They don't need prophylactic antiepileptics or antidepressants because it's not been shown to be useful in all patients with stroke. They need to be screened before they are put on antidepressants. So what can we say in post-hospital management of stroke is that education of this patient is important. When they leave the hospital, they need to be educated. And they will need to continue their re-education back home. You have to follow up this, inform the patient about signs of severity, follow up the functional prognosis of this patient, ensure that the patient is taking his medication as you have prescribed. Remember, we said that 60% of these patients die after they leave the hospital. So there is a lot that has to be done before they leave the hospital. And it is this education that will help them comply to treatment, know the warning signs in order to increase survival. So what are some of the elements of poor prognosis? We have symptoms which have install themselves rapidly, and altered consciousness, convulsions, raised intracranial pressure, and patients with swallowing difficulties have poor prognosis because they have risk of infections, which worsen this. So what can we get home from here is that stroke is an emergency. It needs to be diagnosed and treated as soon as possible. The complications are numerous. General measures are very important in managing these patients, and therefore primary prevention of risk factors, it will play a key role in its onset and even its reoccurrence. So we can end here by saying that there is an urgent need for all of us to work fast in order to prevent FAST. FAST is facial droop, arm weakness, and speech loss. And why do we need to do so? It's because stroke is not a joke. I hope you don't have a stroke. Thank you.
Thank you, Dr. Ngarka, for convincing us that stroke is not a joke. And we need to take care of NCD risk factors so that we don't have brain attacks. Just like we talk of heart attacks, is the same thing, brain attack. 30 years ago, I was second neurologist in this country for 15 million people. But today, we have about 35 neurologists for 30 million people. And just this morning, we had 11 residents who passed their exam to come into specialization. We say congratulations. And I practice general neurology because I couldn't specialize. I mean, you can have 7.5 million patients and you want to subspecialize. But today we can afford to have My former students specialize and subspecialize in epilepsy, in stroke, and we're going to have an interesting story of a specialty, subspecialty in neurology, which is neuroimmunology. And Dr. Chokote Samuel Eric is a consultant neurologist working at the Jamor Hospital, and is going to talk to us on the emergence of immune diseases of the nervous system in sub-Saharan Africa, and I'm thinking he's going to share some examples from Cameroon. Eric, you have 7 minutes since your brother took more than 20.
Thank you, dear Master, for this opportunity to share in 7 minutes on this very interesting topic. Et I would switch to French. Je vais remercier les organisateurs pour nous donner l'opportunité de parler d'un sujet dont on ne parle pas souvent, parce qu'il existe comme une sorte de mythe qui veut que les pathologies dysimmunitaires ou auto-immunes soient l'apanage des pays nordiques, des pays caucasiens. Et nous voulons nous montrer que dans cette période de transition épidémiologique, en tant que médecin généraliste, en tant que neurologue, en tant qu'interniste, en tant que réanimateur, en tant qu'urgentiste, nous devons être préparés à faire face aux pathologies dysimmunitaires du système nerveux, que ce soit central ou périphérique, parce que ce n'est pas aussi rare que ça en a l'air. Et pour nous en convaincre, on va commencer par un cas clinique et suivre le plan ci-après. Donc, je nous demande très rapidement de suivre ce cas clinique parce qu'à la fin, nous allons voter pour le diagnostic de ce que vous pensez. Donc, c'est une patiente que nous avons reçue au service de neurologie cette année, janvier 2024, comme vous le voyez, patiente de 57 ans, qui est veuve, qui est conçue en janvier 2024, bien admise pour 2 épisodes de crise qui sont décrites comme tonico-clonique généralisée. On a parlé d'état de mal tout à l'heure, mais son histoire était un peu plus subaiguë parce qu'en août 2023, sa famille commence à décrire des troubles de la mémoire épisodique antérograde d'installation assez rapidement progressifs, avec quand même un gros impact sur son autonomie. Et en novembre 2023, s'ajoute à cela des céphalées, des vomissements en jet et une altération progressive de l'état de conscience dans le contexte d'un fébricule à 38 pour lequel elle va être hospitalisée donc, au service des urgences, une formation sanitaire. Sans trop entrer dans les détails, on va lui faire un scanner cérébral qui va juste montrer un œdème cérébral diffus, pas de lésion focale, une analyse du LCR qui est strictement normale, une numération, un bilan biologique qui est quasiment normal, sérologie VIH qui est négatif. Donc, elle est prise en charge initialement pour une méningite avec une encéphalite, on va dire, avec de la ceftriaxone à dose méningée. Et dès qu'on a eu les résultats du LCR qui infirmait l'encéphalite, on a continué, elle a continué, pas nous, elle a continué avec les antibiotiques à dose systémique pendant 10 jours, avec légère amélioration de son état de conscience et elle va sortir de l'hôpital. Mais la pathologie évolue parce qu'en décembre 2023, elle a un déficit assez rapidement progressif de l'hémicorps droit et 2 épisodes de crise qui sont décrits, comme on le disait tout à l'heure, comme tonico-clonique généralisée, cette fois-ci en contexte affébrile. Avant, cela n'avait pas d'antécédent contributif. Et en janvier 2024, lorsqu'elle est admise, l'examen fait état donc d'une altération d'état de conscience avec un Glasgow à 13 sur 15, qui fait en sorte qu'à ce moment, nous ne pouvons pas évaluer les fonctions cognitives. Elle n'a pas de signe d'irritation méningée, elle n'a pas de paralysie des nerfs crâniens, elle a un syndrome pyramidal droit de type capsulaire avec une force musculaire A, une hémiparésie avec une force musculaire à 4 sur 5. Et voilà donc son IRM, puisqu'elle avait déjà fait un scanner, son IRM qui montre, excusez la qualité des images, vous pouvez voir, voilà, là, sur ça, ce sont des séquences flaires, des hypersignaux sous-cortico-périventriculaires vraiment étendus, allant jusqu'à la région temporale, qu'elle soit antérieure ou également au niveau de la région insulaire. On va faire une deuxième ponction lombaire qui sera normale, sérologie syphilitique négative, hépatite B, hépatite C négative, une TSH ultrasensible qui est négative. Donc, on se pose certainement la question, qu'est-ce que cette patiente a? Et donc, nous allons faire un petit vote rapidement. Qui vote pour méningite ou encéphalite virale? Personne. Méningite bactérienne, décapitée peut-être? Personne. Encéphalite tuberculeuse? C'est quand même assez fréquent chez nous. Personne. Waouh. Maladie d'Alzheimer. Et donc, encéphalite auto-immune. Voilà. Une personne qui vote. Les autres ne savent pas. Encore. Voilà. OK. Donc, effectivement, nous avons retenu le diagnostic d'encéphalite auto-immune. Elle a été mise sur un traitement immunitaire, tel que vous voyez là, qui malheureusement n'a pas pu être conduit jusqu'à la fin pour des raisons propres à la famille. Elle est sortie contre avis médical et 1 mois après sa sortie, elle est décédée. Donc, que devons-nous retenir de ce cas? C'est que c'est effectivement un mythe de penser que les encéphalites auto-immunes sont rares. Ça existe dans notre contexte et en l'absence de traitement approprié, ce sont des pathologies qui sont mortelles. Donc, cette diapo, c'était pour nous montrer que les pathologies dissimmunitaires du système nerveux concernent tous les étages, mais le domaine dans lequel il y a eu beaucoup plus de révolutions ces 20 dernières années, c'est l'encéphalopathie auto-immune. C'est-à-dire c'est une nouvelle entité qu'il est important pour nous de prendre en compte et de connaître parce que nous allons certainement les rencontrer. Véritable révolution depuis 2007 que la première entité a été décrite, qui a été appelée l'encéphalite NMDA, mais aujourd'hui, on peut grossièrement diviser les encéphalites auto-immunes en 3, les encéphalites systémiques, non systémiques et post-infectieuses. Et c'est une véritable révolution aussi parce que depuis 2007, donc, il y a un véritable changement dans l'épidémiologie des encéphalites. Aujourd'hui, on estime que 40 à 50% des encéphalites sont infectieuses, 20 à 30% peuvent être auto-immunes. Donc, un patient sur 3 que nous voyons d'encéphalite peuvent avoir une encéphalite non infectieuse qui est auto-immune. Dans les pays développés, ils sont à 50-50. Et on se dit qu'avec la découverte des auto-anticorps, cette prévalence va certainement basculer en faveur des encéphalites non infectieuses. Et depuis 2006, vous pouvez voir que l'incidence, entre 2006 et 2015, l'incidence des encéphalites infectieuses est restée stable, tandis que l'incidence des encéphalites auto-immunes va grandissant. Et ce sont des pathologies mortelles. Dans certaines séries, même avec un traitement, on a une mortalité de pratiquement 41%, un risque de rechute qui peut aller jusqu'à 62%, un risque de séquelles cognitives et psychiatriques graves. Et cette mortalité et morbidité sont liées à un retard diagnostique et un retard thérapeutique, raison pour laquelle il est important pour nous de savoir au moins dans quel contexte est-ce que je dois évoquer, nous pouvons évoquer l'encéphalite auto-immune. Et donc, il existe, voilà, donc pour dire qu'en Afrique, pas beaucoup de données. Pour l'instant, on a quand même quelques cas cliniques qui sont décrits en Afrique du Sud, au Soudan, au Togo, au Kenya. Pourtant, cette possibilité donc, dans l'épidémiologie des encéphalites auto-immunes contraste avec la prévalence très élevée d'encéphalite cryptogénique, c'est-à-dire des cas d'encéphalite dans lesquels nous n'avons pas de diagnostic étiologique, qui peuvent aller jusqu'à 63%. Et on a donc cette série de cas avec plusieurs auteurs camerounais que vous pouvez retrouver dans la liste qui est en cours de publication pour nous montrer que même dans notre contexte, cela existe. Donc, il existe depuis 2016 des critères diagnostiques qui doivent nous permettre d'évoquer, de se dire qu'on est peut-être en face d'une encéphalite non infectieuse, mais plutôt une encéphalite auto-immune. Premier critère diagnostique, c'est la survenue subaiguë de troubles de la mémoire, c'est-à-dire moins de 3 mois, troubles, altération d'état de conscience ou de troubles psychiatriques, avec la survenue d'au moins un des 4 signes suivants, un déficit neurologique focal, des crises convulsives, qu'elles soient focales ou généralisées sur un patient qui n'était pas connu épileptique, une pléocytose avec une cytorachie supérieure à 5 par millimètre cube et des lésions IRM particulières que nous allons vous montrer. Tout ceci, bien entendu, ayant exclu les causes infectieuses, métaboliques, toxiques. Donc, dans quel cas, on a déjà dit, dans quel cas clinique, et on va céder donc des lésions IRM, juste pour mentionner ici que des hypersignaux bi-hippocampiques sont considérés, après avoir exclu l'encéphalite herpétique, comme pathognomonique d'une encéphalite auto-immune. L'analyse du LCR peut nous montrer donc une pléocytose, des bandes oligoclonales, mais la particularité, c'est que l'IRM et le LCR peuvent être tous les deux normaux. Cela n'exclut en rien le diagnostic d'encéphalite auto-immune et on peut avoir des patterns spécifiques à l'EEG pour certaines sous-entités. Lorsqu'on a suspecté et qu'on a des éléments paracliniques qui nous confortent, il convient de pouvoir confirmer le diagnostic avec le dosage de certains auto-anticorps, soit dans le sang, soit dans le LCR ou les deux. On a des auto-anticorps qui sont synaptiques, d'autres qui sont intracellulaires. Juste pour mentionner que celles qui sont synaptiques sont le plus souvent auto-immunes idiopathiques, tandis que celles qui sont intracellulaires sont le plus souvent paranéoplasiques. Et c'est là où le bas blesse parce que pour réaliser ce panel que je viens de vous montrer, comme cela se fait dans certains grands centres de neuroimmunologie, il faut au moins 2 millions de francs CFA. Vous imaginez que ce n'est pas évident. Donc, ce qui veut dire qu'à l'heure où nous pensons que l'incidence va augmenter en Afrique subsaharienne, où nos revenus sont faibles, nous devons avoir d'autres alternatives, d'autres circonstances qui nous permettent d'évoquer et de pouvoir commencer donc nous devons tropicaliser les protocoles diagnostiques et thérapeutiques. Donc, le traitement, en première ligne, ce sont les corticothérapies, les immunoglobulines intraveineuses, la plasmaphéreuse que nous n'avons pas, et en traitement de deuxième intention, le rituximab, qui est disponible au Cameroun, pas que cher, le cyclophosphamide, qui est disponible à un coût quand même assez abordable. quoi qu'il faille faire attention avec les effets secondaires. À quel moment donc commencer un traitement immunomodulateur devant une encéphalite lorsqu'on a donc les critères cliniques que nous avons montés, cliniques et paracliniques, lorsqu'on a des lésions IRM d'encéphalite bilimbique avec après exclusion d'une encéphalite herpétique, c'est suffisant, même à l'absence d'auto-anticorps, de pouvoir commencer un traitement immunitaire, bien sûr, lorsqu'on a exclu les causes infectieuses dans la mesure dans la mesure du possible, traitement de soutien. Donc, en conclusion, qu'est-ce qu'il faut retenir? C'est que l'incidence des pathologies dissimmunitaires augmente dans le monde entier et très probablement en Afrique, et particulièrement l'encéphalite auto-immune, même si nous n'avons pas beaucoup de données en Afrique, ce qui veut dire que nous avons beaucoup de travail qui nous attend, que c'est une pathologie qui est traitable lorsque le diagnostic, il faut penser au diagnostic, il faut l'évoquer et il faut le traiter même en absence d'une confirmation diagnostique, mais lorsque les critères sont bien établis, et cela concerne, c'est une prise en charge multidisciplinaire. Donc, si nous pouvons retenir, et je vais le dire en anglais, encephalitis is not always a matter of infection, alors nous aurons gagné quelque chose de cette présentation. Je vous remercie.
We thank Dr. Eric Chokote for that presentation. And I think we have how many minutes for questions? Just 1 minute. Okay. I see 2 hands. If you can ask. Okay. 2 hands at the back, then 2 in front. Yes. The ladies, if they can have the mics. Indicate to whom your question is, and you ask your question in 5 seconds. Please.
Thank you, Doctor, for the presentation. Please, I would like to ask, I've never understood why we don't have to reduce blood pressure in ischemic strokes.
Very good. We'll take all the questions. That question goes to Dr. Ngarka.
Merci, cher maître, de me passer la parole. Je suis docteur Capi, résidente en 2e année médecine interne. Ma question va au docteur Eric Chokote. S'il vous plaît, cher maître, je voudrais savoir, est-ce qu'il y a une explication sur la distribution bilimbique des hypersignaux dans l'encéphalite herpétique et auto-immune? Merci.
Exceptionally, one question. Yes.
Merci, je vous remercie. Je remercie au cher maître.
La question, s'il vous plaît.
Oui,
Juste
la
tout le point.
question, je voudrais demander, est-ce que comment l'obésité endommage la sécrétion de l'insuline? Et j'ai juste 2 questions, si vous me permettez.
Non, une seule. Merci. Vous avez suivi. Je ne sais pas à qui c'est adressé, mais le panel est là. Okay. Bring the mic here for the faculty members, please, for comments.
I have a question for Dr. Chokote. Why was your patient not considered to have multiple sclerosis?
Give the mic to Prof. Njoya, please.
Thank you, Mr. Chair. J'avais beaucoup de questions, mais là, je me rends compte qu'il y a très peu de temps, pas que Théo se fâche,
Oui.
et puis d'autres questions ont été posées. Alors, la question, là, je vais résumer en une seule question, 2 questions. Permettez
Oui.
2 questions.
Oui.
Docteur Mbonda, vous avez donné un protocole de prise en charge quand il y a échec, passe de l'un à l'autre. Alors, comme nous savons que les médicaments sont essentiellement agissant sur les centres respiratoires, est-ce que ce n'est pas cumulatif? Et s'il n'y a pas un risque? La question va à Lionel Gaka, qui est en gastroentérologie. La peur des AVC, c'est la perte de réflexe de déglutition, comme c'est qu'elle est. Alors, what do we do when there is like something like what do we do for that? And then how long can it take to have a resorption of that?
Thank you very much for those questions. I think I just start from my left.
Merci, cher maître, pour votre question. Alors, effectivement, il y a un très gros risque de détresse respiratoire. Et c'est pour ça que dès que ces patients-là arrivent aux urgences, La première question qu'on pose déjà, même quand ils sont en train de convulser, c'est est-ce que vous n'êtes pas passé dans un centre de santé déjà? Est-ce qu'il n'a pas reçu du diazépam dans ce centre-là? Combien de fois? Bon, la famille ne peut pas toujours savoir, mais une fois qu'on sait, qu'on est sûr qu'il a reçu, ou même qu'il est passé par un centre, on sait que répéter la deuxième dose de diazépam n'est pas nécessaire. Souvent, on préfère passer directement au clonazépam. Et si ça n'a pas du tout marché, on est obligé quand même, d'après les recommandations, d'aller au phénobarbital avec le risque qu'il y a. Et si effectivement il n'a pas marché, autant aller à la troisième ligne, appeler les réanimateurs. Mais c'est vrai que vous attirez l'attention sur ce fait-là. Il ne faut pas répéter les doses parce que c'est un problème qu'on a souvent aux urgences. On répète beaucoup, c'est maximum une fois en s'assurant qu'il n'a pas déjà pris ça quelque part, une benzodiazépine. Parce que sinon, effectivement, il y a parfois des détresses respiratoires ou parfois on a ce qu'on appelle vraiment l'état de mal larvé où il ne fait plus de crise clinique, mais il est en train de faire des crises sous le plan électrique. Et c'est tout un autre problème parce que ça a des séquelles énormes. Bon, merci encore d'avoir attiré l'attention dessus, cher maître.
Just one little addition that with clonazepam is short acting and the effect might not be that cumulative if we manage to have it.
Merci, cher maître. Donc, deux questions nous ont été posées. Pourquoi la distribution bilimbique dans l'encéphalite herpétique et auto-immune? C'est une question de similitude antigénique. On a vu tout à l'heure que l'encéphalite auto-immune, c'est plusieurs antigènes. C'est des auto-anticorps contre plusieurs antigènes qui ont des distributions assez particulières dans le système nerveux central, particulièrement le NMDA, qui est un sous-récepteur des récepteurs glutamate et très bien distribué au niveau de la région bi-hippocampique. Et on voit cette similitude avec certains antigènes du virus de HSV1, donc qui fait qu'il y a un tropisme à ce niveau. Et c'est même pour cela que l'encéphalite à NMDA peut compliquer une encéphalite herpétique. Donc, la deuxième question, pourquoi est-ce que la patiente, le cas que nous avons décrit, n'avait pas une sclérose en plaques? Une très belle question. Cliniquement, on aurait pu évoquer, on va dire déjà, le délai était très rapide, 3-4 mois. On aurait pu évoquer une sclérose en plaques rémitante récidivante, mais c'est trop rapide. Une forme progressive primaire n'est pas typique. Mais ce qui était très contre c'est l'aspect IRM. Parce que dans les critères diagnostiques de la sclérose en plaques, c'est l'IRM, ce sont des lésions périventriculaires de petite taille qui ont une topographie périventriculaire juxtacorticale, sous-corticale ou médulaire, alors que là, nous voyons bien que c'était des hypersignaux qui sont non confluentes. Alors qu'on a vraiment des hypersignaux en plage qui sont diffuses, qui ne sont pas du tout en faveur de la sclérose en plaques. Donc, c'est surtout l'IRM ici qui ne nous permettait pas d'évoquer le diagnostic.
Another addition is that Professor Gachu's question is very important. In textbooks many years ago, they used to say that there's no multiple sclerosis in Africa. That is not true. As we're training more neurologists and they're diagnosing, we're having more and more multiple sclerosis. It's true that it is not like epilepsy or stroke, but we're having, so raising that is very important so that we keep that in mind. Leo, to answer your own questions.
Thank you. I had two questions. The first was, why is it not, why should the blood pressure not be brought down in ischemic stroke? I think it comes from the little explanation I gave that in ischemic stroke, we have the core where there is limited blood supply and there is death of cells there. And the area around the penumbra zone, the cells are suffering, but they are still alive because they still receive blood from collateral vessels. So the raised blood pressure enables blood supply to that penumbra zone and keeps the cells alive. So any attempt to reduce the blood pressure will reduce blood supply to that penumbra zone and will extend the core and will worsen the neurological deficit the patient has. So the outcomes won't be good. So that is why blood pressure is maintained up to 220 on 120 in ischemic stroke. Beyond that, it is deleterious. That's why we need to bring the reduce about 15% of the blood pressure. And the question our master, Professor Njoya, asks is concerning swallowing difficulties. What time does it occur? It happens, it's part of the symptoms of, yes, it usually takes about 2 weeks, but in some cases, it's almost permanent. And so we have to discuss the possibility of putting them gastrostomy, which is sometimes quite challenging here with the infectious context. So it's Oh, okay. Yeah, I'm sure that's the best option. But unfortunately, usually we have difficulties with yeah, with infections. That's the challenge we have with that.
Okay. I think the panel here is concerting to say that the question that was asked on the keynote cannot be taken because keynotes don't have any questions. Apparently, that question was for the keynote. So I think that with the organizing, yes, we have to thank you all for your excellent questions and contributions and thank the panel here. And as such, I would thank the organizers and hand over the floor to them for the next item. Thank you very much for clap for yourselves.
I would like all of you to remain seated because one of our key events is just about to start. We have been informed that the British High Commissioner is in the building and he has a very important role or a very important activity to carry out today. So please remain seated and we will try and bring him into the hall shortly. Thank you. Can we get some interlude music, please? Yes, ladies and gentlemen, can we stand up to welcome the British High Commissioner, please? While he's coming down the stairs, I would like to seize this opportunity to, I'm sure he will give you an idea, but the Royal College of Physicians is one of the oldest colleges in the United Kingdom, and medical training in the United Kingdom is organized in a way that general medical training is done by the universities and postgraduate training by the Royal College of Physicians. Mr. Wood, it gives me great pleasure to welcome you to the CamDoc seminar. I'm Professor Ngachu, International Advisor to the Royal College of Physicians. Welcome to the seminar. Please take a seat. I believe you want to say a few words.
Yes, thank you very much, Doctor. Wow, bonjour, bonjour à tout le monde. Je croyais pour un moment que j'allais devoir intervenir sur les non-communicable disease emergencies in low-income regions, mais heureusement, je ne suis pas là pour ça. Alors, j'espère que ça c'était intéressant ces 2 derniers jours pour vous. Yes, I don't know really which language to speak in, so really, okay, je vais faire un mélange des deux. Alors, First of all, thank you very much for welcoming me here to this seminar. Thank you very much. I'm not going to speak for very long, but there were a few things I just wanted to say. So my name is Matt Woods. I'm the British High Commissioner here in Cameroon. Ça fait un mois seulement que je suis là. Alors, je découvre, c'est la première fois que je suis à l'université. C'est pour ça qu'on était un peu en retard, car on a fait un peu le tour de tous les bâtiments de l'université. C'est un espace très impressionnant. Mais bon, I just wanted to say a few things about, as the doctor was saying, about the Royal College of Physicians. I think I'm probably not the best person to talk about the Royal College of Physicians, given we have such expertise in the room. But I wanted to say three things which struck me about it when I was looking into it before I came here. And the first, as Professor was just saying, is the historic nature of the institution. C'était établi en fait en 1518 par le roi Henri VIII, ça aurait devrait être, oui, Henri VIII, très bien, by a royal decree. So it's really one of the oldest and most established institutions in the UK or in medicine, certainly. So it's very historic. The second point which struck me is that it's very expert. And I hope you have been able to en profiter de cette expertise au cours de ce séminaire. J'ai vu un peu les titres des séances qui m'ont rien dit à moi, mais il me paraissait très intéressant et c'est une excellente idée de partager cette expertise avec vous tous et d'en discuter. And the third thing which struck me about the Royal College of Physicians is how global it is and how much it works pour la santé du monde en tant que partage d'expertise, d'expérience et d'idées et d'échanges. Et c'est bien pour ça que je salue et je félicite tous ceux qui ont organisé cette conférence. De mon point de vue en tant que haut commissaire, je pense que les relations bilatérales, en fait, il ne s'agit pas seulement, il ne s'agit pas surtout il ne s'agit pas que des relations entre les gouvernements, sinon, et beaucoup plus important que cela, ce sont des relations entre les personnes, entre les peuples, les échanges. C'est ça qui nourrit et qui enrichit les relations bilatérales entre deux pays. Alors, ça m'a vraiment fait beaucoup de plaisir de voir des initiatives telles comme ceci pour nous rapprocher le Cameroun et le Royaume-Uni. So, thank you once again. So, I think I'm now going to present or to say welcome to some new members of the Royal College of Physicians, or some members of the Royal College of Physicians. We have 6 among fellows. Fellows, very good. We have 6 here, si j'ai bien compris, et encore 10 au Royaume-Uni, n'est-ce pas? How should we do this? Shall I call their names or comment est-ce qu'on fait? Yeah. Yes, very good. So, okay. So we have, I don't know who is who exactly, so perhaps we can have them all on stage. We have Professor, oui, j'ai les noms là. Professor Jean-Claude Mbagna, okay. On va quand même les applaudir. Il faut applaudir les absents également, c'est vrai. Professor Martin Luma, okay. Vous-même, Professor Theodore Ngachu. We have Professor Alfred Njamshi. We have Professor Eugene Songui. We have Professor Simeon Pierre Choukem. And another 10 or another 12, in fact, who are not here with us today, but I just wanted to kind of congratulate you all for becoming fellows of this wonderful institution, and how very grateful I am for all that you do, not only in medicine, but also to bring our countries together. So thank you very much.
His, Ex His Excellency, and like His Excellency said, the Royal College is very much involved in education of doctors and particularly of physicians around the world. And I did not want to disclose this at the start, but as you can see, we have present today 3 eminent fellows of the college, and we have some more eminent fellows who are not present today. I don't know if you people could actually have identified that, but when they were giving their presentations, I could feel the caliber, the quality of their presentation. That caliber and quality is the essence of the Royal College of Physicians. You can the Royal College of by going through the examination route, so you become a member, and if you demonstrate good quality of clinical excellence, you are elected, become a fellow. You can also become a fellow of the college if you demonstrate excellent quality of practice, even without taking the exam. The college has got a panel of advisors like myself who will scout the world over to identify those clinicians who demonstrate excellence in medicine. We will nominate them, and they will go through a panel, and if the panel approve their nomination, they will be granted fellows of the college. If you are not a fellow of the college, you cannot have the title FRCP. So the FRCP, its name is an indication of clinical excellence. So all those fellows you find here can proudly put FRCP at the end of their name. The 500-year history of the Royal College of Physicians and still maintaining that level of respect means when you attach FRCP to your name, anywhere in the world, you are giving that respect. Another advantage of being a fellow of the college is that only fellows of the college can vote for the president of the college. A further advantage of being a fellow of the college, and what you people might not know, and I hope my colleagues here, fellows, will make use of it, is that own hotel in central London, and only fellow college can stay in that hotel. So now they know. When they come to London, please ring the college and inform the college that you will be in on so and so dates, and they can reserve a room for you. Thank you.
Your Excellency and colleagues, permit me in this historic moment to give you 1 second of history. The first director of this school, the Yaoundé School of Medicine, Professor Gottlieb Lobe Koso, was, I think, the first fellow of the Royal College of Physicians. That's how far the history goes. Yes, Gottlieb Lobe Monikoso, fellow of the Royal College of Physicians. Just wanted to indicate that history.
Very much, Professor Njamshi, for that history.
Great.
And thank you very much once more, Mr. Wood, and happy to have you with us.
Thanks a lot. OK. Merci beaucoup. Bonne continuation à tous.
I, I think we can all have a deserved break. Oh, sorry. Oh, sorry. Excuse me, Excellency. His Excellency, don't move. So, sorry, I apologize because I am informed that the Dean of the Faculty of Medicine is actually here by the Vice Dean. Apologies. Can you come up stage, please? We would like to get a word.
Good morning, everyone. Thank you. I apologize for my coming late. Thank you very much for these opportunities to exchange about this CamDocUK. Thank you, sir, for coming and support these in these faculties. Yes, I hope people are. I hope people are learning. I see some students and residents. Ah, that's good. Yes. Thank you very much.
Yes, like I apologize for that lapsus. We can easily take our break and stretch our legs. Okay. Is there anybody who wants to take us a family photo? Okay, while we're here. Do you think we'll all fit in this place or should we go outside? Prof. Njoya, can I ask your respectable person to join us on stage, please? Yes. I would like to seize this opportunity to also present Professor Njoya, who is the medical director of the University Hospital, Yaoundé. And I'm being told he's an honorary vice dean. I will apologize for not knowing all of those responsibilities because these are all people I consider personal friends and I know them on personal basis, not on title. So apologies, Prof. Can you guys join us down here?
Oh, we thinking that our is was here to get the parking that.
No, it's absolutely. You might end up parking way, way back, very back at the hospital. Yeah. And you've got about a mile to walk to get back to the main outpatient to get ready.
Hello. Hello.
Well, get my number off. Thank you very much. Yes.
Good morning, everyone. Please, we are on break and there's breakfast being served down where we had breakfast tomorrow. So let's go down there. We have timely and we are back in time for the next session.
And check. Ah, in 35 minutes. That's time. Just come here and then look. Sometimes if you have
Come and deep on this one again. You see the jokes on you, keep thinking tomorrow. Don't want for party now. You see the jokes on you, all the bad bitches welcome, they want to fuck me now. You see another man shit, it's another man go. Now want me to choose my own. The joke's on you in the pool party, baby girl, they want blessing now. Thank God it's Friday. We just want to party. We no hurt nobody. So don't kill my, don't mess my vibe. Thank God it's Friday. We just want to party. We don't nobody. So don't kill my, don't mess my vibe. So many girls in my camp for me. Me gorilla me a job out there. Solidar, solidar. My baby girl, my lady girl. So many boys wanna come to me. Them say, baby, why need money? Soledad, soledad. My baby boy, my baby boy. Baby boy. Come give me the vibe. That's vibe. I wanna wine bandit in. Come closer. I wanna give you the vibe. That vibe. Make you match bandit in. Sexy figure eight girl. Sexy thing a ling a ling. Say I go make you mad bandit in. You're sexy. Thank God it's Friday. We just want to party. We don't hurt nobody. So don't kill me. Don't mess with my vibe. Thank God it's Friday. We just want to party. We don't hurt nobody. So don't kill me. Don't mess my vibe. Thank God it's Friday. We just want to party. We don't hurt nobody. So don't kill me. Don't mess my vibe. It's Friday. We just want to party. We don't hurt nobody. So don't kill me. Don't mess my vibe. Say baby, I thank God it's Friday, but I'm gonna change it. So your dream don't finally come true. Don't finally join the Kiliwi. I'll be so proud of you. I no go waste your time. Other girls do me wrong, but you do me right. Oh my baby, make up your mind. You gotta to give you money, I give you love. Cause I give you love. Sweet melanin, oh girl. Sweet melanin, cover your body, girl. Tell me why your boy never cry. Over your body, girl. I say you coca body, the follow me auntie. Oh, tell me why your boy never cry. Over your body, girl. Yeah, girl, I go love you night and day because now you the boss my brain and I go blow your mind 40 for day, 40 for night and day. Girl, I go love you night and day because now you the boss my brain and I go blow your mind 40 for day, 40 for night and day. Yo, yo, night and day. Yo, yo, night and day. And I go blow your mind 40 for day, 40 for night and day. Yeah. Night and day, yo, yo, night and day. Yo, I go blow your mind 40 for day, 40 for night and day. Sweet melody, no girl. Sweet melody, over your body, yeah. Tell me why you're going to cry. Over your body, yeah. I say your coca body, the worry me auntie, yo. Tell me why I'm going to go cry. Over your body, yeah, yeah, yeah. I will love you night and day, because now you did bust my brain, and I go blow your mind, 44 days, 44 night and day. And I go love you night and day, because now you did bust my brain, and I go blow your mind, 44 days, 44 night and day.
A better records.
Big Joe on the beats.
Let's do things.
Okay. Mr. Yeah, to the day time shots, but I go talk and more. Oh my God, I'm begging you, make you forgive and more. If you ask me today, say what's in be the truth of the matter, I know, no. Me, I just duplicate what's in my eyes, see you, but I know, no. T'avais beaucoup d'ego, aujourd'hui t'es foiré, ouais. Beaucoup d'ego, aujourd'hui est ton lave, ouais. Petit commando, partout dans le quartier. Papa, papa, aujourd'hui t'es foiré, mais qu'est-ce qui n'a pas marché? 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 Ficelle, on t'appelle la reine de bon mais aujourd'hui y a rien. On te dit cherche l'amour, toi tu cherches les dos. T'as connu le vrai, mais tu préfères le faux. La femme est une fleur qui éclore le matin, mais le soir va finir par faner. Beaucoup de mecs qui aujourd'hui t'ont largué. Ouais, tu visais là-haut, mais aujourd'hui t'es tombé. Ouais, t'as brûlé la peau. La tata du quartier, mais aujourd'hui t'es fini. Ouais, bon chien, qu'est-ce qui n'a pas marché? Qu'est-ce qui n'a pas marché? Qu'est-ce qui n'a pas marché? Qu'est-ce qui n'a pas marché?
Yeah. What nowadays them think they too smart. They show you love them, show you big car, show you big house, show you big car. But you know, I'm not just flat. Just follow them, I come with the money. Yeah, them follow like a honey. And when the money finish, you go see them running. And leave you with the baby. No, ton mariage, personne à respirer. Voici quelques mois, voilà vous. Partout dans les bars, partout dans le quartier. Voilà maintenant, vous voilà divorcé et qu'est-ce qui n'a pas marché? 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 Let's listen. Ghana you be the worry got you. Free me and repeat them, don't lie and complain. They put money for you. Get somebody die for you. I just sorry for you. I wash out for you. Mola. So I find palava. To talk to net survivor. Then they go to school. You remain for God's sake. Money for school fees. You take on your shop. Your present for school.
You say you want wanted. You didn't get what you said that the show me. Get up from my shit. 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 Selection on the mix. Get up from my shit. Get up from my shit. Okay. I think it looks coming down. Look at here, that's that man.
So your dream don't finally come true. Don't finally join the Kiliwi. I'll be so proud of you.
I no go waste your time. Other girls do me wrong, but you do me right. Oh my baby, make up your mind. You gotta to give you money, I give you love. Cause I give you love. Sweet melanin, oh girl, sweet melanin. Cover your body, girl. Tell me why your boy no go cry. Over your body, girl. I say you coca body, the ball in me auntie. Oh, tell me why your boy no go cry. Over your body, girl. Yeah, girl, I go love you night and day because now you the boss my brain and I go blow your mind 44 days, 44 night and day. Girl, I go love you night and day because now you the boss my brain and I go blow your mind 44 days, 44 night and day. Yo, night and day. Yo, night and day. And I go blow your mind 44 days, 44 night and day. Yeah. Night and day. Yo, night and day. Girl, I go blow your mind 44 days, 44 night and day. Sweet melody, no God, sweet melody, cover your body, yeah. Tell me why your boy no cry. Over your body, yeah. I say your coca body, the worry me auntie, yo. Tell me why your boy no go cry. Over your body, yeah, yeah. I go love you night and day because now you the boss my brain and I go blow your mind 44 days, 44 night and day. Girl, I go love you night and day because now you the boss my brain and I go blow your mind 44 days, 44 night and day. And I go blow your mind 44 days, 44 night and day.
Qu'est-ce que tu disais dans tes lettres et tes messages? Que si jamais je pars, tu n'as plus d'histoire. Si jamais je pars, t'as plus de vie. Oh, oh, oh. Qu'est-ce que t'as fait de nos photos, nos chansons, ma musique et moi-même? Oh, nami leli awayoke otikinga sina mabanzo nanga yosala toujours présent mon cœur coule de sang dans mes rêves je te vois enamorondoni inganda memo wemo keti sango bima. Qu'est-ce que tu disais dans tes lettres et tes messages? Oh, que si jamais je pars, je n'ai plus d'histoire. Si jamais je pars, t'as plus de vie. Oh, oh, oh. Qu'est-ce que t'as fait de nos photos, nos chansons, ma musique et moi-même? Oh, 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 oh. Mais qu'est-ce que t'as fait de nos photos, nos chansons, ma musique et moi-même? Oh, la milele awayoke otikinga, sina mabanzo nanga, yosala toujours présent. Mon cœur coule de sang, yeah. Dans mes rêves, je te vois. La milele awayoke sina mabanzo nanga, yosala toujours présent. Mon cœur coule de sang, yeah. Dans mes rêves de soir. También vete a querer. Ven a querer, ça te voit. Mon cœur coule de sang, yeah. Dans mes rêves, je te vois. También son locos. Oh bébé, dis-moi ce que j'ai fait. Est-ce que t'es en train de partir? Je ne sais plus où on en est. Bébé, dis-le-moi. Si t'en as assez, mes erreurs de jeune fille, je peux toujours réparer. Oh bébé, dis-moi ce que j'ai fait. Est-ce que t'es en train de partir? Je ne sais plus où on en est. Bébé, dis-le-moi. Si t'en as assez, mes erreurs de jeune fille, je peux toujours réparer. J'ai jamais été du genre à revenir, faire hanter toute ma mémoire, regarder ses souvenirs. Bende tibo kaya dume. Oh, fragile, chérie, ensemble on est. Oh, bébé, petit guéris-moi. Oh, fragile, on revient ensemble, on est fragile. Non, je t'en prie, bébé, petit guéris-moi. Grandir, ça change les gens, tu le sais. Laisse-moi prendre un relais. Pourquoi ça lui fait autant si mon cœur pouvait témoigner. Oh, fragile. Chérie, ensemble, on est fragile. Oh, bébé. Petit guéris-moi. Oh, fragile. On revient ensemble, on est fragile. Je t'en prie, bébé. Petit guéris-moi. Berembe, berembe, nido tiwele. Terembe, terembe, nido tiwele. Wemetene, tembe, nido mabekongo, nila moye. Nadungo, nadungo, tembe wali, nila moye. Nadungo, nadungo, tembe wali. Moto nangu no titere, wangu no tembe kaya. Moto nangu no titere, tembe kaya, wangu no tembe kaya. Mono, donimo, oh, babe. Moda, oh, bina, genta temo. Mono, donimo, oh, babe. Oh, 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 oh. Kanda tamombi nangunuma tambina sisama kanda bisotise akolitingo tile gigi zonanguno titere wanguno tembikaya mozo nanguno titere tembikaya wanguno tembikaya mono zolimo ombi moza ombina gentatemo mono zolimo ombi oh 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 Monombi, mabeyeti, Congo nawa, Guatemo, Biduta, ti, legigi, tamo, tamo, terembi.
Mind is dirty.
Like I could raise my soul with a body. Feel like you go read yourself over that pussy. Shit is messy. Bad energy don't plenty. He don't plenty. Hey, whoa. Inside now. There I sit down. Why if I know they for them? I get killer. Change your for them. All my thing about it take 1 second to change your ways. Change your face. That your days you can start taking on your ass. Oh. Your way you know too straight. Contour. You they got to be there. You they got to be there. And if you heavy for my shoulder, it's a pillow sorry. And I did watch you from my corner. Oh yeah, look away. I did join my heart with what ya. I know your story. I know they like to share my cha-cha. Inside now, yeah, I sit down. Wait for the if I know they for them. I get killer, change your for them. All my sin about it take 1 second to change your ways, change your face. That your days you can start taking on your ass. Oh. Your way you know too straight, contour. You they got me there.
Bilango na bibamo, bisingo na bibamo, bitana bikirim bibamo. Bilango na bibamo, bisingo na bibamo, bitana bikirim bibamo. Atati songo itindomo mukidape. Utangote ungotile gitongo na bibamo. Atati songo itindomo mukidape. Utangote ungotile gitongo na bigimo. Bindoyimo. Even if I know you can't reach me, Bindoyemo. Even if I know you can't reach me, Bindoyemo. I love you, even if I know you can't reach me. I won't stop loving you. Bindoyemo. Even if I know you can't reach me, I won't stop loving you, baby. Yeah. Even if I know you can't reach me. Atati songo itindomo mukidape. Utanguti ungotile gitongo nam bigimo. Atati songo itindomo mukidape. Utanguti ungotile gitongo nam bigimo. Bindoyimo. Even if I know you can reach me, yeah. be loyal. Even if I'm wrong, you can reach me.
Hello. We look forward to welcoming you to the first ever CamDocUK Scientific Conference in Cameroon, precisely Yaoundé. It is themed around emergencies in non-communicable diseases.
This will be a unique opportunity to network with people from all around the world. And CamDocUK is partnering with University of the One, but also the Royal College of Physicians from the UK, who are very keen to understand what practice is like in Cameroon.
Hello, hello. Our next session is about to start. Please, can everyone come into the hall? Everyone, please come into the hall. Our next session is about to start.
Hello. Hello, everyone. I think we've had an ample break, and we are now going to continue with our schedule. We have another magistral presentation. We have Professor Jamshi to chair this session. Professor Jamshi.
Thank you very much, Prof. Ngachu. I'd like to invite Monsieur le Doyen, Simon-Pierre Chukem. As he said, he's traveled 350 kilometers from the highlands of Cameroon to be with us here. He's going to take us through an overview of NCD emergencies. And I think this is the heart, I should say. No, not the heart. I should say this is the main course. To stay with GI, this is the main course of the meal we have for these 2 days. So, Prof, Monsieur le Doyen, you have the floor.
Okay, thank you very much, Prof. Like I said a few hours earlier, I'm very honored, and I'm especially honored to have you introducing me. I always remind people, yes, oh, that's wonderful, 60 minutes. So I can talk, I make poses and talk and make poses. No, I'm joking. Yes, I always remind people that 1992, I know that some people's parents were not even born. 1992, I was a second-year medical student and you were a resident in Switzerland, and you used to come with Professor Bowman to teach us. So neurophysiology, I can't forget it. Thank you. Please, why are you so stingy? Why are people so stingy? You see, never miss the opportunity to value people, to congratulate people, to thank people, because you don't need anything but just a will to do that. But the return you get is just wonderful. You don't lose anything, you see. And the more you give, the more you get. Okay, thank you very much, Prof. Okay, that said, the next thing I wanted to say, yes, I see the room, I mean, the hall is a bit fuller than yesterday, because I wanted to ask, why is it that the hall is not full? Why is it that this amphitheater is not full? Because there are a few thousands of students in the faculty. But the next thing is, if you invite 100 persons and you get only one, please don't cry. Don't say, I got only 1%. You got 100% of the only person who was willing to come. So we have 100% of people who are supposed to be here. Okay, thank you. Well, this morning, I ended my talk by saying a walk, I mean, by paraphrasing Hippocrates, who said, a walk after dinner dries the belly and body prevents the stomach from becoming fat. So at least if we cannot walk, we can stand. And there's another say for NCD specialties, that is, sitting too much kills. In fact, why is it that people sleep or feel asleep after lunch? Can someone tell me, a student? Okay, I know that gastroenterologists are the boss of this thing. Please, I beg your pardon, may you just rise to avoid that sleepy feeling you are having, I'm sure. Yes, we can even stretch, you see. We should feel relaxed, okay? Relaxing is good for the brain. Exactly. Okay, thank you very much. Thank you. Okay, the next slide I wanted to show you before I even start. We are dealing with non-communicable diseases. I prefer to write non in capital letters and highlight it by using the red color. If I ask one of you, please just tell me what's your name. Yes, feel free. Hilaire. Okay. What's your name, please? Okay. Would you be happy if I call you, are you a man or a woman? You would say you're a man, right? Will you be happy if I call you, hello, you are a non-woman? Would you be happy if I call you a non-man? That's where problems start. You decide to call someone something, a non-something else. I think that's where the failure, the lack of awareness, the lack of advocacy, the lack of seriousness of policymakers all over the world, I would say, that's where it started. But I borrowed this from someone who is very dear to me, who was here in 2017, Professor David Matthews. He's one of the very first pioneer of the UKPDS study, who is my boss and my friend in Oxford. And he gave this keynote lecture here in 2017, Epidemic of Chronic Disease, a Plague of Ignorance, Greed, and Laziness. And he used to give this lecture in Europe, all over, and he will always start by saying, are you happy when you are called a non-someone else or a non-something? This was just to raise our awareness on the fact that just by the name, you may start causing troubles for the future of something that's been started. think about it. Maybe tomorrow you'll be the one to sit, brainstorm, and see how to give a name that will tell us more about the problem and maybe attract people to invest more, to take chronic diseases much more seriously. Thank you. So in the next few minutes, I think it will take 20 to 30 minutes, I'll be discussing with you on emergencies in NCDs. I'm very happy because I was supposed to give this talk yesterday at the very first one. It would have been much more difficult because I was supposed to be the first. But now, so many people have already given details. I was supposed to give this after gastroenterologist. So my task is quite easy now. And you apologize if at some point I just go quickly. I don't have any conflict of interest. Let's start by doing some language stuff. 2 keywords, emergencies, NCDs. Let's focus on emergency. What does the word emergency mean? It rings an alarm. Why does it ring an alarm in our mind? Because it means so many things. It means unexpected, difficult, or dangerous situation. You see, nobody wants unexpected situation. Nobody wants difficult, dangerous situation, which happens suddenly and which requires immediate action. You have to act right away in order to avoid harmful consequences. If you don't do it, something bad may happen or will probably happen. This is from Collins Dictionary and Cambridge Dictionary. So from there, we can draw some few features. Number 1, it means that someone may die. You see, someone may die, and that someone is maybe your aunt, your mother, your dad, your brother, your son, your daughter. So please, empathy in that sense. Empathy. The person you may not be taking seriously in an urgent or emergency situation, maybe exactly what will happen to one of yours, to one person who is dear to you elsewhere as a boomerang effect. Always think about it before you treat people. It also means in any clinical situation, yes, you should rule out emergency before you start acting, because if you miss an emergency, it's a problem. You have less time to think before acting. So your brain really has to accelerate. Okay. 16 gigaoctet of RAM, 32 giga, 64 giga, 128 gigas. Okay. Any small in quotes mistake may be fatal. People around, because you should not forget about people around, are anxious, inquisitive, and may become aggressive. So you see, besides making sure that you manage the situation well in terms medically speaking, you need your soft skills. You need to communicate with people around. So I prefer to start with this. So beside all, you need to keep this in mind whenever you face a situation of emergency. Now, what will be the scope of my presentation? When you put NCDs and emergencies together, the 2 key terms, in reality, they might be analyzed in 3 ways. Number 1, it might be a public health view. NCD epidemics that require emergency policy action. In that view, you see that hypertension, diabetes, almost, the 4 or the 5 major NCDs are emergencies, public health wise. Second, but this is not the one I'm going to approach today. This is not the scope of today. Number 2, still a public health view. It might be how to care for NCDs in emergencies. But emergencies here means disasters, infectious disease epidemics, and so forth. This one as well will not be covered during this talk. Then the third one is a clinical view. What are the clinical emergency presentation, that is acute complications of NCDs? And that's what we're going to cover over the next few minutes. So what are the questions I'm going to answer and share with you? Number one question, why is it important to discuss emergencies in NCDs? Why is it important? We need to know that. Otherwise, why should you be here on Friday rather than going to the village or wherever? What are these emergencies? What are they? What are the challenges of prevention and care of these situations? What is the situation in Cameroon? That's where we are much more interested, because we need to know how to manage the situation in our country, in our area, and what lessons should be taken back home. So the objectives are just quite simple. I'll be giving you an overview of the clinical emergencies associated with NCD, very briefly, because it's not my aim to start discussing diabetes ketoacidosis. It was done yesterday, stroke, no. I have just to overview so that everybody in here, the students or residents, know exactly when it comes to NCD emergency, this is what we should have in mind. You have to be aware of the challenges associated with their management, because knowing challenges help prepare better to cope with what we'll face. So I propose the following agenda. I'll define, provide the burden and the spectrum, give you a brief overview of major NCD emergencies, discuss the challenges associated with NCD emergencies with a glimpse of the situation in Cameroon, and I'll end with take-home messages. NCD, what is an NCD? I'm sure you got the definition throughout, but let us repeat it. These are diseases, number one, characterized by non-contagious nature, multiple risk factors, long latency period, prolonged temporal course, functional impairment or disability, and incurability. What I mean here and what is in the literature, it doesn't mean that you can't do anything. It means you can say at one point in time that we have dealt with, goodbye, don't come anymore. Though in some specific situations, we might get a cure, but generally speaking, an NCD, we do not expect a cure. Now, we are very acquainted over things over the past centuries, even millennia, we're very well acquainted with infectious communicable diseases. So since they have been called non-communicable, it also means we have to compare them. So how are they non-communicable? In other words, how do they differ with infectious diseases? Number one, a non-communicable disease generally develops as a result of complex interactions. See? Interactions between risk factors. These risk factors might be genetic, biological, behavioral factors, and so forth, environmental. Number two, as opposed to NCDs, an infectious disease generally develops as a result of, number one, an identifiable microorganism that is gotten through a contamination route, generally speaking. This may happen with or without any favoring factor, which might be terrain, like diabetes favoring infections, or a triggering factor like stress. You see, usually sometime when, just right after exams, so many students have malaria, not so? Because you spend nights sleepless to prepare your exams. Okay, after competition, that's what sometimes happens. So, not in passing that, one may favor or may compete or may complicate the other. Still to compare, let me share this cartoon with you. How do they develop? This is for infectious diseases. you have typically a microorganism in the presence or not of a favoring factor, the disease develops and becomes obvious. Then the evolution under treatment, the outcome may be cure with or without complications or death. Very simple. At least for infectious diseases, the path is not so complicated to describe, though there might be many other complications. This is a very, very oversimplified schema or description. What about NCDs? Risk factors, that's the problem. You have risk factors. Do you have any specific cause except for genetic diseases? You have risk factors, genetic, biological, environmental, behavioral. Then these risk factors lead to initiation and progression of organic and functional alterations. That's the very first step. But at this step, nobody knows. You do not know that you are prone to diabetes. You may not. You are prone to diabetes, and then something is happening progressively, silently. Then, under the catalytic action of factors of progression, the person eventually developed the disease, and later on or further, factors of progression, development of chronic complication or even death. But also, and that's where we are interesting, in the presence of any triggering factor, development of acute complications, and that's where we fall, emergencies. The burden of NCD is 41 million deaths worldwide. And amongst these 41 million deaths, some are death in chronic conditions. Some others happen because of these acute complications. And that's why they are worth studying, they are worth presenting, they are worth discussing about. 77% of these occur in low and middle income countries, Cameroon, okay? 17 million are young, less than 70 years. Beside this burden in terms of death, you may still alive, but develop disabilities, personal, social, and there are also economic impacts. As you probably listened during these presentations, the economic impact is just huge. And that may be one reason why people do not want or do not like or do not think that they should invest in. What are the major NCDs? There are 4 dominant NCDs that represent more than 80%. These are cardiovascular diseases, 17.9 million deaths. Second position, cancers, 9.3 million deaths annually, I mean. Third, chronic respiratory diseases, 4.1 million deaths. And fourth, diabetes mellitus, 2 million deaths annually. What are the other NCDs? Yes, based on systemic organization, you have neurological and mental diseases, digestive diseases, chronic kidney disease, musculoskeletal diseases, non-neoplastic hematological diseases, autoimmune, other endocrine metabolic, glaucoma, hearing loss, and so forth. This one will represent less than 20%. And that's why you typically see in books or elsewhere mentioning the 4 major ones, but it doesn't mean that the other do not exist or that they do not fall somewhere. That said, we are now convinced that NCD, we know now what NCDs are. We now know what's their burden. Why are they worth studying, discussing, and spending time about? We know our spectrum. The next question is, what are these emergency situations that can happen on the background on NCDs and link to the NCD? I prefer a pedagogic approach, a didactical approach to classify them in terms of specific to NCD. That is, if there isn't that NCD, you won't have the complication. And non-specific, an infection can happen on any terrain. For specific, we have direct acute complication or direct emergencies. That means it is the NCD itself that is causing the acute complication. For instance, diabetes ketoacidosis. You can have diabetic ketoacidosis if you don't have diabetes. You may have ketoacidosis from another cause, okay? Indirect, like treatment or procedure induced, okay? Like hypoglycemia. You discussed hypoglycemia yesterday. And non-specific, increased susceptibility to acute infections, increased susceptibility to other life-threatening situations like bleeding, you see. Someone has a disease, a chronic disease, is prone to bleed and dies from bleeding, but the disease itself is not known to cause bleeding directly. So let us go and list them. Number one, cardiovascular emergencies, stroke. Yes, I know stroke is under cardiovascular and also under neurological. Stroke, acute coronary syndrome, hypertensive emergencies and urgencies, acute heart failure, acute peripheral ischemia, aortic dissection, and we can cite many more. Number two, diabetes complications and other endocrine emergencies. You have diabetic-specific complications. They may be direct, DKA, hyperglycemic hyperosmolar states. They may be indirect, that is drug-induced, for instance, hypoglycemia. Or non-specific acute complications, severe infections, because diabetes itself just prepares the room for infections or many other acute situations to happen because of mechanisms we can very well describe. Other endocrine emergencies, for instance, thyroid storm, adrenal insufficiency. Okay. Number three, neurological emergencies, stroke, seizures, severe depression, acute psychosis, nephrological, acute kidney injury, complications of dialysis, you see, indirect complications. Number five, respiratory emergencies, acute asthma, you see. There are many cases of asthma in our environment. Acute exacerbation of COPD, chronic obstructive pulmonary disease. Digestive emergencies, GIT bleeding. Yesterday you did GIT bleeding with Professor Ngachu. Acute liver failure, you discussed it yesterday as well. These are situations that are very common in our environment. Oncological emergencies, acute immunosuppression due to the disease itself or indirectly caused by the treatment, chemotherapy. Acute anemia, acute hypercalcemia. Number eight, non-neoplastic hematological emergencies. Sickle cell anemia, we are in an area, an endemic area, we should never forget about this. Sickle cell anemia and others. So we have just, without being exhaustive, listed in an organized manner the major emergencies in NCDs, which you have, which you probably are, or which you will face in your clinical practice. Whether you want it or not, you will face many of these, either as a patient yourself, that's the worst, I don't wish you, either as a family member of someone who is severe, either as a doctor or either as just a friend or whatever. Okay. That means you have better mastered them. I always teach my students this nice story. In fact, it isn't nice at all. If you neglect others, do you know the syndrome of Saturday midnight in August in the village? It's my syndrome, so you probably don't know. Saturday midnight around the 15th of August, that's where so many people gather in the village. Midnight Saturday. What happens? You are a doctor, you say, I don't care. I don't care. I'm a delegate medical. I don't care about clinical medicine. Midnight, you have had a very nice family gathering, eaten. What happens? Your dad or your mom or your aunt. Pain here. Or pain here. What is here? What is here? Acute pancreatitis. You see, if you neglect one day, 20 years, what I didn't say is after 20 years of medical practice, and on that night, you regret all your life and your future becomes bitter. I don't wish you. I don't wish you that. I see some of my students smiling because they know the story. Luckily, it's not a real story, but it has certainly happened to one way or another. So that's what are the challenges then? Very happy, we're very short because Professor Jamshi, in an extremely elegant way, which he masters very well, he approached the challenges associated with NCD. So you see, coming last has so many advantages because you can skip many things that have been more elegantly approached by other people. NCD emergencies. We wish the pre-primary prevention worked, in which case the person didn't even have the NCD to be able to have the emergency. So we have the challenge of pre-primary and primary prevention. Pre-primary means what? Means preventing the cause of the problem we are studying. So when you prevent diabetes, hypertension, you are preventing the prevention of emergencies associated with this, or primary prevention, appropriate care and follow-up of NCDs. All these are our jobs. A 53-year-old man is admitted in your service for malaria, obviously. What happened is that after 3 days of treatment, you're happy, the family is happy, and the patient is discharged. Wonderful. They say, thank you, doctor. Oh, you are a very good doctor. Oh, you are my God, like people like saying in Cameroon. Then, 2 months later, you get to the hospital at 7 a.m. because you are a good doctor. That's why you come at 7 a.m. And the nurse said, this is your patient who appreciated very well 2 months ago, and the situation is bad. What has happened? You didn't take the blood pressure. The guy was obese. You didn't tell him that, please, this is your BMI. You didn't have holistic view of human beings. You treated malaria as if malaria was under a microscope. You didn't treat the person. And the guy is coming back with stroke. What do you think, or how do you think the family will view you? They are well educated, they go and read, and they say that, risk factors of stroke, obesity, and they come, doctor, we thought that you were a good doctor now, but you didn't tell us that this father could have stroke. You see, I don't wish you this kind of situation. Number 2 challenge, the challenge of timely and appropriate care. It should be timely and appropriate. And this is where, I don't know, I'm still looking for a word to characterize the situation in our country, the situation of healthcare personnel. We have to be honest and look ourselves into a mirror. This is a serious weakness. This health service delivery. Number 1, the response system. Alert. Do you have any alert system? Transport, access, emergency system. Do you have an emergency unit that's well built, that has everything? Competent human resources who are responsive, who are interactive, and who are included in, who like teamwork. Drug availability and accessibility. material and equipment. Yes. Multidisciplinary care, as your colleagues advise. Prevention of hospital-associated complications. And I'll ask you to give me a few minutes because I'm going to travel back to something we did regarding prevention of hospital-associated complications, because these complications happen because the guy is admitted. Why is he or she admitted? Because he has an emergency. Why did he or she have the emergency? Because he or she had the NCD. A few years ago, with my team in General Hospital, we questioned how admission itself can be the source of problem, which we published in Transaction of Royal Society of Tropical Medicine. And we followed up patients in our unit, both infectious and non-infectious unit, to assess the incidence and the characteristics of hospital-acquired complications. Number one, look at this table, and you see that NCDs associated with this admission represent almost 60%. We are in Africa. We are in sub-Saharan Africa. We are in Cameroon. Cancer-related, stroke, diabetes-related, liver disease, heart failure, renal failure, gout, peptic ulcer disease, vascular. These are the diagnosis or the terrain on admission. Then this is what we found. Cumulative incidence of hospital-acquired complications, 29.2 per 1,000 patient year. 1,000, not 100. 20.9% were non-infectious. You see, we are in Africa. The major one, constipation. Yes, never neglect constipation. Neurology will tell you that having constipation may be a very negative factor in so many neurological situations. It might be the case for many other diseases, decubitus ulcers and so forth. And we went deep, we went in depth to see how economically it could have a negative impact and see the additional cost. Sorry. Additional costs associated with these complications, independent of what the patient was supposed to pay for the reason why he or she was admitted. You see, 135 euros, 158, 160, and so forth. And then last but not the least, the length of admission was increased. And that's one reason that explained the increased cost. So I did this just to show you how if things are not well done, not well managed, they may lead to additional acute situation superimposed to the acute situation or the emergency that brought the patient to the hospital. Then let's come back. Let's travel back to number 3, tertiary prevention. Yes, we should think about rehabilitation. How do we rehabilitate these patients who were admitted for stroke and so forth, cardiovascular disease and so forth? The challenge of research and the research to inform policy, we really need that, because how would policymakers purchase X machines of this? X defibrillators, X point of care glucose machines, if they do not know what is the burden of this problem in our health institutions. So we have that job, provide data to inform policy, health system gaps, readiness, what hospitals are able to manage so that we can equip them, or if they are unable, or we can improve. What are the economic costs? And last, yes, capacity building. This is exactly, thanks to CamDocUK, this is exactly what we should be doing in a regular basis. Then, situation in Cameroon. I prefer to approach it as a SWOT analysis, not exhaustive. NCDs, associated emergencies. What are the strengths? Yes, we have a health systems with multi-level healthcare organization. It means that theoretically or in principles, people should know that if it doesn't work at this level, we send the patient to the higher level, in principle. Newly built reference hospitals in regions. Good. Strength. Improvement of health systems are following the COVID-19 pandemic. Good. This is the positive things that we may get from a negative situation. Political will. You heard Professor Sogui saying they have purchased 60,000 of this. Okay, so there is a political will. What are the weaknesses? Unfortunately, you can see that the list is the general behavior. Let's look at ourselves in the mirror. The general behavior in our country, individuals in behavior. Lack of emergency reflex. The patient is amenez-le là-bas. Couchez-le. Pourquoi vous avez attendu comme ça avant de venir? Why do you spend so much time before bringing him? Population ignorance of NCD and NCD emergencies. Poor alert system, poor transportation system, weak geographical coverage, drug availability and cost, very limited. You see. Limited equipment, poor research, funding, poor involvement of other sectors. We really need to raise that. Otherwise, if you don't make a good diagnosis, how will you treat the patient? But we have opportunities. Good news, opportunities. Diaspora, CamDocUK, thank you. But we wish other diaspora, yes, there are other diaspora doing it in other ways, but we need more than that. Diaspora, other private fundings, smartphone penetration in the society, we can use them, we can use that to leverage on communicating, educating. Newly acquired point of care material, like Professor Sogui was saying, integration of and mutualization of national health programs. Patients organization, yes, patients should be interactive and help in tackling the problems. But we have threats. What are the threats? Increasing NCD epidemic means increasing NCD emergencies, unfortunately. Decreasing international NCD funding, financial crisis, prevalent infectious diseases. So we are still focused on infectious diseases. So it is a threat. It is a threat that prevents the system to focus enough on NCDs and their answering emergencies. Infectious pandemics. Yes, you have probably read in many articles that during the COVID pandemic, and it makes sense, the death rate increased for NCDs. That makes sense because all our attention was focused on the epidemics. Rightly or wrongly, but focused. Brain drain. We wish, and that's where we should turn CamDocUK. The right thing is brain circulation. Going abroad is not a problem. Please don't waste it. Going abroad is not a problem. Going abroad may be a huge opportunity, and usually it is. We should shift from brain drain to brain circulation. You go, you get, you bring. You go, you get, you bring. You go, you get, you bring. It develops others, and so forth. Brain circulation. But brain drain is a threat. So to end with, what are the take-home messages? I hope you have listened at me very well, because I'm not going to list the messages. I just want to say, yes, obviously NCD emergencies or emergencies in NCDs are major health problems for obvious reasons. Their causes are increasing. They are very frequent. They are life-threatening. They are very costly, very expensive. Their control requires human resources. good human resources, well-trained, competent, okay, infrastructures, equipment, research, data to inform policy, and to assess or to audit our practices. Multi-sectoral contribution. It's not a matter of Ministry of Health. It's a matter of everybody. The health system is everybody. Hospital is typically the failure of the health system. Hospital represent almost nothing in the health system. Though it is there, we see everything because that's where the severe situations are. And severe situations make noise. The diaspora represents an essential leverage. Whatever you do, remember whenever you're managing emergencies. Number one, primum non nocere. First thing, do not harm. The very first essential law of medicine, do not harm. Number two, it goes in the same direction. I quote William Osler, the young physician. Some of you are very young physicians or students. Young physicians start their life with 20 drugs for each disease. But if they really learn well, they end up with one drug for 20 diseases. That said, thank you very much for your attention.
I don't think that applause was enough for Prof. Shukem. Thank you very much, Prof. Shukem. There are not supposed to be any questions for a keynote address like this. But since I have the privilege of being the chair, we can have some conversation. You started philosophically by expressing the concern about the terminology and semantics around none. A similar thing happens with mental health. WHO has invested into the mental health program for 20 years. But if you download their report of last year, I think, they're saying if they were to start, they would still have the same objectives as they had 20 years ago. It's written in the report. That's not very encouraging. And you know, psychiatric problems constitute a big portion of NCDs, as it's a question of identity. If identity and level of appreciation, when you know who you are, where you're coming from, where you are, and where you are going to, then you best know whom to go with and how to go. But when you don't even know whom you are, you don't even recognize your name when it is called, or you don't even agree with the name that you are called, then you have several problems. I think that's why we have proposed, at least to the WHO and the scientific committee, that the only way we're going to make progress in mental health is to adopt the IGAP. That is to talk about brain health. Last year, when I had 275 residents in this same hall for their initiation seminar for them to start their training, all 31 specialties together, I asked the psychiatrists to come and stand in front. They came and stood in front here in this hall. Then I asked the rest of the physicians in training, how would you feel if your personal doctor asked you to come and see one of these? I would feel ashamed. I would feel shy. I would feel shocked. That's how we physicians feel about our colleagues who practice psychiatry. because that specialty, unfortunately, is stigmatizing. Equally, the name mental health is stigmatizing. It is stigmatizing, it is short-sighted, it is many other aspects that I came up with. I would continue to argue that NCDs, as they are called, most of them are risk factors for brain health. If you tell someone, come and have a brain check, what would you feel? I mean, if I say, Mr. Takwe, that I would like you to come, let's go to the hospital for you to have a brain check, would you quickly accept or you would hesitate? Okay, if I ask you that you badly need a mental check, you would ask for you would ask for your coffin, right? What I'm saying is that the concept of mental health is stigmatizing, is short-sighted. It is not, doesn't attract funding. Just like the concept of NCDs doesn't attract any funding. If everybody, which is what we are asking all governments around the world, and that's what we went to the UN to see, if all governments around the world would focus on brain health, because even politicians need brain health. Business people need brain health for their business. Children need brain health for their studies. Couples need brain health for their sentimental stuff. I don't want to say that leaders who initiate wars need brain health. If we focus on that, we can get a better buy in terms of funding and in terms of reduction of stigma, in terms of reduction, and can fit the users. So I want to check with organization if we're on time and if we can round up here. Yes, for this session. So again, Prof. Monsieur Le Doyen, thank you so very much. There's a lot of work to do. There's a lot of philosophical thinking that has to go into this again. And thanks for the work you've been doing, and thanks for this excellent presentation and for this approach.
Thank you, Professor Njamshi. Thank you, Professor Chukem. We are moving on to the next bit, which is going to be an interactive section. I think Professor Chukem said it. Looks like after you eat, you feel very sleepy, what they call postprandial somnolence. So if you Google it, you can Google it and understand what it means. So I think the next panel is going to try and get us out of that somnolence and give us some caffeine. I would like to welcome no other than the president of CamDoc, who is chairing this session, Dr. Linda Bello. And I also like to welcome to the stage Dr. Beho Agboro Obale. This is a wholly CamDoc panel. So please listen, and before they take up their presentation, I would like to make a small clarification, because some of the issues might actually cause a bit of misunderstanding where we are. And that clarification is the difference in the health systems. I think it's important we get that clear. The Cameroon health system is structurally or organized different from the English health system, even though the elements might be the same. The organization is different. In Cameroon, we have I think you have a district medical officer. You have 189 health districts, and each district has a district health officer. Now, I don't know their remit, but that is the lowest level of medical care in Cameroon. And like you heard, it's a tiered system, and you go up to the tertiary and quaternary hospitals. In the United Kingdom, healthcare is organized in a primary care, a secondary care, and a tertiary care. Okay. Now, in the United Kingdom, everybody is entitled to a primary care physician. So everybody in the UK has a primary care physician. Secondary care has got different levels of doctors up to the consultant. So you would hear on some of the presentation, the patient presented to their GP or general practitioner. That is different from the GP you have here. The general practitioner in the UK is called the family physician in the United States, and I don't know the equivalent in Cameroon. Sorry? Yes. In the United Kingdom, a general practitioner or a family physician is a trained specialist. They are trained in family medicine. They are specialists in family medicine. They are not just somebody who has just come out of medical school. So let's know that difference. Somebody who has come out of medical school is a junior doctor in the hospital. So you might hear, they will say a foundation doctor or a resident, as they want to call them nowadays. So I'll hand over the microphone to the chair, Dr. Bello, to lead in this session.
Thank you very much, Prof. You've really, you've stolen my thunder a little bit, Prof. But yes, Prof has explained everything that as a prelude to the presentation by Dr. Bahel Obale, who is one of our founding CamDocUK members. She's a very, very experienced acute medical consultant. She does lots of teaching. She's already done some teaching before coming and doing these presentations here today. She'll also be teaching next week. She's going to be talking about early warning scores. We're all being encouraged to download that app. So I hope you guys have got network data to download this News2 app, because that was going to be very helpful for this very interactive presentations. So without further ado, let's welcome Dr. Beho Obale. Dr. Obale, over to you.
Good afternoon, everybody. Can you hear me? I don't think I have only 15 minutes for this talk.
No, this one is 45. Yeah, we swapped it around.
So good afternoon, everybody. Thanks, Linda, for the introduction. So this talk will be interactive. I just want to Okay, this discussion is going to be interactive, and kind of people who have got access to the app kind of will be able to use it, but we'll have the kind of the screen copy of the kind of what I want us to calculate during the talk. So what I'll be talking about, early warning scores, clinical tool to improve patient outcome. And next slide. How do I change the slides? Okay, so what I'll be talking about is the national early warning scores that are used in the United Kingdom. I'll be talking about physiological parameters. I'll be talking about scoring. I'll be talking about track and trigger and impact of the use of early warning scores on patient outcome, some case history, some final tips and takeaway. And hopefully I might be able to get some people to consider thinking about the early warning scores. So I'll be talking about that shortly. But one of the things I'll talk about, say before I start is, I'm not going to talk about rocket science. Today we're going to talk about down to earth things. So I'm going to talk about something that I'm sure all of you know about. I'm going to talk a lot about vital signs. I'm sure, can I have a hands up kind of to make sure that everybody knows about vital signs? Good, good. I expected more hands. Who doesn't know about vital signs? Everybody knows about vital signs, I suppose so. So we will be talking about vital signs, and we'll be talking about something that's changed on as far as vital signs. And so I'll talk about the first two slides, and I'll talk a little bit more why we kind of had this change in the UK for the past 20 odd years. So we'll talk about the NEWS 2 scores, is the established track and trigger system used in all ambulance services and hospitals in the United Kingdom to assess illness, severity, and risk of deterioration for patients. It uses six physiological parameters, and it uses a simple algorithm that is easy to calculate. So we've got the 6 physiological parameters. We've got the respiratory rate, we've got oxygen saturation, we've got the blood pressure, we've pulse, we've got temperature, and we've got cognitive status or mental status. So for this scores, the normal vital signs are considered as 0. Any subtle variation from the normal vital signs are given numbers, and this variation kind of giving severity scores that vary from 1 to 3. And when we kind of add the use of oxygen to a patient who is acutely unwell to maintain their oxygen levels, it gets a score of 2. And if a patient is acutely unwell and has acute confusion as part of their illness, it scores a 3. So we've got we've already talked about the respiratory, the parameters, respiratory rate, kind of talks about the the respiratory rate as well as the effort and stuff like that. So we will go into all of this in much more detail. So that is the the new scoring system. We will be using this to calculate the different scores as we go along. The app in the computer, the application in the computer kind of calculates these scores just as well. So could we go back to this so if you look at all the column that is white, talks about the normal scores. And if you go just you shift a little bit on the yellow bit, you've got the just a subtle variation in the normal scores. It may not be that significant, but by the time you add, when the patient comes into hospital normally, usually within half an hour, they're supposed to have all of their vital signs checked. When the vital signs is checked, they check their respiratory rate, oxygen stats, pulse, blood pressure, temperature, consciousness level, and all of that is added up. Sometimes all of them could be 0 and have a score of 0. Sometimes they could get some yellow markers, that will score 1. They could have some orange markers that could score 2. But any scores of 3 is considered as a danger score. So you will see how we'll talk about those danger scores soon. Next. So this monitoring can identify patients at risk of early or acute deterioration. Acute deterioration in patients who are unwell is often preceded by subtle changes in these physiological markers. And very often it takes hours prior to any occurrence of serious adverse events. And when we talk of serious adverse events, we are talking of cardiac arrest, death, or the need for admission to the intensive care unit. All of this can be avoided if we're able to identify these subtle changes in the physiological parameters, act on them, and get them corrected back to normal. And it assists in deciding which patients need admission, such as patients with high early warning scores, which of those patients might need ITU admission, which of those patients need to be managed in specialist areas like the resuscitation area or high dependency area. Also, picking up the early warning scores early can make people get treatment promptly, and that could get them to recover quickly. And say if somebody was scoring a high early warning score of 5, given appropriate treatment, early score drops to 2, they could be observed for a few hours and discharged from ED rather than being admitted into hospital unnecessarily. So it's it's more like an alert system, as Prof just said recently. That is one of our alert systems that works very well. And so when people come to triage, it helps the senior nurse, with all the nurses in triage as specialist nurses, to be able to identify where to put these patients, how quickly can this patient be assessed. And so it's not just in the in hospitals that we use this. The ambulance team uses this, the primary care physician. Linda Bello is one of our primary care physicians. They all use this, and it's a common language we all use. So if I say patient is scoring 10, oh, Linda will be right on her feet to sort something out because we all share the same language, as you'll see soon. So could we go to the so the use of the health, so I would say the use of the new score has improved clinical outcomes significantly. It has saved tens of thousands of lives each year in the UK. And I would say it could be hundreds of thousands of lives, but you're not going to calculate something that somebody that didn't end up in IT. But I will say that I've worked in NHS for many, many years. And I will say in the past 10 years, I would say the number of cardiac arrests we get from deteriorating patients in the wards has reduced to such an amount that if I get one cardiac arrest in the ward area I work in 3 weeks, it's like, oh, that is plenty. As a registrar, 3 a week was like the norm. Getting 3 cardiac arrests in a week, that was the norm. So to me, I think as a personal experience, it shows a marked improvement in patient care. And so when patients get their early warning scores kind of recognized, identified, responded to promptly, and they get the treatment promptly, and the specialist people who could manage them at the different levels, as we're going to see soon, they stay in hospital shorter, they get well better, and the need for ITU admissions is reduced. So we do not get plenty of patients being admitted to ITU because, as you will see very soon, the ITU team is on board. And years ago, it was noted that patients who had very high early warning scores, when they went to ITU, they didn't do well anyway. So I come to the ward to make sure that the patients are supported and patients get the best care possible. And it's just something to mention that the early warning score, in the past 4 years, it's become mandatory training for everybody in the hospital. All the hospitals in the kingdom, before lots of hospitals did it, it was done ad hoc, but many people had some training, but now it is mandatory training. That implies that from the edge soignant or the clinical support worker to the consultants, we cover about the same topic and the same items on the early warning score. Though as doctors, we get plenty more things that are out of the early warning score. So what it is I'm not going to present just things on the early warning score because it will make this a bit boring, because as it's important that we impress on you people that what is about clinical reasoning, about clinical judgment. The early warning score does not replace clinical judgment, but it's a trigger to make sure that patients are identified early, treated properly. It's a form of an alert system, and it reduces mortality. So this is that. If you Google Royal College of Physicians early warning score 2, you're going to get that page. And on that page, if you scroll down on that page, you'll get lots of articles, lots of links, lots of information that goes to support how they came to develop these national early warning scores. As I mentioned, vital signs measurements have been there forever, hundreds of years. We've known about vital signs. As of the 90s, lots of the teams from critical care units and emergency care units and the hospital mortality teams and clinical care, they discovered that there were certain issues that made patients die in hospital, that certain things that contributed to patients' mortality. So they came up with packages that could classify different physiological markers, the variations, by giving them scores. So the early warning scores I'm talking about is not something that's been going on forever. We used to use the vital signs to make clinical judgments, but the concept of early warning scores as a bundle that could be used by everybody to make best decisions has only been there for about 30 odd years. And so it wasn't there when I graduated from medical school. Some disclosure of being older. So there is so it's been developed by the Royal College of Physicians. It's a national tool, and it's also used internationally, early warning scores in other countries internationally. I will be using some scenarios from the discussions in the early warning score electronic learning sites to which kind of it feels you. It is free for doctors who work in the United Kingdom. In case anybody who is in the medical profession, nurses or kind of nurses, doctors, or anybody who has anything to do with patient care, if you want to register, you may have to pay a fee. It's £5. That's about 400, about 4,000 for non-UK staff. And if you do the e-learning, it's kind of, you'll get a certificate. And the e-learning, it's got 7 modules. It could take about an hour or up to 2 hours, depending on the seniority of your clinical practice. So the Google app there, you could get the app in case you want to do some of the calculations. So that was what was put on the screen. Oh, is it possible to have some water, please? So I'll just say that why do I want to encourage people to use the news? So some of the reason I want to encourage us to use the news is that you have 6 physiological parameters and you've got the scoring on the side of the form. So you do not have to think on how to calculate the scorings. I'll show you people the scores we use soon. It's easy to clinical staff on how to use it. There is no cost equipment or expensive resources. A thermometer, a sphygmomanometer, and your eyes and your finger to kind of measure the pulse. That's just about what it is. Nothing complicated. You're being observant to be able to see if a patient is acutely confused or if the patient kind of is not responding to voice pain or is unresponsive. It's not expensive. And we want to kind of look for something that could improve patient outcome without breaking the bank. I know we're talking about resource poor countries, but kind of we use it in England and it's not costing us anything. So we've got the score, kind of the scoring there again, I'm going to kind of talk a little bit about it for a minute. If you look at the scoring on the kind of with the respiratory rate, if you look at the respiratory rate, less than 8 is very low. You know that could cause cardiac arrest. Greater than 25 is very high. I've got a slide I'll show at some point why kind of you've got to be very careful with the markers on the red area. And on the oxygen scale, we've got 2 different scales. I'm sure you've noticed it. The first scale is for everybody, and normal is above 96. But when patients are acutely unwell, the consensus is that when patients are admitted in hospital, they are unwell, the aim is to achieve to keep the oxygen stats at 94 to 98. And on the second oxygen scale is for people who have got known history of COPD, or if they've got COPD and they are known to retain oxygen, especially if you give them additional oxygen. And for kind of acute confusion, part of the reason acute confusion was included is because we had lots of elderly patients who could get kind of acutely unwell. They may not spike a temperature, but they could just go acutely confused or have delirium. And that has helped, that is one of the improvements that was done on the alert score in 2018. And the alert score 2 was implemented nationally in 2018. Okay. So we've talked about patients kind of getting the vital signs at presentation, at triage, which identifies the level of concern. For the track, all the patients who are in the ward, they get their vital signs done. That helps us to know what their physiological status are throughout the patient's stay. And the physiological parameters are allocated numbers, which we already know. Ill patients will always have abnormal physiology. And we know 3 is a severe, mild is great. Then we have what we call the trigger. The trigger kind of goes by the fact that when you kind of physiological marker, you've got to add them up. 0 is the expected normal. And kind of sometimes you may get levels of total of 1, total of 3, kind of total of 4, total of 5, and so on. If you've got one parameter that scores 3, it's classified as severe. If you have a total of all of them that scores 5, or 5 including one parameter that scores 3, it's considered as severe. It has kind of moderately severe risk, and that has got to be actioned promptly, if possible, within the hour, and somebody should be seeing the patient within 30 minutes. So serious adverse events are common in patients who've got high early warning scores. Next, please. Next, please. Okay, so part of it is just about kind of talking about the early warning scores provide all of us with a kind of a simple language. We all understand what we are saying. So if you say patient is scoring 10, you know that this patient needs to be seen kind of in a high dependency area, monitored every 15 minutes, the kind of the airway, respiration, circulation, and all of that has got to be managed properly so that the patient should recover quickly. If you do not do that, the patient, anybody who is scoring anything above 7, especially above 9, outcome is not usually very good. Okay, and it kind of enables a consistency in communication. So part of it is because it's national, kind of once you mention what the score is, everybody knows what you're talking. You could say early warning score of 6, and you could break it down. Early warning of 6 with a 3 for acute confusion and a 2 for oxygen level that is at 92%. So it's a national language that all of us understand. And we already know that the clinical services, ambulance and hospitals always use it. And it's often effective. Once we get the early warning scores, we assess patients using the ABCDE framework. And that helps us to be able to pick up lots of other problems that could have caused the early warning score to go down. And kind of we've got also that, what I can't even read from me. So, and we know that the early warning scores, I said earlier, it does not replace clinical judgment. It's not an isolated tool. We use the clinical kind of the new score in addition to other scores, such as the CURB score, the ABC2 score. We're using the Glasgow Blanchford score. We use it with other scores. We take the history, we kind of past medical history, patient frailty scores, and all of that and kind of what medication is the patient taking, is the patient alcoholic, all of that kind of come together to give the patient the best care. Kind of completion of assessment or investigation must not delay patients' life-saving treatment. Next. So we've got some limitations for the kind of the early warning scores. The one I'm talking about is called the adult early warning score. We've got a separate early warning score for pregnant women and a separate early warning score for children, 16 years or less. And it's not appropriate for people with high spinal cord injury. So when we have the kind of, that's the threshold we have for the early warning scores. Scores of 0 to 4 are considered as low risk. Kind of 5, kind of 1 score of 3 is considered as low or medium risk, could be urgent ward-based, normal kind of, the nurse kind of would kind of see if there's anything that could be corrected immediately, or if the kind of the patient has got to be seen by a doctor, usually kind of one of the junior resident, one of the resident doctors, maybe first or second year, kind of resident doctors to see or we call that foundation year 1 or 2 doctors. But when scores start going to 5 and 6, we need somebody a bit more senior, like a registrar, or if we're talking about score of 7, maybe kind of a registrar with some experience or somebody who has got experience for airway, critical care outreach team, or kind of critical care outreach team. Anybody scoring 5 or above as well will need a critical care outreach team. And all those patients, they kind of, any urgent impairments are corrected and they still get ABCDE done. Next, please. So that when we get, that is just kind of part of the trigger kind of thresholds. We know that anybody kind of, so patients who score 0, kind of patients who score 0, normally those are very stable patients, but I work in the acute medical unit. So any patient who gets admitted within the past 48 hours, they usually get their vital signs done every 4 to 6 hourly. So if patients are stable, they are ready to go home, or they're just waiting for a social issue, they could get their vital signs every 12 hours. Patients scoring 1 to 4, minimum of 4 to 6 hourly. You know they could get monitored every hour if there is any concern, or if there's one parameter that is scoring 3. Anybody having one parameter of 3, we know that the patient has got to be monitored a minimum of an hourly. Patients having a 1 parameter of 3, normally we expect that they will be seen within an hour by the resident doctor. Anybody scoring 5 or more will need to be kind of monitored at least hourly, and will kind of need to be seen by one of the doctors or a senior team member or from the critical care outreach team within 30 minutes. Scoring anything above 7, kind of continuous monitoring of vital signs, and kind of hopefully should be seen within 15 to 30 minutes. Okay, so this is how the early warning score chart, the monitoring chart looks like. I'm going to show the other, the other slides so that it will be able to show bigger. I might just kind of raise the booklet. This is what it looks like. The adult early warning observations chart. But I'll put the microphone down for a moment. Okay, are we happy? So that is what it looks like. So if we go the next slide, I just kind of, so if you look at the way the physiological parameters are arranged, you get airway and breathing, kind of, you've got circulation. And did you notice that by the sides, it has the scoring, kind of in the center, we have the scoring. So anybody scoring with a respiratory rate of more than 25, they're scoring 3. Anybody scoring a respiratory rate of less than 8, they're scoring 3 as well. And then you've got normal between 12 and 20. Are we happy with that? Okay. And kind of, although if you look at, there are 3 boxes that score the same 0, but the reason you get it there is for a reason, in that if patients are deteriorating slowly, you could see that as a kind of a trend, and that you've got to start thinking of taking action. And that is why kind of a nurse could decide that a patient who may be scoring only 2, if she thinks that there is a trend on the way the patient could be deteriorating, they could kind of request some treatment or some action, and the patient could be reviewed much more frequently. Okay, next. So that is the kind of the blood pressure and pulse. Okay, next, please. And we've got the disability, which is level of consciousness, and the kind of external this thing. We go to the next one. So with the airway, kind of, you've got to ensure that the patient's airway is okay, patient is breathing. If you say, how are you? And if the patient said, I'm doing fine, of course the airway is open, that's good. High respiratory rate is often associated with breathlessness, but high respiratory rate is important to know that it's an early warning sign for a deteriorating patient, and it accompanies many illnesses, especially if the patient is not doing well. The respiratory rate abnormalities are important predictors of respiratory or cardiopulmonary arrest. Rates less than 12 or greater than 25 are associated with high mortality rates. Fast respiratory rates, you've got things like pneumonia, obstructive or restrictive lung disease. I may not necessarily be going through all of that. We've got diabetes ketoacidosis, hypoxia, heart failure, kidney failure, metabolic acidosis. All of that will make the heart rate go fast. I'm sure we're all aware of that, isn't it? Okay. And when we start talking of slow heart rate, we may be talking about opiates or kind of too much beta blockers or some CNS disorders. Okay, so that was just kind of, I got that from one of the training books on the acute life-threatening events, recognition and treatment. It's just to kind of give you an idea of what the severity of an increasing heart rate is. If you look at the kind of the lower area where you've got the mortality rate is between 5 and about 7%, the respiratory rate is between 12 and 20. Once you start going above 21, the respiratory rate goes significantly steep to 15%, going to 20%, even going up to 35% mortality with a respiratory rate of 34. So, and the respiratory rate very low. The mortality rate is about kind of 8, kind of just a respiratory rate of 10, having a mortality rate that's about 15, and a respiratory of 12, having a mortality of 5. It's something to realize that it's something you've got to act on quickly, otherwise the patient will have poor outcomes. Okay, so oxygen levels I've already told you about for patients in hospital, and we've talked about the patients who've got COPD, it's 88 to 92%. Very often, if patients come in acutely unwell, they may have a history of COPD. If we do not have any knowledge or evidence that they have COPD, they will normally be put on normal oxygen and try to get their oxygen sats level, kind of oxygen, arterial blood gases, to be able to know, is it type 1 diabetes, is it type 1 respiratory failure, or type 2, or kind of, should they be continued on that level of oxygen? So, and we know some of the causes of low oxygen, isn't it? Pulmonary embolism, pneumonia, and stuff. So we're going to start with the first case, and I took this case directly from the kind of e-learning app. So we've got a young man, he's 24 years old. Has anybody been able to download the app? Anybody? So if people haven't got the app, we may go back to I think we may be able to go back to one of the pictures. But the respiratory rate of 20, is that normal? Good. Oxygen sat of 91. Are you happy with that? Good. So can anybody suggest how much we may score that? Anybody suggest how much we'll score an oxygen sat of 91% on air? No, 3. 3. That is severe. That's hypoxia. Okay, the patient is not on, the systolic blood pressure is normal, pulse, conscious level, temperature. So in total, how much does this patient score? Can we go to next slide? So in total, this patient scores 3. Where does 3 fall in? What color did I say 3 was? So 3 is a red score. It means something has got to be done. So what would you consider doing? What would you consider? We just need one person to answer. Somebody, what would you consider doing for a patient with an oxygen of 91? Give oxygen, isn't it? But you give it's a young man, he is talking, he told you he's got pain, so we know his airway is open. So one of the other things we may want to think about, he's had an accident, he's having pain in his chest, his oxygen is low. What kind of things would be going through your mind? Could we just take it around so we get somebody to answer? So the man has had he's talking of pain in his sternum, his oxygen levels are low. What could we think could be causing such a low oxygen level? Yep, somebody's hand is up there.
Doctor, I would think about a pneumothorax.
Exactly, that's the first thing we should be thinking about, a pneumothorax. And so if we're thinking about a pneumothorax, that implies that we want to do a chest X, isn't it? But we should not delay a chest. We should make sure we give him an oxygen before we start waiting for the chest X-ray, isn't it? Thank you. So next slide. So because the patient scores 3, the patient has got to be actioned, and the nurse is going to make sure that some action is taken. Next. So patient has had an oxygen. We've talked about that. So we know that is 3. Patients will be given some oxygen, and then we're going to book for a chest X-ray, but patient has got to have a full ABCDE. And when we do the full ABCDE, we may find that he's got some fractured ribs, isn't it? We could find even frail ribs. He could have a big hematoma, and we may want to do his arterial blood gases because that could tell us that he may need more oxygen than we think. So next, and we'll have to give him some analgesia, isn't it? Good. So some of the effects of hypoxia is that hypoxia could reduce with hypoxia, when patients have got hypoxia, the heart will have to beat faster to be able to correct, so that oxygen gets into all the tissues. And sometimes the heart will have to beat faster because hypoxia will cause metabolic acidosis. The heart will be beating faster to get, are you hearing? To get the oxygen through and get things going. Very hypoxia could lead to cardiac arrest. If the kidneys are not getting enough oxygen, they are not going to function well. We're going to get retention of creatinine, acid, salts. That could lead to acute kidney injury. Likewise, the brain, the patient could have altered mental state, agitation and stuff. Also, high carbon dioxide levels could cause acute confusion. And it's important to know if it's type 1 or type 2 because it could determine how we treat them. Arterial blood gases will aid this decision. And hypoxia is known to cause cardiac arrest. Treat proactively. It's also important to know that in young people, they have a lot of reserve. Young people will not show very high warning scores initially. It takes a long time for young people to deteriorate. Okay, could we go to the next one? Okay. Which one is that? It looks as if you've missed one. No, next. So we've got the second case. So we've got a 55-year-old lady. She's coming into hospital because she's been seen in the medical ward because she's having a cough, productive phlegm, and we think she could have a community-acquired pneumonia. So we've got a respiratory rate of 26. Wait, how many people were able to download the app? Okay. So we've got a respiratory rate of 26, oxygen sats of 95. The patient is not on any oxygen. The systolic blood pressure is 111, pulse of 104. Patient has got a temperature of 38, and patient is alert. It's scale 1 because the patient is not known to have COPD, scale 1. I have only 15 minutes. Have I talked for 30 minutes? Oh my goodness. Okay, so how many people have got an answer? Show me with fingers. What did it score? Okay, we may have to go to the next one. We kind of just go. So that is the whole score to kind of respiratory rate of 26. So that scores 3. Oxygen sats of, was it 95? Yeah, so that scores 1. Kind of the pulse of 104, that scores another 1, isn't it? So what's the total? It's 5. Could you go to the next slide? So it's 5, isn't it? So it's scored 5. So it's a serious matter because we said anybody scoring 3 in one parameter is a serious matter, or in total of 5, it's a serious matter, isn't it? So we are concerned. Would you be concerned that this patient is at risk of having sepsis? Yes, well done, because the guideline says anybody scoring a total of 5 and they have anything to suggest an infection, you should consider sepsis. Next, please. Next. So we know that the patient will have to be monitored every hour. Kind of a registrar will have to see the patient within 30 minutes, isn't it? Are we happy with that? Okay. So, and next slide, please. Okay, so we talked about circulation, and we know that a blood pressure of less than 90 is not good, and it's a red score. Next. So hypotension is very often a late sign in acute illness. It's a sign of a compromised circulation. The circulatory system is occurring as the body's compensatory mechanisms to maintain hemostasis begin to fail. Patients will often have an increase in respiratory rate and tachycardia prior to a drop in their blood pressure. If you talk about preload, patients who have vomiting, diarrhea, or kind of acute bleeding, they could have low blood pressure, likewise sepsis. Patients who've got acute heart myocardial infarction, they've got some very fast arrhythmia, massive pulmonary embolism, and heart valve dysfunction, they will have low blood pressure as well. And likewise, patients who have kind of afterload problems with kind of significant vasodilatation, they will, like sepsis and anaphylaxis, they will have a low blood pressure. And so, you know that some of the complications of low blood pressure, we've got acute confusion, acute kidney injury, angina, myocardial infarction. And so kind of, it's important you find out what is causing this hypotension and treat it appropriately. And if patients are scoring 3 on hypotension, it's important you start thinking of getting the outreach team and a senior resident or the consultant to see a patient. So that is, now we're going to the next circulation, that's the respiratory rate. And we know that heart rate greater than 131 or less than 40 patients is at very high risk of cardiac arrest. Okay, next. So for circulation, so we know some of the causes of tachycardia, isn't it? We know about fever, sepsis, pain, hyperthyroidism, cardiac arrhythmias, and fever, and some drug toxicity. And bradycardia of less than 50 scores 1, but kind of, did you notice something odd? A heart rate of less than 40 scores 3. So likewise, bradycardia, you could get it in hypothyroid and hypothyroidism. So can we go to the next slide? Well, am I making sense? I'm trying to kind of introduce what we do. Does it make sense what I'm talking about? Okay. So we've got this other patient. This particular patient is not very well. This is a 72-year-old patient who was visited by the district nurse. District nurses work in the primary care sector, and the patient has had a urinary tract infection that's been going on for up to 2 weeks, and she's not doing well at all. So I'll just, as I read it, can I get people to kind of see if they could score them? Patient has got a respiratory rate of greater than 25, which is 29. What does that score? 3, very good. Oxygen sats of 95. No supplementary oxygen. Systolic blood pressure of 85. It is less than 90. Where would we put that? Are we all happy? 3. And then the pulse of 115, that would be 2. And conscious level, patient is confused. Where would you put that? Patient is confused. Where will you put that? 3, well done. Patient has got a temperature of 38.3. Where will you score that? It's 1. Okay, so if we go so we've got that there, if we go next, okay, that's fine. So this patient scores 13. Will you be worried? So will you be worried? Very worried. Where do you think we should be thinking of if the patient is coming from home? So the district nurse is going to call the ambulance team. Where do you think the ambulance team is going to take this patient to? Resuscitation. That's the resuscitation room. So that is where the patient is going to, resuscitation room. And all they need to phone is, patient is scoring 13. In 2 minutes, a bed will be ready, okay? So the patient is going to, so it's a medical emergency. We've got sepsis. There will be A, B, C, D, E. Patient is scoring plenty of red scores, isn't it? So prompt and proactive treatment. So this particular patient is likely to get oxygen straight away. We'll get IV fluid straight away. I'm just going to show pictures of the sepsis protocol. I'm not going to talk about sepsis because that is a big topic in its own right. So next slide. So that is what the sepsis screening tool in our hospital looks like. What I want to impress on you is the fact that it says that anybody scoring a news of 7, you should be thinking of sepsis. Or anybody scoring a score of 5, of which there is a score of 3, or evidence of a confusion or significant deterioration or infection, think sepsis. So that is what it is. So such a patient would have triggered straight the sepsis protocol. And the next page, so that is okay, and the next page, so, and we've got the sepsis 6 that we use giving senior consultant involved, giving the patient giving this patient oxygen as the patient needs, IV fluids, all the bloods that should be done, cultures, antibiotics within an hour. Okay, and there is monitoring as well. How often should we be monitoring these patients? How often should we be monitoring the patients? Continuously, exactly. A patient should be monitored continuously. So that's fine. So hypotension, I thought we've already talked about this slide. Sorry, it's a duplicate slide. Move on, please. So we've got the the conscious level, we've got the alerts, where the patient is alert, knows where they live, know their name and everything that's going on. But then we have the confusion. Patient can still be alert, but be confused that they may not know their date of birth. They may not know they're in hospital. They may think that they may just think that they are in Douala when this is in Yaoundé, even though they stay in Yaoundé. So we've had some of the this is not an exhaustive list, but it just tells you some of the things that could cause confusion, like stroke, seizure, trauma, meningitis, encephalitis, brain tumor, history of dementia. And we could get other secondary causes like hypoxia, if a patient has got infection, hypoglycemia, hyperglycemia, or the blood pressure is very low, or some medication, or if the patient has got uremic encephalopathy from kidney failure, or ammonia from hepatic encephalopathy. Likewise, if patient has got a high carbon dioxide level in their blood. Next, please. I'm almost done. I think I've got just a few slides left. So normally, it's good to expose the patients because E is for exposure, so that covers the temperature. So you take the temperature, you know that if it is less than 35, patient is at increased risk of cardiac arrhythmia and death. Temperature rise is a common marker for infection, though as we saw yesterday when Dr. Manka presented, that patient was quite very ill. Patient was septic, but patient didn't mount a temperature. And as I said, we've seen that in ill patients. We've seen that in patients on immunoregulatory drugs. We may not be able to mount a temperature. And so we talked about full exposure. We may be able to see some non-blanching rash that could tell us patient has got meningitis. We could see a big bruise. We could see something that could tell us that this is why this patient is unwell. So I'm just thinking, I'm going to do a quick I know I've got just 5 minutes left, isn't it? I'll give a quick talk because I just wanted to show you people how we use the ABCD stuff in assessing our patients. So we've talked about Peter. He's 68 years old. He's been in hospital for 3 days with fever, shortness of breath, cough, and a productive cough. He's got a past medical history of hypertension on amlodipine 10 milligrams. He's a non-smoker, drinks just about 10 units of alcohol a week, retired civil servant. His vital signs show a respiratory rate of 18. And some people try to calculate respiratory rate of 18, oxygen stats of 94 on room air. His pulse is at 92. The blood pressure is 106/60, and his temperature is 37.8. Oh, I put the early warning score there. So the early warning score is 3. Are you all happy? Okay, so patient is sent to the kind of the same day emergency care unit. So patient normally in the same day emergency care unit, we can treat the patients there, observe them for 1 or 2 hours, send them home. Okay, next. So he's been to the same day emergency unit. He was able when he got there. Then an hour later, the nurses realized that he did not look very well. His breathing was fast at 24. His oxygen stats had dropped to 93. On air. He didn't have any cyanosis. He had some crepitations in his right lower zone. And the circulation showed a pulse of 100. Blood pressure had gone down to 96/54. His capillary refill time was 3, and his his hands were cool because the nurses had told the doctor that the patient is not doing fine. So the doctor had gone to see the patient. On the disability score, patient is alert. The glucose level is 6. Pupils are normal reactive. Patient is having pain in the right side of his chest. Temperature is 38.3. He's got mild dehydration, no lymph nodes, no edema. His calves are normal. There is nothing to suggest a deep vein thrombosis. His skin is fine, nothing to suggest meningitis. We know this patient is unwell. Patient has deteriorated quickly, okay? So I thought I put this one that. So if we have to calculate his early warning score, if somebody could people who haven't got the app, if they could count there, what do we get? 9. Yes, the patient has got 9. Thank you. So are we very concerned? Can I see a show of hands? Anybody who is really concerned? Yes, consensus. We are all very concerned. Next. And we have to act quickly, isn't it? And do something, okay? So we know that this patient is on the red zone at the bottom there, continuous monitoring, vitals. Who would you want to call if you were the nurse? The critical care outreach team, the senior reg, isn't it? So we'll make sure that the patient gets some acute care. But while you're doing that, is there anything you can do to start helping? Is there anything you could do to make things better? Anybody wants to take the microphone? Is there anything anybody will want to do? Boniface wants to say something. Good. So we know that that's on board. Next slide. So we've so patient has got hypotension, tachycardia. Patient was seen by the consultants. So patient had some oxygen, 3 liters. His saturation went to 97%. Patient had IV access, blood cultures, electrolytes and urea, CRP, lactate were done. Then patient was given IV fluids, 500 mils of saline over 15 minutes. The blood patient was reassessed. Blood pressure had improved. Patient had IV antibiotics as per chest sepsis protocol in the hospital. Patient had some IV paracetamol. Patient had continuous monitoring and reassessments every 15 minutes. Patient had the second lot of IV fluids. The blood pressure came up to normal levels. Next, please. Next, please. Okay, so some of the discussions so patient did quite well. So patient was being observed. Patient was because the consultant was there, and although the critical care outreach team were alerted, the patient did not go to the critical care outreach team because an hour later, patient was stable, patient was doing much better, patient was admitted in the ward. So patient did not go to ITU, so that was a bed saved. So some of the things we were talking about is that trends, look out for trends, pointers to that would signal the likelihood of deterioration. If the respiratory rate was 12 on admission and it's going after 4 hours, it has gone to 20, you should start worrying. Is there anything that's going on? So just saying it's 0 for respiratory rate. If the respiratory rate is 18 and the patient is making an effort to breathe and using accessory muscles, you may have to think there's something not going on right. If the blood pressure is going down, you may have to start thinking, or the heart rate is going towards the upper limit of normal. So patients could be well, even with an early warning score between 1 and 4. And I just wanted to say that you've the early warning scores are not be all and all. You've got to use clinical reasoning and clinical judgment with it, as well as the normal history, nation, A to E assessments, as well as the other things to medication and stuff like that. As I said, you have subtle changes, and it's those little subtle changes that add up to create patients who get very unwell. So you kind of, I just said, that is just an example from the course to show you what trend. The patient came in respiratory rate 18 to 20, SATS was fine. Nobody kind of bothered about anything. But within 4 hours, you kind of, did you see how things started going down? And if nobody does anything, if nobody noticed that some trend was happening, the patient, although the patient had only 3, it's important that you may want to do something, because if nothing is done, look at what happened. Kind of within some hours, kind of, what time was that? Between 2 a.m. So kind of that was about 4 hours? 4 hours later, the respiratory rate has gone up from about 21 to 25. That's caused a 3. And the oxygen sats has dropped a lot. So there's a problem, isn't it? So I just wanted to impress what it is to look at trends. It's not just about saying it's 0 or just 1. So an early warning score of 3, though it may look non-threatening, could kind of signal that there's trouble. I'm almost done. So kind of go on, we're almost done. So I just wanted to show you that this is what the chart looks like when the nurses feel them. This is what it looks like. If you look at that patient had a pulse, that was very high. And if you look at when the pulse was going quite high as on the red side, the blood pressure was dropping as well. Patient had temperature. So it just it gives an idea of what kind of the early warning scores look like. And anytime the patient scores anything that is on the red, the nurses will take an action. The next one, I think I'm almost done. So I'm not going to go too much about this. One of the things I might want to say is somebody who is known to have hypertension, if their usual blood pressure is 140 to 150, if the blood pressure drops to 110 or 100, because it's a 40 millimeter drop in their blood pressure, their kidneys may not perfuse, reduce urine output, and they could develop acute kidney injury. If somebody kind of came in with oxygen sats of 93, and you gave 2 liters of oxygen, initially the oxygen sats went to 95. If after say two hours, the oxygen sats again drops to 92, and you're now giving 15 liters of oxygen to maintain the oxygen sats at 96 or 96, you have to start worrying. Are you dealing with a big pulmonary embolism or a worrisome chest infection? You may have to take action. So although the oxygen will always score 2, whether you gave 2 liters or 15 liters, you've got to realize that you're having a trend in your oxygen administration, isn't it? So, and you have to monitor the urine output. Urine output falls under circulation, because if you look at, if the blood pressure is low, the urine output will be low. And I'm sure all of us know how much urine output we expect per hour. 0.5 mils per kilogram. Are we all happy? So somebody who is weighing 80 kilograms, we expect 40 mils of urine per hour. Are we happy with that? So, and also it's important to know that if we get we make sure that sometimes even just telling the patient, encouraging the patient to drink plenty of fluids, monitoring the urine, if you tell the patient or the family will cooperate. Because if they know that if the kidney function is good, they stay in hospital less, they spend less money, they are going to do it. And that could give you an idea what's happening to the blood pressure, because if the patient is not making urine, it just gives you an opportunity. You have to review this patient. There's something wrong with this patient. And it's also important to know that when patients are very unwell and they're taking blood pressure medicines, their blood pressure is less than 115, you should consider withholding their blood pressure medicines. For older patients, if their blood pressure is less than 130, their blood pressure medicines are withheld. Likewise, non-steroidals, diuretics, and ACE inhibitors. Look out for any limb weakness or any other neurological signs when you're doing your ABCDE. So, summary, I just want to try to make sure that I impress to you people that I think there is a place for national early warning scores in the management of patients in every setting, whether being it a developed country or a medium income country or whatsoever. I think there is a place for a national early warning scores, because it gets and I think it works best if all the nurses, all the doctors, all the clinical support workers and ex-soignants are all trained. I'm not expecting them that they'll get this level of training. The ex-soignants should be able to pick up that this is a red score, a total score is high, and patient is acutely confused, and get the nurse or the doctor to know. That is what is most important for their remit. And if you do the the cost, you'll see what I'm talking about. Lots of the other things we're discussing were additional things to make the the teaching appropriate for the occasion. We know about better outcome, fewer ITU admissions, and It's not expensive. It's affordable, isn't it? Can I see a show of hands for people who believe that it's affordable? Any show of hands for people who believe that it's something they may want to consider? Thank you. And I'm sure we'll get some lives saved. If at all we get 1 or 2 lives saved, I'm sure that I think I would have done my job.
Amazing. Thank you. Okay, come and have a seat, Dr. Beho. Do we have any questions for Dr. Beho? We have time for, let's say, at least 3. Yep.
Thank you so much, Doctor, for this brilliant presentation. I just wish to know, at what level are we going to implement this? Considering that in most hospitals, you have the vital signs room where you have mostly the low-level nurses like the nurse assistants who are taking the vital signs. And we also have hospitals where you have admissions being done. And in the ward, you have the head nurse and you have other nurses who are rotating inside there. And you have the physicians. So is this just going to be implemented at the level of the vital signs room, by the head nurses, by the physicians, or at what level can we arrange this for us to make implementation and better outcomes realized?
Thanks, Mr. Bonnie. So what I'm saying is the early warning score can be a I think it's a training that should be for everybody. The reason I'm saying it should be for everybody is if the people who are the aides-soignants and the clinical support workers, if they are recording vital signs and they do not know the implication of a red score, then action may not be taken promptly. So that is delaying care. So if everybody knows at least the basics about the red scores and the total scores and how to escalate things, at least that is good enough. Because then we're going to pick up patients who are likely to deteriorate. I said the signs are subtle. The young people will hold on to their blood, their pulse and respiratory rate, and they may take plenty more hours to deteriorate than an old person who is ill. An old person, the heart rate will start going up quickly and stuff. But for a young person's blood pressure to drop, they are very, very ill. So I'm thinking if we can pick up patients early, we treat them early, they stay shorter duration in hospital, that is a win-win for all of us. And the reason this presentation is happening, and I'm not talking about any one particular disease, is how can we support? We have plenty of patients with chronic medical problems, the diabetes, the obesity issues, and we've got the hypertension. They are all at-risk patients to have complications. If we can treat them better, we get better outcomes. So what it is I think it can be implemented. I think the way it is getting everybody empowered. I know you're a senior nurse, if you empower everybody in your team, I think it will be a big strengthening of the whole team.
Yep, happy with that, Mr. Boniface? Perfect. Just behind you, the lady in red and black.
Okay. Thank you, Dr. Bero, for your presentation. I'm Dr. Elise. I'm biologist, researcher. Please, your presentation we're very, very interested. But I wanted to know if you have some technique for a researcher like me who is in his laboratory to measure, to search, for example, the inflammatory marker to that may be target for in the reduction of inflammation in some disease like COPD, like arthritis. I wanted to know if news can help us like scientists in our work. Thank you.
Sure. So thanks. There's a slide I was hoping to put on the screen, and somehow it got missed. On the slide, I'll answer your question in a moment. Velma, I'm just wondering, there was a slide I sent, an isolated slide that showed the there was an isolated slide I sent that talked about the mortality. If I find it, we'll put it it talked about the mortality where patients who had an early warning score of less than 5, they had a mortality of about 5 or 7 or 6, while those who had an early warning score greater than 9 had a mortality, 30-day mortality of 25%. Those with an early warning score of more than 9, they had an ITU mortality of 35%. because it was an isolated slide. So what it is you could do a research like the one I want I thought it was going to be on that slide, but I'll try and make sure that we put it at some point, because then you may be able to do some audit or some research to find out that patients who scored high on the early warning scores, what were their outcomes? This particular news thing was not to talk about their inflammatory markers, was just to talk about the severity of the illness and how that impacted on patients' outcome and mortality.
Okay, that's good. Any more questions? The lady, can you come and take the mic? Lady in purple.
Thank you, Dr. Bego, for your expose. So I don't know if they can call the warning score, they can consider the early warning score as good practice.
Yeah.
And secondly, I don't know if there's any manual in order to train staff in some public health institution.
Yep.
Thank you.
So what I said is kind of on the, I think on the fourth slide, it showed if you go to the Royal College of Physicians, the National Early Warning Scores 2, if you have you work in a hospital, you're a nurse or you work in you teach nurses, you could log in. It's just that you're going to pay equivalent about 4,000 francs. You log in and you could put it up and use it as a training tool for all the students. The only difference is you are the only one to get the certificates, but they can go through the training over and over and over 20 times. So all of them will get the training, but if all of them want to have certificates, all of them will log in. At some point, maybe they're during the break, I might log in and some people could see what the modules look like. And I'm sure all of you have gone, you're going to pass the modules without blinking. So it's easy, so there's a training manual, and you can order the books through the Royal College of Physicians. They do not charge for it. All they say is, if you want to order and print copies, you've got to acknowledge that you got it from the Royal College of Physicians. And you've got to it has to be colored, not black and white.
Okay, the lady in green.
Thank you very much for giving me the floor. I just want to appreciate the presentation. It was very educative.
Mm-hmm.
We all know that in emergencies, we need to act fast, and we need to act. We do not need to send in patients to the lab to do this and that. We should concentrate first because we want to alleviate distress. And I think this approach is very welcome in our context, where we can contextualize this approach and get everybody, as you earlier said, to get acquainted with this course. Mm-hmm. But then we can categorize it, and maybe for the nurse aides, we can use colors. For that, we can, everybody at its own level can be able to determine what is the alarming signs. Will go according to the different cadre of professionals.
Yeah.
That is my little contribution. Thank you.
Yeah.
Okay. We have time.
Yeah. So when you go to the course, all it says is like early warning score of 3. What are you going to do? The nurse will take action, patient will be given oxygen. So that is where it ends. And then you go to the next case. Early warning score of 5, patient has got infection. How often do you have to monitor the patient? Which are the people you need to inform? So you say, okay, the answer it will come. So if you choose, you got the answer right, that is 3. Then it will say you got the answer that was 5. Then it will say how often would you want this patient being monitored? And then you're going to say at least every hour. So they did not go into all those details about me talking about pulmonary embolism, about causes. Though I will tell you that on the course, what happens is when you go to things like blood pressure, you get one of the nurses comes, they're teaching you how to take the blood pressure, and then they talk a little bit about some of the causes of high blood pressure, some of the causes of low blood pressure, but they didn't go too much into the treatments and A, B, C, D, E. No, I made it because we've got residents here, we've got senior doctors. If I just pitched it at the level of the junior nurse, I think it would have been unfair for you all. Is that okay? So the way they've put it and lots of the videos and things, if I had to put the videos, it would take about 1.5 hours just going through the video. So So part of it is it's just kind of the level at which they have pitched it. It's not complicated.
Okay. That's great. So one final question.
Yeah.
To the gent. Oh dear. Okay.
So
two short questions. Two final last questions.
Yes, please.
Okay. The gentleman in the suit had his hand up, in the grey suit. In the grey suit, the gentleman in the grey suit. Then we'll give it to the
C'est
lady.
pour demander, est-ce que dans le cas de sepsie, comme avec déstabilisation des paramètres hémodynamiques, on va mettre certains médicaments pour lever l'urgence. Est-ce que la mise de l'antibiotique la mise systématique de l'antibiotique est idéale?
Bien sûr. Dès que tu donnes ça pendant une heure, environ une heure, is that the right sentence?
Yeah.
As long as you give it within an hour. So that is why I put up the sepsis protocol. So anybody scoring 5 and above, fever, signs of infection, the nurses will automatically trigger the sepsis 6 protocol, and they start doing things kind of proactively. But that doesn't stop them from giving the patient oxygen, giving IV fluids. But if you see, I said, they put a cannula, you're taking blood, IV fluids, IV antibiotics. Very often we'll give the kind of 500 mils in 15 minutes. By the time they're giving the 15 minutes, the nurse is preparing the antibiotics. So by the time the fluid is gone, the antibiotics will be going in. Is that okay?
Perfect. Okay. And finally to the lady.
Merci, professeur, pour votre présentation qui nous a beaucoup édifié. Je voudrais tout de même savoir pourquoi est-ce que l'application ne tient pas en compte des cas d'élévation de la pression artérielle diastolique, même si elle est isolée et qui pourrait conduire à une altération de la précharge. Merci.
So what's happening is lots of the patients who come in acutely ill, the majority of the patients will have blood pressures that are dropping. So we can see, we kind of, on the early warning score, I noticed that kind of the way they went and put the early warning scores, I did not write it up. That is why I just got it from the official documents, kind of, I didn't have to change anything. So what it is a kind of a blood pressure of greater than 220, that is hypertensive urgency, will trigger. But what's happening if a patient who is normally not known to have high blood pressure comes in with a blood pressure of 180, it has to be treated, isn't it? Or the patient is coming in with a blood pressure of 180, is having a headache, blurred vision, and stuff. You've got to be treating it as a hypertensive urgency or emergency even. So the track kind of, but that is going to be treated as a hypertensive emergency, which is one of the talks you're like here this afternoon, so I do not want to get into that. So I just focused on what we will see 90% of the time. So very often you get hypertensive emergencies coming in as a pathology on their own on admission. And the track and trigger, it follows on the patient while they're in hospital and see how they're doing. Okay? Thank you all, yeah.
Lovely. So on that note, I'd like us to give Dr. Beho a huge round of applause.
Thank you.
Thank you. Excellent. And just really to add probably a discussion for another time, is that what Dr. Beho has just really spoken about is what actually helps me as a doctor, as a primary care physician. So if I have a patient in front of me, I'm manually calculating that score. I'm not in a hospital where I can start some of these life-saving things immediately. Of course, I have oxygen in my office. I have IM antibiotics if I absolutely need to. But what this early warning score will help me, as I said yesterday, is that if I'm getting one above 6, 7, 8, if I pick up the phone and I tell the ambulance person that I've got a score of 6, 7, they'll be in my office in 7 minutes with a blue light ambulance. I understand that might not be a luxury we have here, but I guess those of us that are seeing patients in our clinics where we're not really close to a hospital, that it might be something that you should try and put into your practice. We have it on the app here. We were just calculating it. I was calculating it. When you get the answer on the app, it tells you what you need to do. Because sometimes we have patients, we have lots of patients that we're seeing, and sometimes you might not realize that a patient is very ill, you know. So when we've got those numbers in front of us, we have them for a reason. And these kind of scores, I mean, this is not even new. You say this is not even old. It's something new. It's something quite recent that we were thinking that, and Dr. Beho is very passionate about bringing it here. I don't know whether there's a similar sort of store here. Is there anything similar in any of the hospitals that we've described? So our aim is to see whether something like that can be brought in, you know, so you guys, when you go back to the hospital, you might say, we learned here in the conference about this score. Is it something that we can use? Or you have it in your app and you can just use it to make you become a better doctor. As I said, as a person who works by myself most of the time, I don't have the nurse. I'm the one taking the blood pressure. I'm taking the respiratory rate. I do that even in patients that come in. Some of them come in, they look so well. Then I'm like, oh, you've got the temperature. And it's like, oh, I didn't realize, you know, and then you realize that, especially the young ones, you're having somebody sat in front of you that is unwell that you did not realize. So it is so important, if I'm going to end her talk with anything, to say that, listen, this might look like a pointless task, you know, but it's not a pointless task. Put it in how, if they tell you to go and assess the patient, use it and say, you know what, we learned about this new thing. That patient looks well, but I think, you know, I'm worried about this number. It looks like they're scoring this thing. And that's why we're here, to kind of impart all that knowledge. Okay, so thank you again. Yes, we're doing some. Okay, so the next session apparently is mine. So if we could just have my presentation up on the screen. I'll just run through what we're going to be doing. It's not going to be more than 15 minutes. My talk is about 7 minutes, and Dr. Beho will talk after me. Then we're going to have lunch. Zenith, are they doing it after us? Are they here? Okay, we'll have a brief talk from our sponsors, Zenith. We're going to have lunch. When we come back from lunch, we're going to have a presentation, cardiological one, and then we're going to have the abstracts. And what I was very interested in telling you is all the abstract people, there's going to be a prize at the end. We didn't tell you guys, but I hope some of those from yesterday have come today. There will be a prize at the end for the best abstract. You're going to get your own certificate, some money for the best abstract. Okay. Is my presentation ready? Okay. All right then. We'll give you a few minutes. Are you ready? Which do you have hers? Do you have hers? Okay.
Yeah, let me start. Hello? Hello?
Yeah.
It looks as if you'll be getting me again. Hope you not get tired of hearing my voice. Okay, so I'm just going to talk about communication. Initially, I thought I was just going to chat. Yeah, I'll talk hopefully less than 10 minutes. So I'm just hoping that, so I just thought I'll do some bit of communication. Communication is a very tricky kind of topic, and communication sometimes varies in different areas and different cultures. So some of the things I'll talk about the communication is the SBAR, the situation, kind of a background, assessment and response. And I'll talk about ICE, which is what are the ideas, concerns, and expectations. Next, please. So that's kind of part of the plan about review and acute handover and some communication with patients. So I've already told you about what SBAR is. So kind of the why SBAR. So it's a quick and concise communication. A communication tool to effectively share information about an unwell patient. It allows communication across all members of the care team and helps colleagues anticipate the required information needed to formulate important communication to the right level of detail. So you remember when we're talking about the score of 5 and score of 7, and we're saying you've got to talk to IT and critical care outreach registrar. Those are some of the things we're talking about. sorry. So when it's about the situation, so who are you? So if you have to call a registrar is like a senior resident, or you have to call the consultant. It's important you have to kind of introduce yourself. Who are you? Where are you calling from? Check the person you're talking to. You shouldn't call and you're calling another first-year resident. That might not solve the problem. Talk about the patient age, gender, reason why you're calling. Next. And you may want to the background, you may want to give some information about the patients. When were they admitted? Why were they admitted? Are there any important clinical findings, any important medication, allergies, or important blood results? And what has happened? Has there been an acute change? Has there been a big change in the early warning score or something you're worried about? Next. So for the assessment, you've got your early warning scores, you get your A, B, C, D, E, you've got your laboratory results, examination findings, any response to treatment provided so far, what are your differential diagnoses, what are you concerned about this patient? For the recommendation, it's like, what have you done so far? Have there been any improvements? Have you got any investigations? Anything else I need to do? So I'm going to kind of give like a more so I'm going to get my phone. So first of all, I'll use my phone to discuss something. So I've in the ward, I had a patient who had been admitted. So I'm going to call let's assume I'm a first-year resident. And I've got a patient who is not doing very well, and I'm called Dr. Ako. I'm a first-year resident, and I'm going to call a senior doctor and to talk about a patient. Ring, 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 ring. Hello, Dr. Tio, is that the gastroenterologist? So I am Dr. Ako, the foundation year 1 doctor, and that's resident year 1 doctor, and I'm calling about Mr. Jones, the 30-year-old man on bed 10 who was admitted last night. He had been admitted following 2 episodes of hematemesis, and he had been taking ibuprofen, a non-steroidal anti-inflammatory agent, for about 1 week following a sprained ankle. We saw this patient earlier today. He has no past medical history of note, non-smoker, does not drink alcohol. He was stable with an early warning score of 0, and his hemoglobin was 148. His renal function was all good. His Glasgow Blanford score was 0. So I am very concerned about him, as he had collapsed 30 minutes ago on his way to the toilet. He looked very unwell and pale. He passed a large amount of malina, and he was very sweaty, and he was holding his abdomen, complaining of epigastric discomfort. So he is alert, his vital signs are not good. He's scoring 5 on the early warning score with a respiratory rate of 124, respiratory rate of 22. He's pale. His blood pressure is 105/70, temperature is fine. His venous gases show a hemoglobin of 130. He reports having 2 dark smelly loose stools, that was observed when we had to clean, the nurses had to clean him, and he's complaining of feeling dizzy. I am very concerned. He has had a big GI bleed. So I have put a cannula for him. He's receiving some fluid resuscitation. We have requested some blood from the blood bank, which will be available very soon. He's already had IV omeprazole 40 milligrams. I've requested the endoscopy on the computer system. His vital signs have improved a bit since the collapse. His respiratory rate is now 20. His SATs is 96. His pulse is still up at 110. Blood pressure is 110 systolic. He's now scoring 2 on the early warning score. Is there anything I can do? Since we know our specialist is in front there, I pretend that he's not heard what I've said. Can we get a few people, the microphones, please? I just want, are there any people who may want to suggest? Is there anything we can do? Is there anything you may want to do? Is there anything you're worried about? You people had a talk yesterday. Anybody wants to contribute something? Don't be shy. There's nothing like a wrong answer. Will anybody want to think of doing something?
Those who were here yesterday, you must have heard this presentation. Can you guys answer?
So just remember, this is a young man, and I said low blood pressure is a late sign. And this man was sweaty. He's dizzy. He looked white. He looked as white as a sheet of paper. Am I worried? Am I worried about him?
Good. Yes, somebody's going to talk.
Yeah, I think that we are worried given the amount of the quantity of blood loss, which could lead to deterioration of the patient.
You are worried about?
The amount of blood loss.
Okay.
Which could lead to deterioration of the patient.
Mhm.
So I think that it could be necessary to do a colonoscopy to be able
Colonoscopy.
to identify the cause. Oh, a fibroscopy rather. Sorry.
Right. Now, there's somebody up there. For those of you who are in training or residents, what I tell my junior doctors is, whilst you are going around with me and asking questions, is the best time for you to say whatever you think. Because if you get it wrong, I will correct you. Okay. We have a culture in the United Kingdom of training doctors. We don't insult them, because the only time you become independent is when you become a consultant. Now, if you become a consultant and you get it wrong, you'll be in trouble. But if you don't learn it properly, when you become a consultant, you'll probably be in trouble. So as a trainee doctor, it's the time for you to learn.
Okay, thank you for giving me the mic. Concerning this case, apart from what has already been done, we have seen there is a patient that is completely white, with pale and dizzy. I think I will envisage adding blood transfusion to this patient.
Yep. Yes. Oh, the microphone is coming, please.
I'm not of the doctors of today, but I want to imagine that, I don't know, maybe I ask it in a question, as in a form of a question. Maybe a Levy's meal will be appropriate to stop the bleeding.
Levy's meal is some adrenaline drink. I know we do not have it in the UK, but I heard they use it in Cameroon. So what it is that is what you do. Because the patient was completely stable in the morning, it's good you inform the consultant looking after the patient, because such a patient is at risk of rapid deterioration. And remember that that's a young person with a lot of resilience. If the patient could be so unwell, there's something going on very wrong. So I'll just give you the chance to just talk a minute or two, so they know what it is, the kind of communication they get from the senior.
Okay. Now, what they've presented to you is a patient. How old was the patient? Was a young man.
He's a young man, only 30 years old.
So it's a young man who came in with hematemesis. And when he was seen in the morning, he looked hemodynamically stable. But subsequently, he became unstable. So there has been a change in his condition. Now, the instability that we identified is suggesting that he's probably lost volume. Okay. Yesterday, when I was talking to you guys, I said the priority is to replace volume. It is not relevant what you put in him, replace volume. So that's the priority, okay? His heart rate being tachycardic is suggesting that he's not been fully replaced. Now, if a junior doctor calls me with that patient, I will tell the junior doctor that the patient is not hemodynamically stable because he's tachycardic. The next question I want to ask, Dr. Obale mentioned it, what is the Blatchford score?
Yes. So the patient's urea level came back as 8.
So if the patient's urea came back as 8, with those parameters, I have not computed it, I reckon the Blatchford score will be 7 or 8.
Yes, you're right. Absolutely.
Okay. So with a Blatchford score of 7 or 8, like I said yesterday, a patient who is scoring high on the Blatchford score means the patient needs intervention, needs some form of intervention. So this particular case will need some form of intervention. Okay.
Yeah. So what happened is the patient had the patient had some blood transfusion. You advise that you're going to contact you're going to contact endoscopy, and the patient was able to get an endoscopy. The patient was able to get an endoscopy, and patient had 2 units of blood ready while patient was going to endoscopy. So once the first one got finished, the patient had the other 2 units of blood. Patients had a bleeding ulcer that was managed appropriately in endoscopy, and patient was fine.
Thanks, Dr. Obale. I did not know the patient.
So that is why I completed it.
I did not know the outcome of the patient, but that just tells you. We talked about it yesterday. The Blatchford score tells you which patient will need intervention. And because of the high Blatchford score, you saw what they found. Had ulcer that was bleeding that needed intervention. Believe me, if the Blatchford score was 1 or 0, I will be telling the team to send the patient home because I don't think the patient needs me. Okay.
Okay. So I think I only have about 3 minutes. So we we're talking about ideas, concerns, and expectations. So what it is when we talk to patients, it's an interesting way of working in that you ask the patients what ideas they have about their condition, what kind of things they're worried about, what do they really because sometimes you may be surprised that what the patient is worried about is not what you are thinking. So it's important to give them the opportunity to tell you. We could go to the next slide to talk about what they're worried about and what kind of expectations. It's important that you make sure that you're having the same agenda with the patient. I've had situations where I'm telling a patient that, your diabetes is poorly controlled. We need to start you on insulin. And the patient goes, no, doctor, you're joking. That's not going to happen. I said, why? But your diabetes is poorly controlled. You could get complications. No, I'm a heavy goods driver. I cannot go on insulin because then I won't have a job. And sometimes you may want to find out why don't they want to have a treatment. And you've got to honor their views as well and document all of that. And then, so part of it is, I hope you people are okay with that. Let's go to the next one. I don't want to take all of Linda's time. So it just simplifies, it makes us know what the patients are thinking, and we can gauge what they expect from the treatment. And it makes us listen to the patient, take their views on board, and explain things to them. Sometimes you may be able to explain to a patient why they need to go on apixaban or warfarin because they've got an atrial fibrillation and the risk of stroke. And sometimes they may say no. They may say they want to discuss it and think about it. And maybe the next day they may decide that, okay, they're happy to go on the treatment. But you have to discuss things with patients. Are we good with that? And sometimes you still have to respect their views that they do not want the treatment. You get some patients with iron deficiency anemia, they're 90, and they say they do not want any investigation. You can't force them to have it. And they tell you they're 90, they're just happy the way they are. And so you get things like that. So I think we just have one case there. 52-year-old employed as a sorry, I typed something wrong. That man is a postman. He does a lot of delivers mails and walks about. Presents to ED with progressive worsening knee pain. And he said, I've been thinking of that it might be some kind of arthritis. My mother had this in her later years, had to get a hip replacement due to severe joint pains and limited movement. I'm concerned, I've been worrying about the impact on my work. I spend a lot of time on my feet and my knee pains, making it incredibly difficult. And the pain is almost unbearable after a full day's work. I'm hoping that you could arrange an X-ray and some other tests. Having a diagnosis would and help me plan for the future. Okay? Thank you.
Lovely. Any questions, 1 or 2, in terms of the sort of mnemonics that Dr. Beho has given us? Have any of you heard of that before, the S-bar? So S-bar is more for doctors when we're doing a handover, and ICE for when we're speaking to patients. S-bar as well. Yeah. Yeah. Have you guys, are these all strange mnemonics? They are. Do you feel that you guys might be able to use them? Do you think that they're useful for you clinically? Yeah. So S-bar. So when you're speaking to a professor like from Gachu, sometimes you pick up the phone and you'll be thinking, oh my God, you know, and you might, your brain is all mumbled and you're thinking, ah, but if you have SBAR in your head, you'd be like, what's the situation? What's the background? What's the assessment? What's the recommendation? So that kind of puts your thing into order. When you're speaking to a patient, a doctor like me and Dr. Manka, we're primary care physicians. We only have 10 minutes with our patients. We have people waiting at the door. If we don't have some kind of structure in terms of how we ask our patients questions, we'll miss it. The patient might come in with a cough and we're thinking, oh, they think they want antibiotics. But if we don't ask them what's your concern, what's the concern and what are you expecting of me? Those two things, you know, it's really, really important. And if you guys can also incorporate that into when you're taking your histories, especially when you have a short time, it will be so useful. And those of us in the UK, we have to have a patient satisfaction scores. Your patient satisfaction scores will be very high because they feel like you've listened to them, and you'll do it really quickly instead of going into one kind of thing, ordering some tests that the patient was not even worried about. So yeah, SBAR, ICE, remember those.
When you discuss with the senior consultant or senior doctor, like registrar, you have to record in the notes. Yeah, when you've discussed with the registrar, you have to record kind of the things in the notes and the decision from the advice from the senior doctor or the registrar and what was done after that. It's good that you record it in the notes. Otherwise, we'll miss out what happened.
Perfect. Another round of applause for Dr. Beho. Thank you. Lovely. You've got my presentation now. Thank you. Lovely. So mine will be very nice and short. So that's me. You guys have seen a lot of me today. I'm the president of CamDoc. As you know, I'm also a family physician. I work in Colchester Medical Practice. Colchester is a small town near London. I do other things, as you can see there, because it's nice to have a varied job. Now, I got my phone to make me that picture. That's AI for you. I said, please make me a picture of I was trying to make the doctor look like me because I didn't want to use one of my patients. And I said, do a picture of someone with blonde braids breaking bad news to a Black patient. That's what he came up with. So there. Next slide, please. So I'm to you about breaking bad news. I do a fair bit of this. As we were talking yesterday with Dr. Manka, when we were talking about oncology emergencies and how we sometimes have to break bad news to patients. So I'm just going to be teaching you about talking to you about two little models that I tend to have in my head when I'm breaking bad news. So the first one is a bit longer. It's called the Spikes models. And the other one is just a kiss. So you won't forget that one. That one's a bit shorter. So Spikes. So we'll go with what's the Spikes model? So it was published in The Oncologist in 2000. Quelle surprise. Oncologists have to break a lot of bad news with their cancer patients. And they had to have a protocol for delivering bad news to cancer patients. Next. So it's been adopted more widely and it's now used in clinicians in various circumstances to communicate difficult news to patients in a clear, supportive, and compassionate way. So S stands for setup. So you want to set it up, keep going. So think about what you want to say in advance. And you may wish to suggest to the patient that they should come with a friend or relative, specifically if it's really bad news that they might be shocked afterwards. So if they're driving, you probably wouldn't want them to drive themselves home. Next slide. So you also want to choose a time and a place that allows for privacy and quiet and considered discussion. Make sure that there's somewhere for them to sit down. And you see, we carry our phones everywhere. Try and put your phone off and things like that. If you're in the hospital carrying a bleep, keep it away so that the patient knows that they have your full attention. So if it isn't a patient that you know and you're so unlucky and they said, can't tell that patient they're gonna die next week and you've never met them, you cannot obviously just start telling them about the bad news. You have to establish some kind of rapport with them. Even if it's gonna make your breaking bad news a bit longer because it's really so important. Try and maintain eye contact. And I know we don't have time, but you must allow enough time for the patient and or their relative to express their emotions and ask questions. So for perception, so you want to know what they know. So you're going to use an open-ended question to determine what they understand about their condition so that you can know how to give the information. So because they may have already spoken to a doctor or they've already guessed that they're unwell, so it makes it easier for you. If they don't know, then it'll be harder. Check, go back, please. Check that the patient is able and willing to hear what you're going to say. So they may give you an opening to start the discussion, or they may try to avoid what you're saying. And you really need to be aware of that, because if they don't want to hear you, you might be speaking and they're not going to listen to you, and they'll just enter one ear and go out the other. Waste of their time, waste of your time. So the I is for invitation. So some of them would say they want to know everything, but some may not want to know because they're using it as a coping mechanism. If they don't want to hear the details, you can offer to answer any questions in the future. Or if they've come with someone, you can just offer to speak to their family or friend that is with them. Use language appropriate to their level of understanding. And it can help to just reflect the same kind of words that you've used. And you don't want some kind of long stage 4 ovarian non-small cell. You don't want that. Just say what it is. Avoid unnecessary jargon, euphemisms, which could impair the patient's understanding and create a barrier to communicating with you. And be sensitive to how the patient is reacting. Give the information at an appropriate pace. Knowledge, so SPIK, warn the patient that you may have some bad news so that you don't suddenly say, hello, you've got cancer. And give them, once you've given them the information, give them enough time to absorb it and ask the questions. I had a patient once, I said it, and they kind of were in shock. It was a diabetes diagnosis. They didn't say anything for a few minutes. They were a lorry driver, so it was basically they had so many things in their mind. So I just let him sit and just absorb it for a bit. If there's any doubt about prognosis, you should just explain it and give them options for clarifying any uncertainty that they may have. Give the patient information about next steps, such as follow-up appointments. Ideally, this should be in written form. Nowadays, when I'm writing my notes, in my notes, there is an option to just text the patient that I'm speaking to, and I can send them a leaflet through the phone. Everything is through the phone. So we really have no excuse not to give people information, send them the information. Sometimes I even text and I say, today we discussed this. Sometimes I copy and paste my notes and I put it in the text message if I feel that the patient might not remember. So you want to give them all that information. You should also tell them who will be in charge of their care, how to contact them. In most cases, I just say, come to me, because as the primary care physician, I know nearly everything about my patients. And if I don't know, I'll have a letter telling me who they can contact. Reassure them that you are going to be there for them. It's very easy for me. I am their doctor normally. So they know that I'm going to be there for them. And just that bit of saying, I'm here. I work here all the time. If you want to see me, you can come tomorrow. I can book you an appointment next week. This really helps them to cope and feel less isolated. In our practice, we have a cancer specialist nurse. This is for cancer diagnosis, and we have many specialist nurses that I can link these patients to easily. So if the patient has come with a friend or relative, sometimes the relative wants to know more. let's say a husband and a wife, if it's the husband that has the diagnosis, the wife would be like wanting all the answers, all the, wanting all these questions, having all, and the man might just be sitting, not knowing what to do. So in this case, I always ask the man, I say, do you want me to just tell your wife and she'll tell you at home? And obviously just check with him that he's happy. Or sometimes I even give the wife or the relative an option to come and speak to me separately with the patient's consent. Next slide. Empathy. So I think as a doctor, that's really the most important skill that we have to have, we have to have empathy for our patients, right? I know we see many people that are so unwell, and sometimes it can be just normal to see someone that might die tomorrow, or we see someone who is dead, or we see their patient, but remember to just try and have that. Don't make assumptions about what the patient is feeling. Encourage them to tell you their concerns, respect their wishes about how much information they want to hear. I had a patient come in. I needed to tell her something important. She said, I'm not ready for it. I'd booked like 20 minutes of my time to talk to her. She said, I can't talk about it today. I said, it's okay. I tried to establish why. She said she doesn't. She's feeling so overwhelmed. I said, it's all right. I tried not to judge her. Even though in my mind, I was like, oh gosh, I could have seen 2 patients in that 20 minutes. But, I said, it's okay. Go to the reception and they'll book you another appointment and you can come back when you feel ready. So we must try and show empathy. Again, when you're observing them, validate the emotions that they have. Give them enough time and space to express their reactions. All patients are different. So some of us made of strong stuff. We could be told that something's going to happen to us. We might be very religious and we're like, oh, I'm going to die next week. You're like, it's God's will. And you might be sat there very, very calm. Another one might just burst into tears. So all patients are different. So just react to people the way they've reacted with you. So spikes. So last one. Make sure the patient has understood by asking them briefly to summarize the main points of the conversation. Sometimes that's difficult, if you've told someone they've got diabetes and say, tell me what I've told you, but try and make sure they've at least understood by just asking them a few questions. Encourage them to express their concerns. Give the patient reading material, as I said. So I normally send these by text message. Suggest they write down any questions that they'll like to ask you at the next meeting so that you can be sure that you're exploring their understanding. And that was it for the spikes. So that's my preferred method. And I try to go through it like that when I'm doing a breaking bad news where I've got like 10, 20 minutes to really go through it. But some people might say, you know what, I just want a short, snappy mnemonic to use. And I found this one, which is a KISS. So A stands for anxiety. So you just want to try and elicit the anxieties. K is for knowledge. You want to know what they know. I is for information. You're giving the information, give it simply regarding the treatment and the prognosis. Sympathy, and I'll probably put empathy in there as well. So it says give human contact. It obviously depends on your relationship with the patient. I have some patients where I can give them a hug because I've known them for a long time and it's appropriate for me in that situation. There might be some that I just touch them in the hand gently or I just squeeze their hand. So you need to really, in a society like us that is litigious, you don't want someone to say that you kind of sexually harass them. So just be careful about that and obviously always ask for permission before touching someone in that context. And the last S is support. Support. Practical help, letting them know that they can reach you. As I said, for me, this is very simple, easy for me because, as I said, I'm a GP, I'm a primary care physician. So my patients have access to me. I can easily say, listen, this consultation didn't go very well today. I feel like you might need me to call you again. So I'll book another appointment with them. I'm here for you. So a KISS. So that was the second one. And I told you that my presentation was going to be short and sweet. And there we are. Thank you. Next one. Next one. Yep. So that's where I got all my stuff from. So Bradford VTS is so us that are primary care doctors in the UK, that's where Bradford VTS has all our training things about how to communicate and break bad news and things. Medical Defense Union is what a lot of us have to have in the UK. Someone sues us, our Medical Defense Union will be there for us. So they always have tips on how to talk to patients. And of course, the spikes came from that oncology paper that I discussed. That's it. Perfect. Lovely. Dr. Beho, do you want to ask if there's any questions?
Okay, then. Thanks, everybody, for holding on. Any questions, please? Is it what? Any questions? Yes.
Merci. J'aimerais poser une question de savoir, lors de la communication avec le patient, nous, moi et mon collègue, dans notre lieu de travail où on a eu affaire avec une patiente dont on devrait traiter le paludisme. Elle dit son ancien docteur de traiter matin, soir. Nous, ici, on vient, on change l'air là. Quoi? Et il a fallu vraiment beaucoup de temps. Elle a refusé qu'on la soigne jusqu'à ce qu'on appelle d'abord l'autre docteur. Et le docteur, écoutant qu'on était, on était à côté, s'il disait le faux, on allait aussi le compliquer, obligé de dire à la femme là que non, l'ancien système, parce que tu rentrais tellement le soir, qu'on a voulu te traiter le soir. Encore un autre patient qui était venu, il a un problème de malnutrition. Et on a dit à sa maman que votre enfant là, il a un problème de malnutrition. Il faut améliorer son alimentation. Et la maman a ramassé l'école de ma chemise pour me dire que elle donne le Coca-Cola à l'enfant chaque jour. Pourquoi on dit que l'enfant est mal nourri? Face à cette situation-là, vous pensez que est-ce que la communication va être facile?
So I'll let you answer that one.
Ouais, je te dis, ce n'est pas toujours facile. N'est pas toujours facile. Dr. Beo a dit ICE, right? Ideas, concerns, expectations. So pour ton patient là, son idée c'était Coca-Cola, c'est une bonne nutrition pour son enfant, right? Est-ce qu'elle était concernée? What were her concerns? She had no. Why did she come to see you? Elle n'était pas concernée. C'était l'enfant, ok. Quelles étaient les expectations? Donc, regarde, il n'y a pas quelque chose qui sera parfait. On aura toujours les patients qui vont entrer, les ice là, tous les trucs que je t'ai dit, ça ne va pas marcher. Si tu fais ça la majorité du temps, c'est OK. Mais je te dis, dans une patiente comme ça, si tu sais que tu ne vas pas gagner, il ne faut pas perdre ton temps. Mais tu dois faire ce qui est, on dit en anglais, medically justifiable. Donc, comme pour le cas de paludisme là, si elle prenait ça matin et soir et c'est quelque chose que ça ne va pas causer un problème, il faut laisser, non. Tu laisses. Mais si ça va causer du problème, tu appelles comme tu as fait, tu appelles l'autre médecin, tu dis comment? Appelle ton patient, tu lui dis de faire comme on fait ici pour donner l'autorisation. C'est comme ça qu'on fait. OK? Mais si vous l'utilisez, je te dis, ICE, ça marche 9 times out of 10. Quand j'utilise ça, quand je suis en retard. Je veux dire, non, 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 tu es entré, je vais te donner l'antibiotique. Ce n'est même pas ce que le patient voulait. Et puis, à la fin, il dit, well, doctor, I was worried about this. Et tu commences au début. Donc, c'est très, très important qu'on sache ce que le patient veut. Et si c'est quelque chose que tu peux, on dit en anglais, meet them in the middle.
Au milieu.
You meet them in the middle. Tu l'es là au milieu parce que c'est eux. Si tu dis, prends ça, tu dis, prends le médicament matin et soir, tu seras là à la maison avec eux. Elle va donner ça quand elle va donner. Donc, il faut que le patient, tu peux dire, ah, c'est comme ça qu'on fait, mais la mère, comment on peut faire? Ouais, on veut que on veut que ta fille, ton fils soit guéri. Donc, il faut faire comme ça, un peu de, tu vois, ça ne peut pas être, on dit en anglais, black and white. Tu dois,
I wanted to ask a question.
yes.
So, when you finish, so I'm just a bit concerned when it comes to children. Children are protected in England. They're more like crown property. They're protected by the state. I'm just thinking, this child, has the child got a social worker?
Social worker, c'est quoi? Béo, social worker, c'est quoi? Béo, let's stop ça. Il n'y a pas de social worker.
No, but the thing is that the child needs some support for nutrition. Malnutrition will make this child ill because if this child has got a pneumonia or chest infection, that child will be very ill.
It's a fair question. So my question back to you is, in a situation where you feel like a child is being neglected, what are the process? We only know our processes that we have in the UK. Unfortunately, I didn't work in Cameroon, so I have no idea. So in a situation like that you've described to us, you're worried that the child is just drinking Coca-Cola morning, noon, and night. What can you do? Are there any higher processes?
For nutrition.
Si j'ai bien compris la question, hein, parce que je comprends un peu, mais
Donc, la question, c'est que si comme l'enfant là, tu étais inquiète, non?
Oui.
Donc, qu'est-ce que tu peux faire? Est-ce qu'il y a quelqu'un? Parce que là, en Angleterre, on a les gens, on appelle les social workers. Donc, si je crois que la mère, quand on dit néglecte son enfant, je les appelle.
Bon.
Elle sera, she'll be in a lot of trouble. Donc, est-ce qu'il y a quelque chose comme ça au Cameroun? Je crois que peut-être il n'y a pas. Qu'est-ce que tu peux faire?
Bon, c'est moi que ça m'a surpris hein, parce que vous voyez qu'à l'hôpital, on reçoit assez de patients.
Oui.
Si j'avais su avant que sa réaction allait être ainsi,
oui.
je devrais préparer en avance comment je devrais l'aborder.
Okay.
D'abord, je devrais l'expliquer ce que contient le Coca-Cola.
Exactement.
Et ce qui manque à l'enfant qu'elle devrait apporter.
Oui.
Et là, je devrais traduire ça en son dialecte pour qu'elle puisse comprendre.
Oui.
Et ce qui m'a manqué, moi, je pensais que bon, elle était venue physiquement, elle voyait une personne qui pouvait comprendre rapidement sans avoir des arrêts pensées que bon, elle peut avoir ce genre de pensées. J'ai répondu que non, l'enfant a malnutrition. Je n'ai même pas terminé ma parole et puis ça s'est ensuite.
Donc maintenant, tu sais, s'il y a une autre maman comme ça, tu vas savoir, non? Tu vas plus faire la même erreur, n'est-ce pas?
Bon, juste que si je fais face encore à ce genre de patients, je prendrai les mesures parce que la première question est de prendre d'abord les informations
Exactement.
de la patiente.
Exactement.
La langue qu'elle parle, lui sort son niveau d'éducation.
Oui.
Et là, maintenant, je vais me positionner à lui répondre. Alors, de l'autre côté, je n'avais pas pensé à son niveau d'éducation, c'est pourquoi j'ai fait cette erreur.
Correct. The lady in green behind there, and then you, and then her, and then you, and then we'll end.
Thank you. I think in our context, in the hospitals, there are social guiding structures within the hospitals. You can refer those kind of cases when the parents cannot take care of them.
Okay.
Where they can supplement their support them, for example, because I know in hospitals you have unappelled indigents, okay? So you can refer them to the director, and they have a committee, there's a management committee that can reevaluate that case and see how they could assist them. And I just also wanted to seize this opportunity to say that the different ways of communication is very inspiring. And already we have some of these infectious diseases, HIV. A lot of people, it's the same spike, you know, how do we deliver bad news in terms of, in case of HIV? That's exactly the approach that they have trained a number of people, psychosocial workers, trained doctors, how to deliver bad news. I think it's something that it's a good practice. It's a good practice that can be shared. Maybe we need to reiterate on that and kind of capitalize and, on that approach. I think your contribution towards that is very, very pertinent, and we'll try and see, can adapt it in our context easily. Thank you very much.
Excellent, excellent. The lady at the top, and then come down here, please. Lady at the top, her hands up with a nice scarf, multicolored scarf.
Thank you very much for the presentation. I am Dr. Tia Elodie. I'm a psychiatry resident. Especially this presentation on Breaking Bad News is a really great one, and it's my first time of hearing about it, and I believe it will help me a great deal in my practice. I will just try to make sure that I integrate it gradually. Now, I have a worry. What do you do when you have a carer? Okay, let me contextualize it. You have this mother who comes to her son, is addicted to marijuana. In the US, you don't get into rehab until the patient requests. And now she wants a rehab against patient request. And so she comes back to Cameroon because it's possible here. And she tells you the first time he got into crisis, besides, he was diagnosed of schizophrenia. And she said when the diagnosis was made, he was put on low dose risperidone. It's a psychotropic, it's a neuroleptic. He was put on 2 milligrams, and the doctor said that eventually the dose is going to be reduced. Now, the difference between the objectives of that doctor and the objectives that we have now are obvious. He just wanted to maintain the patient into a socially acceptable level. And she comes with the patient and she wants us to get him out of addiction. And she equally wants us to maintain him on the medication and dosage which he came with, because she's concerned about, her first issue was a lot of tests were done before he was put on that medication, which tests she didn't present a medical file. And she's concerned about the eventual side effect of neuroleptics and antipsychotics. And you take time and explain to Mama. Okay, another thing that I forgot to say, she wants that we should do him a CBT, a cognitive behavioral therapy. Now, how do you get a patient who is suffering from schizophrenia, who has in majority negative symptoms, to undergo a cognitive behavioral therapy when he is not even able to communicate with you? He has a socially acceptable level. He feeds himself. Well, he no longer washes his hands. He doesn't care about that. But he doesn't make noise. He doesn't disturb. So socially, it's okay for her. But he doesn't communicate. You need to step up those doses and add other medications to make sure that he gets to a level where he has remission of symptoms before communication. Now, you have spoken with Mama. She seemed to understand. She gets to see that you have added doses, and she still comes and hammers. You get another colleague to talk with her. You think she has understood. She brings up the worry again.
Sorry, Claudine.
I mean, it's kind of disturbing. I don't know. What do you do in that case?
Yeah, hello,
do you
Claudine.
just let go, or? Okay, thank you.
Claudine, you're having quite a difficult case there. Sometimes there's something we call best interest meeting. You may have to get some other colleagues, kind of yourself, and maybe one colleague that may be a bit senior, or maybe the psychiatry doctor and psychiatry nurse, at least 2 or 3 other people who belong to it. The best interest meeting is that this person hasn't got capacity. And you're going to treat this patient based on best interest or what would be best for the patient's care, because the mother may not understand the complications and the kind of the whole risks about sub-treatment. And so even though she may be having her own ideas, it is not for the patient's best interest. So we have to do that for the patient. I know it's complicated. I'm using a culture from a different
Yes, but that's what we would do.
That
Yeah,
is what
that's
we
very
would do.
complicated.
That's
It's
what we
very
would do.
complicated,
Because
yeah.
the mother is dictating the patient's treatment.
And she's not a doctor.
Based on clinical experience or expertise, based on emotions, which is not for the patient's good. So a best interest meeting.
A best
would be
interest meeting, yes. Leo, wait, is there this such a thing here?
Because we give the patients the medication. Yeah, I think it's complex because I would have that after the best interest meeting, a district nurse will go there in the morning, give the medicine.
I see. Oh,
injection. I'm so sorry.
Next question.
Yeah.
Thank you for the opportunity. Thank you for the knowledge shared today. So I don't have a question, but I just want to explain something personal which confirms why it is important to really take the time to explain something to a patient. Because the way you explain something to your patient may either benefit the patient or worsen the situation of the patient. For example, some few years back, I felt a lump on my left breast. Knowing my medical history, my primary doctor recommended me to see a prominent gynecologist here I think here in Q7. I was missing this doctor for the first time based on my personal doctor's recommendation. Surprisingly, the first thing the doctor said to me was, go prepare yourself for an operation. I asked him why. He was just like, we need to operate you. We need to operate you. I told him that, no, sir, you cannot operate me. You don't know my medical history. You don't know why I'm missing you. But you're already proposing a solution. And I left. That kept me anxious for so long. And it had to be was my nephew who was then a student in Q's who calmed me down and sent me to another office, big friends who just completed school and was also specializing in gynecology. That was when I was able to calm down because this young doctor, even though he was still specializing, took his time to ask me questions. He helped me to express myself. He saw my anxiety. He took his time to calm me down. And at the end of the day, it turned out to be a false alarm.
Good.
And now I always ask myself what happened if I was a yes doctor kind of patient. Exactly. I could have gone along with the operation, which was unnecessary, possibly causing me more harm, more financial expenditures. So it is very important that you as the patient make the conscious decision to educate yourself about your health. Ask questions. A good doctor will always listen to you and try to explain things to you. And if possible, offer second opinions just to calm your fear before they proceed with your treatment. Because sometimes some treatments are just unnecessary because the doctors don't have the patience to explain. So thank you for listening and thank you for sharing the knowledge. It's very helpful.
It's my pleasure. I think that's actually That's actually, sorry, sir, we won't, oh my days, we're running so late. We have to kind of wrap it up. Sorry. You guys can come and meet me at lunch and I'll answer any questions. I think that's a very nice time to wrap it up with a personal experience of how it's really important to take your time and explain. Less haste, as we say, less haste, more speed. Exactly. Exactly. So Azinit here. Lovely. So before we go for lunch, just a brief talk from our sponsors from Zenith. I'd like to ask them to come up to the stage and give their presentation.
Uh, Good afternoon, brothers and sisters. This is Zenith Insurance. Zenith is a company owned by Cameroonians. It was created in 2005 and started operating on the 1st of November 2006. Our vision is build a modern and sustainable company that work every day for the well-being of individuals and business. Our vision, our value is humility, responsiveness, responsibility, loyalty, and professional ethics. Our mission is anticipate customer expectation and assume all our responsibility as insurers. Our team, Zenith team, consists of men and women filled with experience, motivated, and fully committed to the success of their missions. Our customers is our priority. Our commitment to quality, Zenith Insurance is ISO, that is International Standard Organization. It was certified. ISO 9001, 2015, and ISO 27001, 2013, certified. This certification reflects our commitment to offering our customers a service that meets the highest international standards. So today we are here to present our various products. Essential one is the health policy, which will be presented by Dr. Tem. So we have the other product, the insurance, automobile insurance. Whereas an individual in a company, your vehicle can be insured. You can choose the various coverages, third party only, or third party and fire coverage, or comprehensive insurance. For comprehensive insurance, we have multi-period commercial insurance cover, SME and SMIs, multi-risk, home period coverage, your business, your establishment, or your home is the fruit of a major investment. We offer a range of products to cover your assets against the following risk: fire and allied perils, theft, water damage, machine breakdown, operating loss. So we have the health insurance, and then we have the personal accident insurance, which cover against bodily injury that may occur in your private or professional life through the payment of compensation for accident death, permanent, partial, and permanent disability, medical and pharmaceutical expenses, daily allowance in the event of hospitalization. They will have travel insurance. They need to accompany you 24 hours a day on your travel around the world, taking care of you in the event of illness or accident. We also cover the loss of luggage or administrative documents with the support of interpartner insurance and MAF assistance, world leaders in assistance. We have surety insurance. We guarantee the performance of public contracts or peaceful exercise of your activities through various bonds. So we have the bid bond, the startup advance bond, have the retention bond, have the performance bond, have the professional bond, and have the financial guarantee. And they'll have construction all risk. We support you through your construction building or civil engineering projects by covering material damage suffered or caused by them during the duration of the project. We have all risk computer and electronic equipment insurance. We guarantee the smooth operation of your company's IT system by covering damage to IT and telecommunication equipment. We also provide financial assistance to cover software replacement and additional costs. Okay. So we are going to continue with the health insurance, which is going to be presented by Dr. Tem Severin. Thank you.
Bonsoir. Chers professeurs, docteurs, mesdames, mesdemoiselles et messieurs, concernant l'assurance maladie de Zénith, nous avons une représentativité dans les 10 provinces, dans les 10 régions, et nous nous occupons de l'assurance maladie des groupes et des individus. Donc, nous avons plusieurs sociétés qui sont affiliées à Zénith. Et la principale innovation en matière d'assurance maladie, ce sont des cartes biométriques que Zénith a mis à la disposition de ses clients. Ce sont des cartes avec lesquelles vous pouvez aller directement dans des hôpitaux, aller dans des pharmacies, dans des laboratoires sans pour autant passer par des bureaux. Donc, vous pouvez quitter votre domicile, vous allez à l'hôpital avec votre carte biométrique, vous êtes pris en charge selon votre taux de couverture. Il y a des clients qui sont couverts à 100%, 80% selon le contrat. Donc, ça, c'est la principale innovation de Zénith. Et nous aimerons aussi vulgariser l'assurance maladie parce que nous avons remarqué que actuellement au Cameroun, c'est principalement les sociétés qui sont, et même des sociétés qui sont un peu, qui respectent la réglementation, qui prennent l'assurance maladie pour leur personnel. Nous aimerons dire que les familles peuvent également avoir une assurance maladie. Un parent, il vient, il prend l'assurance maladie pour sa femme, ses enfants. Ceci pour assurer, parce qu'avec des temps qui sont difficiles, ce n'est pas tous les jours que nous avons du liquide, du cash pour prendre en charge nos enfants, notre santé. Donc, avec l'assurance maladie, nous prenons en charge quand vous ne pouvez pas le faire. Zénith Assurance fait également des évacuations sanitaires lorsque c'est nécessaire, des soins à l'étranger, selon votre sollicitude. Donc, nous sommes situés à Yaoundé, nous sommes situés à Immeuble et Camp au Palais des Sports. Pour ceux qui ont des questions, des préoccupations, qui aimeraient savoir comment ça se passe davantage, ils peuvent passer nous voir, nous sommes ouverts et nous sommes disponibles. Également, avec Zénith, nous avons un site Internet, donc vous pouvez souscrire en ligne et avoir un peu le coût de votre assurance, par exemple. Vous pouvez, étant chez vous, vous allez en ligne et vous avez le coût de votre assurance, celle de votre famille. Si vous avez des questions, nous sommes ouverts. Merci.
Thank you very much for your presentation. I think what we are dealing with here, I think it sounds very much like a marketing ploy. Okay, But I would like to challenge Zenith to a different approach to what they are saying. Now, we know the biggest problem of healthcare in sub-Saharan Africa is actually financing healthcare. So to pay for your treatment, that's our biggest problem. In the United Kingdom, we have the luxury that our healthcare insurance is funded by the government. So it's all included in general taxation. In other countries, like in Germany or in the United States, it's funded by insurance companies. Now, I will tell you, I was expecting Zenith to tell us how they can play that role in Cameroon to fund healthcare for the general public. So that is my first point. So if you can, we'll be very happy to hear how Zenith will support the layperson, X, Y, and Z, that when they go to the hospital, they don't have exorbitant bills. Do you understand me? Yes.
Merci, professeur, docteur. Donc, Zénith, dans ce volet social-là, pour s'occuper de la santé du Camerounais, nous, on a mis à la disposition certains produits qui ont un coût abordable pour les familles. Donc, on ne peut pas dire là que ça sera gratuit ou avec Zénith, vous allez aller plus gratuitement. Non, mais on a mis des produits avec Zénith. C'est la raison pour laquelle j'ai dit on ne peut pas détailler tous ces produits-là ici. Mais pour des familles, selon le rang social, on a des produits qui peuvent favoriser et à des coûts acceptables pour avoir des soins dans des hôpitaux. Donc, ce n'est pas gratuit, mais il y a des packages que nous faisons pour cette couche de la société.
Par exemple, ce coût, est-ce que c'est un coût que n'importe quel Camerounais peut payer?
Bon.
Ou bien, parce que le salaire moyen d'un Camerounais, c'est combien? 50 000 francs par mois?
On peut encore parler de ça.
Hein? What?
Mais moi, j'avais dit qu'il y avait ça.
Yes. Le salaire moyen d'un Camerounais est 50 000 francs par mois. Le coût de cette assurance, c'est quoi? Minimum. Et qu'est-ce que ça couvre? Minimum. On a parlé des urgences médicales. Est-ce que votre assurance couvre les urgences médicales?
Je peux. OK. Les urgences médicales font partie, c'est même la raison d'être de l'assurance, parce qu'on peut avoir une urgence et on n'a pas de cash, il faut bien qu'on soigne. Donc ça, c'est déjà même, ça fait partie des priorités de l'assurance. Et avec l'assurance, il y a lorsqu'on fait des assurances en groupe, ça permet que les coûts diminuent. Ça veut dire que plusieurs familles peuvent se mettre en groupe. Avec ce groupe-là, on aura un montant qui ne va pas revenir à grand-chose parce que c'est annuel.
Bien. À combien?
Et on ne peut pas donner le coût parce que l'assurance, ça dépend de l'âge, ça dépend du nombre de personnes, ça dépend des soins qu'on veut. Par exemple, il y a des soins dentaires, des soins d'ophtalmologie. Donc, ce sont des trucs qui se font selon ce qu'on veut. On ne peut pas donner un prix global comme ça. Et le taux de couverture également est important.
Okay, we would like to thank Zenith Insurance for their presentation. I will strongly say, that is a very difficult topic for healthcare across the world. It is not unique to Cameroon. You find that everywhere in the world. How do you finance healthcare? We have heard a lot of presentation, mostly about what we do in the United Kingdom, because in the United Kingdom, we don't talk about the costs. I will tell you when I started working in the United Kingdom and I was treating patients for hepatitis B about 30 years ago, tenofovir just came out and they were telling me to treat patients with tenofovir. And I said, tenofovir is very expensive. Lamivudine is cheaper. My consultant colleagues told me that costs is not the problem. Efficacy is the problem. Tenofovir has a resistance rate of about 33% per annum. Tenofovir has an efficacy rate of 98%, even though the cost was about 1,000 times more. So that is the difference. Now, I was trying to press Zenith for them to tell us that they will cover a certain condition for everybody. So you go to the hospital and you don't have to pay for that. So that people can go and see their doctors or see the hospital without worrying who is going to pay. Thank you very much, Zenith. There's a gentleman there who was asking a question. I've got a microphone for him. Now, listen, the gentleman asking the question is taking your lunch time. So people can go for lunch, he can ask his question. Sorry? Yes, ask your question.
Yeah, thank you very much, Professor. I just wish to find out from Zenith.
They're gone.
Yeah.
They are gone. They are not meant to answer questions. Ask them outside.
Okay, thank you.
Yes. When are we coming back? Now, I think we have 25 minutes for lunch break. So you guys make it really snappy.
So yeah, give me a fine. I'll be so proud of you. I know go waste your time. Other girls do me wrong, but you do me right. Oh my baby, make up your mind. Sugar, I did give you money, I give you love. Cause I give you love. Sweet melanin, oh girl, sweet melanin, cover your body, girl. Tell me why your boy no go cry. Over your body, girl. I say you coca body, the ball let me auntie. Oh, tell me why your boy no go cry. Over your body, girl. Girl, I go love you night and day because now you the boss my brain and I go blow your mind 44 days, 44 night and day. Girl, I go love you night and day because now you the boss my brain and I go blow your mind 44 days, 44 night and day. Yo, night and day. Yo, night and day. And I go blow your mind 44 days, 44 night and day. Yeah. Night and day, yo, night and day. Girl, I go blow your mind 44 days, 44 night and day. Sweet melody, no girl, sweet melody, cover your body, girl. Tell me why your boy no go cry. over your body, yeah. I say your coca body, the worry me auntie, yo. Tell me why your boy no go cry over your body, yeah, yeah, yeah. I go love you night and day because now you the boss my brain, and I go blow your mind. 44 days, 44 night and day. I go love you night and day because now you the boss my brain, and I go blow your mind. 44 days, 44 night and day.
Okay, we take another shot.
Dang, 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 dang. I really like to. Yeah, yeah. Oh, yeah, 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 yeah. Mm. You look your mouth, you know the walk, you don't take talking, and you just ain't talking. Every day you they talking, every day you they talking, you know the walk, you just ain't talking, my man. Every day I'm not, blow the summer night, I will be by your side, be by your side. Every day I'm not, I will be by your side. Will be by your side. You didn't do me mal addicted, but you're my brother. Oh, you didn't do me mal addicted, but you're my sister. Family day, oh, family day, oh. I want my brother go walk. If I chop, my brother go chop. Now anything I get, my brother go share with me. For me it's gold, for me it's bond, for me it's love, for me no no shame, for me no one name, for me no love, for me no no. Why got backside, we go define and more. For me it's gold, it's love, for me it's everything, everything. For me no no shame. Famina no Christmas, famina love, famina day, famina oneness. No, 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 no. Everything night, it's night. I'll be by your side. Every day and night, oh, through the darkest days, I'll be by your side. You didn't do me my life, my life, but you're my but she's my sins. Brother, fight, a still one family. Hey, the big ginger boy.
Okay, we take another shot.
From the very, very first time that my body jam you, girl. I don't think happy not because you just smell nice or the type of eyes you get. Whatever the case may be, Make you don't say you got a hold on me. Girl of my dreams, I'm so sorry. Baby, all the one possible to see you again. The sun they shine, rain they fall, wind they blow. Girl, I think of you. Whether for two, baby, where are you? Can't you see the way that I'm missing you? Why? You're picking me the fumble, I did fumble, I did lose my mind. Tell me how to make you realize. So now you be the reason when it's wrong, man, they do totally. Yeah. Time, baby.
My chat fine, I no go lie, my chat fine. I the ever lick crown when I say my chat fine. I know they think them hard, but for hard, keep trying. That's the girl you won't leave if you in your right mind. We just like Jay-Z and Beyonce. She did for my back like I be Moses. Something's about me that she won't say. You ask her anything, she will tell you that we okay. We fight all day, it'll be me start. She gets good, but I know she got a good heart. If we suffer, I know I played a big part. That's why I hustle every day, so we won't be apart. I met this girl back when I was in family. He tell you passing me and he would start a family. Her dad didn't like me, my mom didn't like me. When she with me, I don't really care who dislikes me. Yeah. I know say una know bombo na so me happy. Gucci for my food demand too much in my fee. Life only better, like una no three. Maka Gucci, na Gucci said the thing na flippery. Now na time to free. We there for Kribi, I shake out manga. Let's say na pingis, I love like na craze, but man, they no believe me. If life was the tree, like the branches to me. I'm feeling with the flow, tell me when I speak for money, flop quiet with the crap, now your chapter wanna Jovi. Jovi. I'm all over the country like a walk at this hard, just come full of branches. Put on everything, even if you got an army. I got Icarus of gold on the song, you don't be harm me. No bragging on the beat, your boy swagging. Mark to MCs, every day I'm still tagging.
Tiens-toi mon amour, pitié de mon cœur. Je travaille nuit et jour pour ton seul bonheur. Pitié-toi mon amour, pitié de mon cœur. Je travaille nuit et jour pour ton seul bonheur.
Yeah, they say Africans are so broke. They know they talk about me, yo. I give the girls hope every time I'm overseas. Yeah, money not my first wife. If you not know, be no. Don't quite be my no dog. Yeah, the money at the glow. She's on my bed every day. Yeah, what you want me to say? Yeah, it's all about getting paid. Go back home and get laid. Now I see a lot of haters. Police the one for love me. My girl wanna stress me. And some of these ladies wanna bug me. Yeah.
Pitié, toi mon amour, pitié de mon cœur. Je travaille nuit et jour pour ton seul bonheur. Pitié, toi mon amour, pitié de mon cœur. Je travaille nuit et jour.
Yeah. My slowly green up. Congo me, see how they shake for this, then I could fully. In short, my pop no be ever cold, he won't die, so my song no be ever old. Man, a hustler, wise man, I made take hands with the best and so stickling and jabba, I doubt it for the rapper, you want a booty clapper, accelerate, my hustle on the script, yeah, I never postpone, I take it all this, yeah, me I the see foul, boy, I've been a Pharisee, the jealousy pass, so boy, you been a Sadducee, opponents the wrong, kill him with the flow, line him up in one take, kill him with the rope, open up a bank account, fill it with the dough, next week I dip for seven bitch, kill him with the hoes, yeah.
Pitié, toi mon amour, pitié, toi mon cœur. Je travaille des jours pour ton seul bonheur. Pitié, toi mon amour, pitié, toi mon cœur. Je travaille des jours pour ton seul bonheur.
Daydreamers, we busting every bubble. Flexing every muscle till we double up the hustle. Blue collar job, you still want to smuggle. Noble but humble, can't kill the struggle. We putting it together. I stand on the rock. My foundation is love. That shit will never crumble. Nothing no be free, my man within a jungle. Let me that story. I throw hell in my own pool. Namina you, all place. Namina you. Wanna move, you speak like man, I move. Champagne campaign. There's nothing I can't play. When it comes to you, no, you know I won't play. I do it all for you. I play the other. Got everything locked down. Don't need to brother. Don't need to know how much everything will cost me. Just know I got the bill. Cosby.
Try to be my main star. Oh, I get around. Like, yeah. Every time this baby show, he don't lost $1,000,000. Shooting the shot, she probably do. We don't talk the thing, but if you wanna leave, baby, make you go. Said if you wanna leave, baby, just go. Thought that I'd be dead if you leave me, but for me, you gone already. Baby, why you crashing my party? Are you ever gonna stop with your ranting? I just wanna lay me down alone. Why you making noise? Please don't bother me. I just wanna chill out on the lawn. Baby, can't you see that you hurting me? Please, why you do worry me? Please, why you do follow me? See me sorry. Now you go killing me. Every la vida loca me never bye. You're not getting you crazy if you don't believe it's telling me. Every time this baby show, we don't lost $1,000,000. Shooting the shot, she probably do. We don't talk the thing tire, but if you wanna leave, baby, make you go. Said if you wanna leave, baby, just go. Ah, vamos, 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 señorita. Vamos, 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 mamacita. Adiós, adiós, señorita. Adiós, adiós, mamacita. Mamacita. Mátame yo para nambe mavalebe. You are my nanga mini nara pa mape fangalebe. Mátame yandi fanga grow up. Ibore beating para grow up. Masap sop yandi nara grow up. Ibore beating para grow up. Ah, nara bini. Oh, nara bini. Every time this baby show, we don't lost $1,000,000. Shooting the shot, she probably do. We don't talk the thing tire, but if you wanna leave, baby, make you go. Said if you wanna leave, baby, just go. Vamos, 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 señorita. Vamos, 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 mamacita. Adiós, Adios, señorita. Adios, adios, mamacita. Under the feeling, 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 under the feeling. Get around. Like, yeah. Every time this baby show, we don't lost $1,000,000. Shooting the shot, she probably do. We don't talk the entire. So your dream don't finally come true. Don't finally join the Kiliwi. I'll be so proud of you. I not go waste your time. Other girls do me wrong, but you do me right. Oh my baby, make up your mind. You gotta to give you money, I give you love. Cause I give you love. Sweet melanin, oh girl, sweet melanin, cover your body, girl. Tell me why your boy never cry. Over your body, girl. I say your coca body, they follow me auntie. Oh, tell me why your boy never cry. Over your body, girl. I go love you night and day, because now you the boss my brain, and I go blow your mind, 40 for it, 40 for it. I go love you night and day, because now you the boss my brain, and I go blow your mind, 40 for it, 40 for night and day, yo, night and day, yo, night and day, and I go blow your mind, 40 for it, 40 for night and day, yeah. Night and day, yo, night and day. Yo, I go blow your mind, 40 for day, 40 for night and day. Sweet melody, no girl, sweet melody, cover your body, yeah. Tell me why your boy no go cry. Over your body, girl. I say your coca body, the worry me auntie, yo. Tell me why your boy no go cry. Over your body, girl, yeah. I go love you night and day, because now you the boss my brain, and I go blow your mind, 40 for day, 40 for night and day. Girl, I go love you night and day, because now you the boss my brain, and I go blow your mind, 40 for day, 40 for night and day.
Okay, we take another shot.
Yeah. And the girls no Gucci, Prada, Louis, Sessa, Louis, stood. Came to dripping about me, bomb me. You came to test the about one to me. Can't control me, can't control me. I'm angry, you can't console me, can't control me, can't control me. I'm very angry, you can't console me. I like you, you shall consume, you back consume, you like shot to me, you love more to me, you remote to me. She loves America to me, I like you, you shall consume, you back consume, you like shot to me, you love more to me, you remote to me. You love Canada to me.
Tell me, how much you having in your account? Look at paper, we're packing with rubber band. How much is even the whole amount? That's what I'm trying to understand. You have insult me, you should apologize. For someone to toast, you come and laugh. To ba my long, will it summarize? To ba long tire gun, will it fuck in your life? Don't you ever come my side? You see my front that you want to come and shine. If you lack, only let my try. Your girlfriend will vanish before your eyes. All the clout on my body cost the arm and the leg. One day ask me if I go right to the check. What's strong with you? Are you mad?
And the girls no Gucci, Prada, Louis, Sessa, Louis, stood. Came to drip in about me, bomb me. You came to test the about one boom. Can't control me, can't control me. I'm angry, you can't console me, can't control me, can't control me. I'm very angry, you can't console me. I like you, you shall consume, you back consume, you like shot to me, you love more to me, you remote to me. She loves America to me. I like you, you shall consume, you back consume, you like shot to me, you love more to me, you remote to me. You love Canada to me.
Monsieur, tu me prends pour qui? C'est quoi ça? C'est quoi ça? Explique-toi, hein? C'est quoi ça? Tu me trompes et puis tu me prends pour qui? Nadia, c'est qui? Nadia, c'est qui? Explique-toi. It's my sister. Quelle sister? Quelle sister? Tu me dis rien. Tu me dis rien. Tu m'as de payer, madame.
All day with the argue, fight, argue. Seeing any pass for when I not slip out to Stono, sure. I did dodge, done it in another Bank Adi give me headache. Bank hey. I know if you take I'm again. I don't know why you did put me through all this pain. Now which kind guy this way the nang now for outside stop for the Bobby day on now for outside press them up from up now for one way. Did you see an ele for that kind of guy way? It the walker anyhow, just the sure anyhow. Now so you go candy when I want to talk, you know the one for yeah, you ele want to argue, you know the one for land. You ever want to argue, you are all you not for win. If man no catch you so for the tea, no go green. Then you woke up for morning now your own time up for sleep where you joke out, you put come on up for usayo. Man you want sleep for now when your own time up for come on, you come on so the go now for usayo.
On est si amer, on se bat, ça fait du mal. Tu n'écoutes pas, mes pleurs n'en parlent pas. Tu m'as fait tant de peine, pourquoi ne vois-tu pas? Et comme à la guerre, tous les jours, on ne s'arrête pas.
I don't have a dog because when I want to talk, now you the dog past me. When I time for walk, I need to see you. But when I time for chop, now you the chop past me. If it was kind of woman myself, it go the 3 months. You the green make I owe you. You the green make I touch you. It takes out a stick. If you say I did do now, now me to wash your clothes. Now me to cook your chop. Now me to pay the house. Now me to pay the bills. You know to pay nothing. You don't know how to be. I said go for school. Less small work. You go green. No expect respect. But you no respect yourself. I don't expect your respect, but I respect you. And you say no say I respect you. I don't know why you know they respect
On
me.
est si amer, on se bat, ça fait du mal. Tu n'écoutes pas, mes pleurs n'en parlent pas. Tu m'as fait tant de peine, pourquoi ne vois-tu pas? Et comme à la guerre, tous les jours, on ne s'arrête pas. Je sais que tu know, on se connaît. Tu oublies tes go et tu fais comme si de rien n'était, je know, on se connaît. Si aujourd'hui on en est là, tu sais pourquoi on ne se parle pas sans crier parfois. On s'en veut, mais ça tu y es pour quelque chose.
Manca algo, give me yo. Manca algo, give me yo. Manca algo, give me. Hey!
Loving me, go you, loving me, go you, loving me, go you, lady.
You did for my head, I know you play, oh. Not keep pushing me, baby, sing, not keep pushing me, baby, it's getting late. I see that for your hello, I know you're missing me, baby, I know you're missing me, baby. You feel my head, it's getting late, oh. Not keep pushing me, baby, sing, not keep pushing me, baby, I'm standing here. I know the hello, I know you're missing me, baby, I know you're missing me, baby.
My way follow you, no did that anyhow. But you said it bust my head anyhow. I get for stay on trap, rock the stack like I spoil my baby girl anyhow. Right price I get to bring 2 man cow. 7 shrine and 8 full my pound. Show ya rip say if you level with me, I no go do anyhow. But you say I deal with you. You fight any man we play with you. You no be na mop, I know the shake. Call it from Ghana, deal with you. Baby, after you now you. I only with a big cool my stew. I don't be them now, man. Me, I want for that now with you.
You did for my head, I know they play. I know they pushing me, baby. I know they pushing me. It's getting late. Oh yeah, oh, I know you missing me, baby. I know you missing me. Before my head, it's getting late. I know they pushing me, baby. I know they pushing me. I'm still standing here. I know the shake go. I know you missing me, baby. I know.
Hello, Anna Geledosa, Vandamarika, Vandosi, Dandicola, Benindebo, Benelisaba, Infero, for my Millie Jordan, the money, hey, I know they don't want me the money to come my way. Them know they don't go let the money to come my way. So I pray, may they know yeah, I'm going to come my way. Because I know what you know you go to when the money come my way. Hey. When the money no, they don't want to when no shingai, no shingai, no shingai, when no shingai, when the money no, they don't shingai, when no shingai, double no. I know they don't want me the money to come my way. Them know they no go let the money to come my way. So I pray, may they know yeah, I'm going to come my way. Because I know what you know you go to when the money come my way.
Hey, lift me up. You don't give me up. I said this money, man. You don't give me up. Oh, no, no, no. I go find my way. Any day I go find my way. Now God bless me my way. And I said this money my way. Yes, come on. Patonista. When I pull up in the extra. Fiesta, fiesta. When I pull up a fiesta. Fiesta. When I pull up in the extra. Fiesta, fiesta. When I pull up a fiesta. There's a man. Enough. Enough. It's man. But today, enough. But in my heart. We got it with my heart. Ain't gonna get it. With my heart. With my heart. With my heart. With my heart. I know they don't want me the money to come my way. Them know they don't go let the money to come my way. So I pray, may they know yeah I'm going to come my way. Because I can't put in I want use the money to come my way. Now all the things I do for you, you turn then you just match me. So right now I feel sorry for you. You got everything that you might need to succeed and to achieve. Every day I'm praying for you. Black Mamba, Black Mamba. Look me for corner if you check say I be tripod. Black Mamba, Black Mamba. I'm on my road, chap halana, embale God. River Jordan boy, you never catch my rod. Rod.
Sambela mewa belinde. Ngono, ngono mewa benoe. Kaya terembe, lela dadamo. Sambela mewa belinde. Ngono, ngono mewa benoe. Kaya terembe, lela dadamo. Kanza patembe gamolamo. Lindo ya kanza patembe. Gamolamo lindo. Oh, kanza patembe gamolamo. Lindo ya kanza patembe. Gamolamo lindo. Ngono awembe. Modoka wanza patembe. Ngono awembe. Modoka wa. I pray for my sister. I pray for my story. I pray for my brother. I pray for my son. Yeah. Awembe, ngono awembe. Odokawa. I miss you, my daddy. Ngono. I pray for my music. I pray for my giza. Ngono. I pray for my country. Yeah. Awembe, ngono awembe. Odukawanza patembe, awembe, ngono awembe, Odukawanza patembe, ngono awembe, Odukawanza patembe. Odukawanza patembe.
Lead, lead, always for the one.
Qu'est-ce que tu disais dans tes lettres et tes messages? Si jamais je pars, tu n'as plus d'histoire. Si jamais je pars, t'as plus de vie. Oh, oh, oh. Qu'est-ce que t'as fait de nos photos, nos chansons, ma musique et moi-même? Oh, oh, oh. Nami leli awayoke otikinga sina mabato nanga sala toujours présent mon cœur coule de sang dans mes rêves je te vois Anthony inganda memo wemo keti sango bima. Qu'est-ce que tu disais dans tes lettres et tes messages? Oh, que si jamais je pars, tu n'as plus d'espoir. Si jamais je pars, t'as plus de vie. Oh, oh, oh. Qu'est-ce que t'as fait de nos photos, nos chansons, ma musique et moi-même? Oh, 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 oh. Mais qu'est-ce que t'as fait de nos photos, nos chansons, ma musique et moi-même? Oh, oh, oh. Kamileni awayoke otikinga sina mabanzo nanga yo sala toujours présent mon cœur coule de sang yeah. Dans mes rêves je te vois Kamileni awayoke otikinga sina mabanzo nanga yo sala toujours présent mon cœur coule de sang yeah. Dans mes rêves je te vois Também beijei aquele Mon cœur peut ressembler. Dans mes rêves, je te vois. Herber son repos. Se adua kosona solo sala legetelo. Se adunga kosona solo lengbeti ungondatelo. Lolo dundo ndenge mbembe yendo ndo. Lolo dundo ndenge bisalando no. Se adua kosona solo sala legetelo. Se adunga kosona solo lengbeti ungondatelo. Lolo dundo ndenge mbembe yendo ndo. Lolo dundo ndenge bisalando no. Kamuda be mumma binalandango legetembe. Na komyo tiga. Ponge mema nga. Et même si tu pars, je reprendrai ma route. J'en veux pas, mais j'ai pas peur d'essayer. Il me coulera juste un peu de larmes pour ton départ. Oh non.
Je te départ.
Non, non.
Je te départ. Je te départ. Même quand je te parle rare, en vrai, je te parle de tout. Même quand je te parle de toi, en vrai, je te parle de nous. Même quand je me cache, en vrai, je te l'avoue. Quand je te dis au revoir, en vrai, je deviens fou. Tu m'as rendu riche, toi qui étais tellement pauvre, enrichi de ton rire et enrichi par ta peau. Les femmes pleurent au départ, elles sont juste moins lâches. Les hommes pleurent aussi, mais c'est juste qu'ils se cachent. C'est comme ça, jour de départ, ce qui nous sépare. Jusqu'au bout, c'est l'amour qui le répare. Près de ton cœur, de la chaleur de ton bagne, mon amour m'accompagne, ton souvenir m'accompagne.
Bia da sumeta belenge tenga ngoma. Bima bole bembe watamua bembe ma. Mogwe bing ata bing ngule ma.
On est ensemble et déjà tu me manques. On est ensemble, bébé, déjà tu me manques. Le sommeil m'emporte, je ne sais pas.
Tu pars, je reprendrai ma route.
Belle jusqu'à toi. Essayer encore, essayer plus fort.
C'est un peu de larmes pour ton départ.
Yeah. Ce qui nous sépare, jusqu'au bout, c'est l'amour qui le répare. T'es belle jusqu'à toi. Essayez encore, essayez plus fort. J'en veux pas, c'est l'amour qui le répare. Amour au 7e ciel, j'ai le tour. Va falloir qu'on se fabrique plus de souvenirs. Amour au 7e ciel, j'ai le tourné. Va falloir qu'on se fabrique plus de souvenirs.
Juste un peu de larmes pour ton départ.
J'en sais pas.
Oh bébé, dis-moi ce que j'ai fait. Est-ce que t'es en train de partir? Je ne sais plus où on en est. Bébé, dis-le-moi. Si t'en as assez, mes erreurs de jeune fille, je peux toujours réparer. Oh bébé, dis-moi ce que j'ai fait. Est-ce que t'es en train de partir? Je ne sais plus où on en est. Bébé, dis-le-moi. Si t'en as assez, mes erreurs de jeune fille, je peux toujours réparer. J'ai jamais été du genre à revenir. T'as rempli toute ma mémoire, regardez ces souvenirs. Bindim betibo kaya dume. Oh, fragile. Chérie, ensemble, on est fragile. Oh, bébé. Petit oh, fragile. On revient ensemble, on est fragile. Je t'en prie, bébé. Petit Grandir, ça change les gens, tu le sais. Laisse-moi apprendre à voler. Pourquoi ça t'effraie autant? Si mon cœur pouvait témoigner. Oh, oh, fragile. Chérie, ensemble, on est fragile. Oh, bébé. Petit oh, fragile. On revient ensemble, on est fragile. Je t'en prie, bébé. Petit Bilango na bibamo, bisingo na bibamo, bitana bikirim bibamo, bibamo. Bilango na bibamo, bisingo na bibamo, bitana bikirim bibamo, bibamo. Atati songo itindomo mukidape. Gotangote ungotile gitongo na bibamo. Atati songo itindomo mukidape. Gotangote ungotile gitongo na wawa bigimo. Bindoyemo. Even if I know you can't reach me. Bindoyemo. Even if I know you can't reach me. Yeah. Bindoyemo. I love you, even if I know you can't reach me. I won't stop loving you. Bindoyemo. Even if I know you can't reach me, I won't stop loving you, baby. Yeah. Even if I know you can't reach me.
Ladies and gentlemen,
That is so
I think we have come to the final session of this seminar, and we have some interesting presentations. Dr. Mathilde Mbouk, can you come to the first part of this last session is going to be on medical emergencies in cardiology. And that's going to be presented by Dr. Mathilde Mbouk. Dr. Mathilde Mbouk is a senior lecturer at St. George's University in London and at the Sussex University University. Okay, so at St. George's. Yes. Yeah. And she's a cardiologist with a lot of experience, and I'll leave Dr. Mbouk to present to you the interesting topic. Have we got our slides up?
Am I allowed to do those?
You can speak in French or in English.
Okay, no, I wasn't sure. I wasn't sure. Good evening, everybody, or good afternoon. Thank you, Professor Ngachu. I'll probably get nearer to my presentation. So I will do my presentation in French, but feel free to ask me any question in English or in French. Now, when I was told I had 15 minutes, can you believe the pressure of that? My blood pressure is already up. And I was told that I have 1 5 minute to present. And also, I was told to pitch to the level of a district hospital, right? So I had this dilemma of what should I do? Should I do most of my presentation on trials and stuff like that? I thought it wouldn't be appropriate. So it's a very practical one. And it's mainly to draw some recommendations about how to make it easy for a doctor to handle only 2 of the cardiovascular emergencies, because with 15 minutes, I don't think I could manage to more than 2. Okay, but I'm very happy to answer any questions regarding any other potential cardiac emergencies. Voilà. Comme je le disais en anglais, je n'ai que 15 minutes, donc on va essayer d'être rapide. J'ai essayé de faire une présentation pour les médecins qui sont dans les centres de santé ou dans les hôpitaux de district, pas spécialement les hôpitaux universitaires. Et j'ai surtout, en fait, posé des questions, ouvrir la réflexion sur comment optimiser la prise en charge de nos patients. Donc, nous allons parler de la crise hypertensive aiguë et je vais directement partir à la définition. Définition d'abord de l'hypertension parce que c'est un gros problème. C'est nous. Et je parlerai aussi brièvement des accidents vasculaires cérébraux. Je sais que les neurologues ont déjà eu à parler de ça. Je ne parlerai pas vraiment du côté neurologique, je parlerai vraiment sous l'aspect du cardiologue. OK? Donc, on va faire de façon systématique définition des signes cliniques parce que c'est ce qui est important pour les cliniciens que vous êtes et les complications, les approches thérapeutiques et puis des idées sur comment améliorer sa prise en charge de ces patients. Donc, la prévalence de l'hypertension artérielle au Cameroun est très élevée. Même quand on dit 30%, 30% c'est les adultes diagnostiqués. Donc, je dirais quand même qu'on serait probablement dans les 40%. C'est un problème de santé publique majeur. C'est un facteur de comorbidité, mortalité, parce qu'il y a des complications liées à une hypertension non contrôlée. Évidemment, on a plus d'hypertension en région urbaine qu'en région rurale, probablement à cause de nos habitudes alimentaires. On aimerait, d'après l'OMS, avoir la tension artérielle qui est supérieure ou égale à 130 à 90 est un signe d'hypertension. Donc, on a parlé de la maladie hypertensive, la crise hypertensive aiguë. C'est une tension artérielle au-delà de 180 pour la systolique et 120 pour la diastolique. Donc, on est déjà quand même à des chiffres extrêmement élevés. Et alors, comment ça se traduit? Chez la plupart des patients, ça se traduit par des maux de tête très sévères. Le patient dit qu'il a des maux de tête un peu plus inhabituels que des maux de tête qu'on peut avoir par fatigue. Et dans ce cas, il faut parfois se poser la question d'une hypertension intracrânienne. Les patients peuvent aussi parler d'une vision floue de scotum, donc des points gris ou noirs au niveau de leur champ visuel. Et certains patients ont aussi des douleurs thoraciques. Donc, il peut y avoir des éléments d'ischémie, de réduction de perfusion au niveau du myocarde. Donc, les complications, en fait, quand on stratifie la crise hypertensive aiguë, il y a la crise hypertensive aiguë avec une atteinte prouvée des organes cibles, c'est-à-dire le cœur, le rein, le cerveau, ou des neurologiques, c'est-à-dire on appelle l'encéphalopathie hypertensive. Ça, c'est des stades un peu sévères. Dieu merci. Les patients qui se présentent dans les centres de santé ou des hôpitaux de district ne sont pas toujours à ce stade aussi sévère. Bon, l'approche thérapeutique, idéalement, c'est une crise qui doit être gérée en milieu hospitalier. Maintenant, comme on l'a dit, on essaye de vous parler d'un hôpital de district. L'examen cardiovasculaire est toujours d'emblée nécessaire. L'examen neurologique, parce qu'on a parlé de l'encéphalopathie hypertensive. Idéalement, l'électrocardiogramme. Maintenant, on a un problème ici, c'est que la plupart des gens réservent l'électrocardiogramme au cardiologue. Mais tout médecin, en réalité, devrait pouvoir faire un électrocardiogramme. Électrocardiogramme de base, on ne vous demande pas de regarder les arythmies, mais on vous demande de regarder s'il y a un sous-décalage ou sous-décalage ST, parce que ça peut changer le diagnostic. Le fond d'œil, parce que je vous ai parlé de l'atteinte visuelle, donc l'atteinte des organes cibles est un critère de sévérité. Évidemment, le poids du patient, la diurèse, la mixion, c'est des signes cliniques qu'il faut regarder chez tout patient qui vient dans un contexte de crise hypertensive aiguë. Pour les gens qui peuvent avoir le lyonogramme ou la numération, ceci est nécessaire. Qu'est-ce qu'il faut faire? On dit en général reprendre la tension artérielle parce qu'on se rend bien compte que beaucoup de patients parfois ont un pic tensionnel qui très vite redescend. Si ce pic tensionnel redescend, il n'est pas nécessaire d'intervenir au niveau thérapeutique, mais il faudrait surveiller ce patient. Donc, initialement, il faut mettre ce patient sur monitoring. On est conscient que toutes les structures n'ont pas de monitoring, mais ça voudrait dire que ce patient, même s'il est allongé dans un hôpital de district ou un centre de santé, il y a un professionnel de santé qui vient toutes les 10-15 minutes pour monitorer l'évolution de la tension artérielle. Est-ce que vous savez comment bien prendre une tension artérielle? Parce que ça aussi, c'est un élément très important à savoir. Oui ou non? Vous êtes à l'aise avec la prise de tension artérielle? OK. Bon, maintenant, quand je parle de la radio du thorax, l'échographie, l'écho-cœur, l'IRM, ça, j'avoue que c'est dans des structures comme les hôpitaux universitaires, parce qu'on n'a pas le luxe d'avoir toutes ces investigations dans un hôpital de district. J'ai 15 minutes, donc je suis sous pression. Alors, quand on a un patient qui a été identifié en crise hypertensive aiguë avec une possible atteinte d'un organe cible, la voie intraveineuse est très souvent la plus appropriée. Maintenant, dans le contexte du Cameroun, j'avoue que c'est le protocole Loxène qui est le plus souvent utilisé parce que le Présil, qui est aussi un vasodilatateur, n'est pas toujours disponible. Donc, si vous retenez au moins une chose, c'est qu'une crise hypertensive aiguë au Cameroun, il faut que vous ayez un Loxène. Le Loxène, il y a la dose initiale qui est de 1 mg par minute tous les 10 minutes. Ensuite, il y a la dose de maintenance. Certains patients viennent dans un contexte d'insuffisance cardiaque méconnue ou connue mais pas contrôlée. Ces patients pourraient avoir le Lasix qui est un diurétique. Et dans le cas précis de la femme enceinte qui vient avec une crise hypertensive aiguë, le sulfate de magnésium est la molécule préférée pour pouvoir réduire la tension parce qu'on sait très bien que l'éclampsie est une urgence aussi bien cardiologique que obstétricale. Voilà. Alors, je vais rapidement au niveau de l'AVC. Les accidents vasculaires cérébraux, certes, sont des complications neurologiques, mais qui parfois ont une cause cardiovasculaire. Et la mortalité est très élevée parce qu'on se dit au Cameroun qu'il survient un AVC à peu près tous les 5 heures. Maintenant, il y a des AIT qui sont des accidents ischémiques et temporaires et donc qui ne donnent pas des séquelles, mais la grosse majorité des patients se présentent quand même avec des accidents vasculaires cérébraux complets. La mortalité est assez élevée, on va dire à 25% à 1 mois et 60% à 5 ans parce que les patients restent avec des déficits neurologiques qui ne sont pas toujours pris en charge de façon multidisciplinaire. Bon, je viens juste rapidement sur qu'est-ce qu'un accident vasculaire cérébral, quel est le phénomène, la pathophysiologie. C'est une interruption de sang vers le cerveau. Soit c'est un caillot, soit c'est une hémorragie. Comme par hasard, on s'est rendu compte qu'il y a beaucoup d'AVC hémorragiques au Cameroun. Je n'ai pas encore l'explication nécessaire, mais je pense que les neurologues ont parlé de ça ce matin. C'est ça? Donc, le symptôme principal, les patients se présentent avec un déficit neurologique en fonction du territoire qui est concerné. Donc, on a les troubles de la parole, la paralysie ou l'engourdissement, les problèmes visuels, les problèmes de coordination, les patients qui n'arrivent pas à marcher correctement, les céphalées, la confusion. Le test FACE qu'on utilise beaucoup en Angleterre, c'est FACE, c'est-à-dire FACE pour regarder si un patient a, par exemple, une déviation de la face. Arm, c'est-à-dire le patient n'arrive pas à soulever sa main. Speech, le patient n'arrive pas à parler de façon cohérente. Time, c'est-à-dire que c'est quelque chose qui est récent. Et en Angleterre, on dit souvent time is brain, c'est-à-dire que plus tôt on prend en charge ce patient, plus on va avoir, moins on va avoir des séquelles. Donc, le temps est très important. Alors, les complications sont multiples et variées. Des complications comme l'œdème cérébral sont des complications qui peuvent être très sournoises, qui peuvent même intervenir après l'accident lui-même. C'est un patient qui a eu un AVC et puis peut-être même quelques jours après, on le voit avec des céphalées, des nausées, une perte de conscience, une incontinence où il peut convulser. Ça, franchement, souvent, le pronostic est très, très réservé. C'est des patients qui peuvent avoir des thromboses veineuses, puisque c'est un problème de caillot, c'est un problème de coagulation, et des patients qui peuvent avoir une embolie pulmonaire sous-jacente à cet accident vasculaire cérébral. C'est des patients qui peuvent avoir une aphasie qui perdure, ou c'est des patients qui peuvent avoir des problèmes de sommeil, des problèmes cognitifs, des problèmes même de changement de comportement. Donc, il faut être très vigilant sur ce genre de patients. Certains sont envoyés chez les neurologues, les psychiatres, alors qu'en fait, ils ont un AVC. Bon, l'idéal, en fait, le gold standard, c'est la thrombolyse. On le sait très bien. Malheureusement, elle n'est pas disponible. Elle n'est presque pas disponible. Je pense que dans la ville de Douala, il y a peut-être l'hôpital général et encore, ou une ou deux cliniques qui ont une thrombolyse. Donc, il y a à faire là-dessus parce que les patients qui sont thrombolysés assez rapidement peuvent avoir une bonne reprise de leur fonction. Évidemment, ce qui se passe très souvent, c'est des patients, on leur donne de l'aspirine. Donc, on n'a pas toujours le temps de faire une imagerie cérébrale avant de faire l'aspirine, mais dans le contexte qui est le nôtre, on ne vous tiendra pas rigueur de donner à ce patient 300 mg d'aspirine si vous suspectez. Pardon, excusez-moi. On ne vous tiendra pas rigueur de donner 300 mg d'aspirine à un patient si vous suspectez un accident vasculaire cérébral. Donc, j'ai parlé de l'approche cardiovasculaire parce que je savais qu'il y avait le neurologue qui a parlé. Alors, j'ai parlé de l'aspirine, du clopidogrel qu'on trouve quand même de plus en plus. J'ai parlé de la réduction des risques cardiovasculaires parce que souvent, c'est sur un pic hypertensif que les gens font un AVC. Donc, évidemment, il faudrait réduire la tension artérielle et des patients qui ont une hypercholestérolémie, un taux de cholestérol élevé, prendre des statines qui sont des médicaments qui réduisent le cholestérol. Évidemment, les mesures hygiéno-diététiques sont rentrent dans le processus de la prise en charge des patients qui ont les accidents vasculaires cérébraux. Voilà. Donc, je reviens sur la rééducation, sur les séquelles, sur un programme personnalisé. Je trouve qu'on devrait mettre l'accent sur en fait le suivi post-AVC ou sur même le suivi des patients qui ont une crise hypertensive aiguë. Alors, je reviens sur l'importance de la prévention. Quand on a un plateau technique limité, on doit vraiment focaliser sur la prévention. Et c'est pour ça que j'ai tenu quand même à mettre beaucoup de diapos par rapport à ça. Et la prévention déjà passe par la sensibilisation à ces pathologies-là. La réduction des risques et la sensibilisation des patients. Il faut cibler les facteurs de risque qui sont modifiables. On a parlé de l'obésité ce matin, je pense, mais je reviendrai dessus. Il faut vraiment parler aux patients des bénéfices de la réduction des facteurs de risque. On a des populations de plus en plus sédentaires. C'est pour ça qu'on a plus de nos pathologies cardiovasculaires dans les villes que dans les villages parce que la sédentarité n'est pas encore arrivée dans nos villages, Dieu merci. Donc, il faut vraiment encourager les gens à la pratique sportive. La pratique sportive ne veut pas nécessairement dire aller passer 1 heure ou 2 heures chez un professionnel, un coach sportif. C'est même faire 30 minutes de marche tous les jours, c'est déjà très bien. Les mesures hygiéniques diététiques sont importantes parce qu'on se rend bien compte que le sujet hypertendu africain a cette spécificité, c'est qu'il retient beaucoup de sel. Et on mange beaucoup de sel chez nous. On mange beaucoup de choses, des aliments, les cubes magie et tout ça. C'est une véritable catastrophe pour la réduction par rapport aux maladies cardiovasculaires. Le stress a été reconnu comme un facteur de risque et le stress devient une réalité chez nous. Donc, ça fait aussi partie des facteurs de risque modifiables. Donc, je répète, la sensibilisation, l'éducation par des campagnes de sensibilisation, l'éducation du grand public, l'éducation des professionnels de santé. Ces maladies cardiovasculaires ne doivent pas rester l'apanage des cardiologues. Donc, évidemment, on est conscient qu'on n'a pas le luxe d'avoir un système où la prise en charge médicale est sous la sécurité sociale. On rêve de la couverture de santé universelle, mais pour l'instant, il y a un coût de ces maladies. Il y a un coût pour le patient, il y a un coût pour la société, il y a un coût pour les assurances, il y a un impact économique majeur pour un patient qui est hospitalisé, parce que si ce patient est, par exemple, celui qui nourrit sa famille, il y a cet impact sur toute la famille. Et donc, il y a le handicap physique pour les patients qui ont des AVC et qui peuvent perdre leur emploi, l'impact émotionnel sur les familles. Donc, ce sont des maladies qui, en fait, ont un spectre large de répercussions chez le patient, dans la famille et dans la société. Donc, les pistes de réflexion que je me suis autorisé de donner, c'est le renforcement de capacités dans les établissements de santé. Investir sur la modernisation du plateau technique. Quand on parle de plateau technique, on se dit, on pense à toutes les grosses machines qui existent. Oui, la médecine a fait beaucoup d'avancées, mais il y a en fait des appareils de base qu'on devrait essayer de mettre dans toutes les structures, au moins des hôpitaux de district, et garantir en fait l'accès aux soins d'urgence. Avoir en fait en anglais on dit un pathway, c'est-à-dire avoir un couloir qui permet de prendre en charge immédiatement une personne qui vient en situation d'urgence. En situation d'urgence, on n'a pas le temps et on n'a pas un problème et une piste sur laquelle on devrait se pencher, les professionnels de santé, l'État, le ministère de la Santé. La formation du personnel médical. Je dis et je répète que l'électrocardiogramme, certes, est utilisé par les cardiologues, mais n'est pas l'apanage des cardiologues seuls. Il est important que les jeunes médecins généralistes soient capables déjà de mettre un ECG, mais de pouvoir interpréter un ECG de base. Ça leur permettrait de prendre en charge ces patients qui se présentent en crise hypertensive aiguë. Évidemment, le spécialiste viendra en renforcement, mais au moment où le patient arrive, il n'y a pas toujours un spécialiste. Donc, il est important de travailler sur la formation du personnel médical, de mise en place des programmes de formation continue, mais d'élaborer des protocoles de soins standardisés. Je vous assure que quand il y a un protocole de soins standardisé, c'est tellement plus simple pour le jeune médecin de prendre en charge ce patient en toute sécurité médicale. L'accès aux médicaments essentiels. Ces médicaments, certains de ces médicaments que j'ai cités ne sont pas toujours accessibles au moment où le patient se trouve. Donc, assurer la disponibilité, l'approvisionnement des médicaments essentiels pour ces soins d'urgence. Évidemment, tout passe par l'argent. Donc, les sources de financement, les partenariats publics-privés sont à privilégier ou en tout cas sont à mettre en place pour pouvoir renforcer ces différents plateaux techniques. Je vous remercie bien.
That was a very brilliant presentation and in a very timely manner. And as Dr. Mathilde said, she limited herself to a couple of cardiologic emergencies or cardiovascular emergencies, and she targeted the district hospitals. But she is very willing to take questions in other cardiovascular emergencies, and she's willing to take questions from other medical settings. Are there any questions? Yes.
Merci, professeur. C'est juste pour demander l'utilisation des sulfates de magnésium chez les femmes enceintes sans l'association avec d'autres molécules, molécules cardiologiques. Est-ce que ça peut nous aider à résoudre la grande partie du problème du malade?
Votre question, c'est la prise en charge de l'hypertension chez la femme enceinte ou la prise en charge de la crise hypertensive chez la femme enceinte?
Bon, comme c'est classifié, mais d'une façon globale, je parle de la prise en charge de l'hypertension chez la femme enceinte en utilisant uniquement le sulfate de magnésium.
Non. Chez la femme enceinte, on utilise de la bétolol pour l'hypertension de la femme enceinte, en première intention. Dans la crise hypertensive, c'est une crise qui survient en urgence et le sulfate de magnésium a quand même une action assez rapide. C'est pour ça qu'il est privilégié. Et comme par hasard, il est beaucoup plus disponible, en tout cas c'est ce que j'ai observé dans les structures de santé. Pour revenir à la spécificité de l'hypertension chez la femme enceinte, et je pense que je ne suis pas obstétricien, mais c'est des maladies qui sont multidisciplinaires. On a travaillé avec quelques obstétriciens et on a insisté sur la notion lors des visites anténatales de monitorer la protéinurie, c'est-à-dire les protéines dans les urines. C'est très simple, c'est basique, mais ça donne beaucoup d'informations. Et les femmes, quand on s'est rendu compte que les femmes qui ont des protéines dans les urines, si elles sont prises en charge tôt, elles n'arrivent pas à l'éclampsie. Donc, nous, ici, le message, c'est la prévention. On n'aimerait pas avoir des femmes qui viennent en crise hypertensive aiguë. On aimerait voir des femmes, au pire, qui ont une hypertension de grossesse, donc qui sont traitées avec du labétolol. Mais idéalement, des femmes qui, en début de grossesse, on les identifie comme des potentielles personnes qui pourraient développer une hypertension de grossesse. Je ne sais pas si j'ai répondu à votre question.
Oui, bon. Juste l'association, est-ce que c'est sulfate de magnésium seulement qu'on va mettre ou bien il fallait ajouter encore d'autres molécules, quoi?
C'est là, en première intention, c'est celui qu'on donne.
Merci de me passer la parole. Merci, docteur, pour votre présentation qui nous a beaucoup édifiés. Je voudrais, s'il vous plaît, que vous nous apportiez un éclairci par rapport à l'usage des dérivés nitrés. Dans votre présentation, vous avez mentionné le dinitrate d'isosorbide. Est-ce que, en utilisant ça lors de la crise, on ne craint pas une tachyphylaxie? Nous pensions plutôt qu'il était préférable d'utiliser de la molsidomine. Merci.
Alors moi, j'ai surtout dit, j'ai surtout parlé de la disponibilité des médicaments. En cardiologie et en urgence cardiologique, on voit ce qui est. Et quand je regarde, je ne sais pas pourquoi, mais les dérivés nitrés sont beaucoup plus disponibles, en tout cas à Douala. Et donc, j'ai mis à dessein ma présentation sur ce qui se passe localement. Alors, qu'est-ce qui se passe dans une crise hypertensive? On voudrait vasodilater. Maintenant, en vasodilatant, on doit aussi tenir compte des chiffres tensionnels. On ne doit pas réduire subitement la pression, la tension artérielle. Parce que si vous quittez de 18 à 12, vous avez des risques d'hypoperfusion. Donc, vous créez un autre problème. Idéalement, d'après les guidelines, il faut le faire par palier. Et ce que moi, j'ai vu dans les structures à Douala, c'était les dérivés nitrés que les gens avaient de plus en plus. Je ne sais pas si c'est parce que les pharmaciens les ont plus, mais la molécule que vous avez citée est tout aussi valable, sinon même en première intention par rapport aux dérivés nitrés. Je ne sais pas si j'ai répondu à votre question. Oui ou non? Alors, expliquez-vous plus clairement, en fait.
Oui, docteur, s'il vous plaît, ma question était sur le type de dérivé nitré à utiliser en première intention. Parce que nous savons qu'avec l'isosordinitrate d'isosorbide, on a un risque de tachyphylaxie. Donc, je pensais qu'en première intention, on devrait plutôt utiliser de la molsidomine, vu qu'avec cette molécule-là, on n'a pas ce risque.
Vous l'avez personnellement utilisé?
Oui, docteur.
Et vous avez trouvé que parce que quand vous parlez de la tachyphylaxie, vous parlez d'une arythmie qui se développe à la suite des dérivés nitrés ou bien vous parlez juste que ça va développer une arythmie chez un patient qui n'était pas connu arythmique? Ben moi, de mon expérience, même en Angleterre, je n'ai pas vu des patients développer une tachyphylaxie. Et je pense que même Dr Ngachou, qui est aussi, il est interniste, parce que vous savez, au-delà de la cardio, la gastro, nous sommes des internistes. Moi, je n'ai pas personnellement expérimenté ça. Il faut aussi vous rendre compte que certains patients ont déjà des tachyarrhythmies connues. Mais vous ne pouvez pas dire globalement qu'en utilisant des dérivés nitrés, vous risquez une tachyphylaxie. Ça, ce n'est pas vrai. Ce n'est pas vrai. En tout cas, moi, dans ma pratique, ce n'est pas vrai.
Thank you so much, Dr. Matilda, for this presentation. If I got you well, you mentioned a situation where you may have a patient with a suspected stroke that aspirin can be given. I've often had the notion that aspirin can cause more bleeding. I don't know if that is true. If it's the case, then in this case, what can be some of the warning signs that somebody can see and determine that this patient shouldn't benefit from aspirin? Considering that we have health facilities in hard-to-reach areas where a patient may be brought there and may take the next 2 to 3 days before they have a vehicle to convey that patient to the hospital, where they will have to do the x-rays and every other thing to do better analysis and better care, since we are being encouraged to do no harm to these clients and so.
I think the disclaimer was this one. It was that, yes, do no harm, but how long does it take for someone to have a CT brain when they suspected stroke? Could you answer? When someone presents with a suspected stroke, okay, how quick, how soon do you think they can have a CT brain? Sorry? Okay, it's a long period. So how do you make the distinction between a potential ischemic stroke or the hemorrhagic one? Because you think about, so when they're looking at overall, the majority of people that come and present, if someone, obviously, if you find someone with reduced or severe alteration of the conscience, you may then suspect that they may bleeding, they may have a hemorrhagic stroke. In that person, you may be a bit cautious, but you do not harm with just a stat dose of 300 milligram aspirin. We are being practical here. I think that was the purpose of the purpose of my presentation is we put ourselves in the context, okay? I think in London, people will be able to go and quickly have a CT brain and be more, a bit safe in discussing what they can give to people. In fact, thrombolysis will be the gold standard. But I'm talking to you here, anyway, in Douala, very few healthcare facilities have thrombolysis in place, okay? And even if they have a CT scan available, the patient may not have the means to have a CT scan done. Would you delay when we've said time is brain? Would you? Okay.
Yes, let me just add to what Dr. Mbuk was saying. When we practice medicine, we work on probabilities. So the probabilities that we have is usually to guide us what is the most likely problem. Now, I don't know the prevalence in Cameroon, but I know if somebody presents with a stroke, about 70% of them will have ischemic stroke. I don't know what it is in Cameroon. In the UK, about 70% will be ischemic. In Cameroon, it's 50-50. Then we are in trouble. Because if we have a 50-50, then giving aspirin is like the toss of a coin. Because in the UK, it's 70-30. And if you give aspirin, you are likely to save 70% of the people. And like Dr. Mathilde was saying, a 300 milligram of aspirin is not going to make the bleeding any worse if you have the time to identify what kind of stroke they are having. But that aspirin will save brain matter if it's ischemic stroke. So those are some of the little nuances we have, okay? And I think these differences calls for an opportunity for us to actually have a look and see what is the risk of giving aspirin to a patient with a hemorrhagic stroke. Okay. I think that would be a very good point. Yes, it looks like, have you got the answer to that question? Sorry? You have another question? I thought you were giving me an answer to that question. Okay, I hear your question. Have you got the answer to the question? Hein? Tu as la réponse? Tu veux poser une question? Okay. Don't monopolize it. We'll give it to the man behind you.
Merci, Dr. Mathilde, pour votre présentation. J'avais deux doléances. La première était de savoir, pour un malade qui a peut-être été interné pour un AVC, et nous avons peut-être parvenu à maîtriser les chiffres tensionnels, quand est-ce qu'on va libérer ce malade? Donc, quels sont les critères de sortie pour les malades qui sont internés pour les AVC? Parce que souvent, on se retrouve avec un malade et vu qu'il n'a pas encore retrouvé la force motrice, on ne sait pas quand est-ce qu'on va le libérer. Et la deuxième était de savoir pour un malade qui présente avec des signes en faveur d'un infarctus du myocarde. Et souvent dans nos hôpitaux logistiques ou bien dans nos hôpitaux en périphérie, nous n'avons pas de ECG. Que sont les 3 étapes les plus urgentes à prendre si nous soupçonnons un infarctus du myocarde? Merci beaucoup, docteur.
Le patient qui a un AVC, je pense qu'en médecine, comme on l'a dit, le sens commun prévaut. Est-ce que votre patient est stable? Est-ce que votre patient, il est venu peut-être avec une crise hypertensive et il a développé un AVC? Maintenant, on a stabilisé sa tension, OK, artérielle. Au niveau de sa fonction diurèse, numération de formules sanguines, tout ça est stable. Ce patient neurologique, il a été déjà vu par le neurologue, il a un protocole médical qui est en place. On l'a probablement orienté aussi vers la rééducation. Pourquoi le garder? Si peut-être, je sais que si un patient, par exemple, n'arrive pas à bien déglutir parce qu'il a un trouble de la déglutition lié à son accident vasculaire cérébral et qu'il a besoin d'une alimentation parentérale, ceci peut être un critère de le garder à l'hôpital. Mais un patient qui, certes, a une déglutition qui n'est peut-être pas optimale, mais qui peut avoir ce qu'on appelle un régime mou, donc il va prendre un purée diet, comme on dit en Angleterre, tant qu'il est stabilisé, il peut repartir chez lui et avoir un suivi. Parce que ce qui se passe ici chez nous, vous savez que le patient qui est hospitalisé, il y a un coût. Et ce coût vient de ce patient, ce coût est supporté par ce patient. Parce qu'il n'y a quand même que moins de 30% de la population qui est assurée. Donc, j'invite les cliniciens à regarder aussi l'aspect financier des patients. J'invite les cliniciens à avoir une attitude très pragmatique dans la prise en charge de nos patients. Et donc, voir aussi avec le patient quelle est la possibilité pour lui d'être vu en ambulatoire. Je pense qu'une médecine ambulatoire qui est bien contrôlée peut être aussi une médecine qui est faite en toute sécurité. Je ne sais pas si j'ai répondu à votre question. Concernant l'infarctus du myocarde, que je n'ai pas dit là, l'infarctus du myocarde, c'est quoi? C'est, en fait, on va dire un AVC, mais au niveau du cœur. C'est-à-dire qu'il y a une réduction ou une interruption circulation au niveau des artères qui irriguent le cœur. Donc, ce cœur-là, en suivant si c'est un petit territoire ou un gros territoire, le patient peut être stable ou le patient peut ne pas être stable. Il faut regarder les facteurs de risque. Il faut regarder ce qui a mené à l'infarctus de myocarde. Si c'est une crise hypertensive, il faut travailler à remettre la tension à un niveau normal. Si c'est un caillot, si c'est un patient qui a besoin d'un pontage, je préfère vous dire que la cardio-interventionnelle est encore à ses débuts au Cameroun. Il n'y a pas beaucoup de centres qui la font. Mais ceux qui peuvent bénéficier d'une cardiologie interventionnelle, c'est des patients suivant le territoire imprimé, vont être orientés vers ces centres de cath lab. Évidemment, les facteurs de risque vont être pris en charge. Si c'est un patient qui est diabétique, si c'est un patient qui est hypertendu, tout cela doit être stabilisé. Si c'est un patient qui a des douleurs encore, en général, c'est des patients qu'on met sous morphine. Donc, ce patient, je ne vais pas le garder, je ne vais pas le faire sortir, sauf si il dit qu'il n'a pas les moyens ou sauf si l'hôpital n'a pas une comme politique de traiter le patient d'abord et ensuite de pouvoir demander au patient après de prendre en charge. Parce que moi, j'aimerais que les jeunes cliniciens que vous êtes soient conscients du fait que tous les patients que vous avez, en tout cas la plupart des patients que vous avez, payent de leur poche leurs soins. Donc, il faut être responsable dans notre pratique, il faut être responsable dans nos prescriptions. Et je suis pour qu'on puisse mettre en charge des protocoles standardisés pour qu'on puisse pratiquer de la médecine de façon sécurisée en termes de la prise en charge de nos patients.
Right, Dr. Mathieu, thank you very much. And I would like to call this session a close. We have the next session with abstract presentations. Thank you. Right, while they are getting ready, this is the final session of a poster presentation. And like you heard earlier on, the best poster presentation will have a prize. So we're hoping to hear some exciting presentations. I would like to welcome Dr. Linda Bello to the podium. And Dr. Nomo Alet.
Right, we'll get straight to it. It's been a long day. But this is the most exciting part, I think, where we get you guys to obviously tell us a bit about what you've been working on. So the first presenter, hope he's here, hope she's here, Konginui Solange Boxiru. Perfect. And she's going to be talking about lifestyle practices in the prevention and control of non-communicable diseases amongst adults of Alakuma Health Area, Bamenda Health District. So, Doctor, you've got 6 minutes, and then we have 4 minutes to ask you questions. Thank you. Have you got a microphone there? You've got?
Okay. Professor, doctors, ladies and gentlemen, good afternoon. I'm Kongnye Solange, a nurse specialized in public health. I work with Easy Health. It's a common initiative group that works in partnership with AstraZeneca to fight against non-communicable disease in young persons. I will be presenting this afternoon on lifestyle practices in the prevention and control of non-communicable disease amongst adults of the Alakuma area in Bamenda Health District. This presentation will adopt the The presentation will adopt the following outline for the presentation. Non-communicable disease, also known as lifestyle-related disease, they often pose a serious threat to health without showing any symptoms until the condition progresses to an advanced stage. And from WHO report in 2018, non-communicable disease kill 41 million people each year. That is 71% of all the deaths globally. And more than 15 million people dying are between the ages 36 to 69 years. 85% of these premature deaths occur in low and middle income countries. Cardiovascular disease, diabetes, cancer, and chronic respiratory disease, which are the 4 main leading causes of NCDs related deaths, accounts for 80% of all the total premature deaths. Still in 2018, Cameroon recorded 235 deaths from non-communicable disease, accounting for about 35% of the total deaths for that year. Non-communicable diseases are strongly associated with unhealthy lifestyle practices. However, they can be largely prevented by reducing exposure to the main modifiable risk factors, such as unhealthy diets, physical inactivity, tobacco, smoking, and alcohol abuse. For the problem statement, premature deaths from non-communicable disease is a major health and development challenge of the 21st century. And also, rapid urbanization and improved labor-saving technologies increase exposure to sedentary lifestyles, physical inactivity, unhealthy eating habits, and increased obesity and NCDs rates in Cameroon. And despite this, despite the increasing burden to the country, the awareness level and behavioral changes towards the prevention and control of this disease remains poor. And also, in addition, the researcher, while working in one of the health facilities in this health area where the study was carried out, noticed that most of the premature deaths and the sudden deaths were attributed to non-communicable disease. The reason why the study set out to assess the knowledge of the adult population of the Alakuma area about some selected non-communicable disease, and also to identify the healthy lifestyle practices that this population is adopting to prevent and control non-communicable disease, as well as to identify factors that influence the activities for the prevention and control of this disease. This study was a community-based cross-sectional study conducted amongst 269 adults aged 30 to 69 years, recruited through a systematic random sampling technique, and it was done from May to June 2022. Next slide, please. The questionnaire designed based on the objectives were administered to participants after a pilot study. The weight and the height measurements were obtained using a scale and a graduated flexible tape, respectively, and the body mass indices were calculated from these findings. The data was analyzed using SPSS version 23, independent t-test, and one-way ANOVA used to compare mean knowledge score across socio-demographic characteristics, a categorical variable assessed using cross tabulations and odds ratios and their corresponding 95% confidence intervals calculated using the logistic regression analysis. Statistical significance was set at p less than 0.5. For the results, the study involved 269 adults with the mean age of 38 years and with more than 65% in the age category of 30 to 39 years. The mean body mass index of the study participants was 26.9. And when we follow the classification by WHO, we will see that this is in the class of overweight. And almost half of the study participants were of low income class and not up to half had attained a tertiary level of education. Next slide, please. Looking at the chart, we will see that 68% had average knowledge on non-communicable disease and their risk factors, and only 21% had good knowledge on this. The less than 1/4 of the study, next slide, please. Only 22.3% and 37.9% of participants carried out vigorous physical activities and trekked routinely to their workplaces, respectively. The high rate of the physical inactivity could just be related to participants' inability to make out time to engage in physical activities, as most of the reasons that they advanced were being just lazy or lack of time and long distances. Some said they had a bad car and so they didn't see it necessary to trek or take out time to exercise. So Cameroon's estimate in 2017 for adults who were insufficiently active was 28.5%, which is lower than that of our study, which is 34.6%. And the difference could probably be due to the improved modern technologies as time advances. Not up to 1/4 of the study population consume fruits and vegetables daily or at least 4 times a week. And this could be due to lack of finances, which was the reasons most of them gave for not consuming fruits and vegetables daily. And the chi-square test we did indicated an association between healthy eating habits and socioeconomic status. However, the average consumption for vegetables was better than that for fruits, probably because the area where we carry out the studies, some of them at least they had a farm where they could cultivate the vegetables, unlike fruits where they had to buy everything. These findings are similar with those of in a study carried out 2018 at Sri Lanka, where the percentages that consume fruits and vegetables respectively daily or at least 4 times a week were similar to us. If we look at the chart, we will see that the consumption rate for carbohydrates was highest, even palm oils, but when we look at like vegetables oils, it was the lowest. And these findings could be used to explain the high values for overweight, as we saw, like the average body mass index for the population was overweight. So, and all this is in line with the study carried out in Cameroon in 2011, which pointed out the fact that Cameroon is a country where the main foods consumed are very rich in starch, oils, and sugars, and most people are increasingly exposed to sedentary lifestyles and unhealthy diets, leading to increase in obesity rates. The study, in conclusion, the study revealed an overall average knowledge on NCDs, and the main knowledge score of the study participants was associated to educational level. The participants demonstrated a low rate of adequate physical activities and healthy eating habits, high rates of alcohol use, and poor health-seeking behaviors. Inaccessibility to health information and socioeconomic factors were the main identified factors associated with non-communicable disease, prevention activities. As our recommendations, a population-based intervention such as health education geared towards unhealthy lifestyles modification while taking also into account the factors that are influencing changes should be reinforced. Strategies for tackling non-communicable risk factors should include nutrition education, counseling in various settings or health facilities, and awareness campaigns to promote physical activities through maybe organized sports programs and events. NCD screening programs should be cost-effective and brought closer to the target population as much as possible, probably through community health workers. Thank you for your keen attention.
Wonderful. Thank you so much, Solange Cogne. I'll invite you to take a seat and we'll go straight to the next presenter. Please save any questions for the end where we can pose them to Solange. The next presenter should be Kotu Emmanuel Shu. Oh, he's not here. Okay. Next presenter, Okumoka Greta. Okay, over to you.
Thank you, Dr. Linda. The next presenter is Walter Ebot Ojon. Yes. The presentation is about effects of chemotherapy on the hematological profile of cervical cancer patients in the littoral region of Cameroon. We have 6 minutes for presentation.
Thank you so much. I know we are tired. Good afternoon to everyone. Please just turn to your neighbor and tell your neighbor good afternoon. Do that with some smiles. All right. Thank you so much. All the doctors in the house, good afternoon. My professors, good afternoon. My chair this afternoon, good afternoon. I am Inji Dibaklovis, and I'm the principal investigator for a research work that is for my master's dissertation, which was carried out in the littoral region alongside a team of formidable scientists, which I will acknowledge at the end. We did a work on the effect of chemotherapy on the hematological profile of cervical cancer patients in the Douala General Hospital and La Cantine Hospital. Next slide. A brief background, cervical cancer is a preventable. I would like to stress on the word preventable because we are going to see that at the end. Preventable malignancy arising from the transformation of epithelial cells of the cervix, principally by HPV, the human papillomavirus, into tumor cells. You should have so much worry and concern as a woman if you start seeing bleeding apart from your period, or you start having bleeding when you are at your menopause age. You have smelling vaginal discharges, blood-stained vaginal discharge, abdominal pain, and pelvic pain. It should be a concern to you. And many things can lead to that. The HPV virus is. However, we have other fungal bacterial infections, multiple sexual partners, smoking. Most people who are taking pregnancy prevention pills, childbirth control, they are at risk of having cervical cancer. Please, next slide. It's sad to say that cervical cancer is the fourth most common cancer amongst women and the second highest between the women of the age 15 to 44. I must say that globally, an estimate of 604,127 cervical cancer cases were diagnosed, and it's sad to say that 341,831 deaths were recorded with corresponding age standard incidence of 13.3 cases per 100,000 women a year. In Cameroon, our motherland, I regret to say that cervical cancer is the second most prevalent type of cancer among the Cameroonian female population. Next slide, please. Because of that, there are many modalities to treat cervical cancer, amongst which we have surgery, we have radiology, but our focus for the study we did was chemotherapy, which is a widely used modality for cancer aimed at destroying these malignant cells and as well as preventing further growth and spread in the body. So it's very paramount that we understand the effect of chemotherapy on hematological parameters in cervical cancer patients, because it has so much to do with optimizing treatment strategies and managing potential conditions, because we believe every remedy will always have side effects. So understanding this has a lot to do. Now, there is limited data on the impact of chemotherapy on hematological parameters of cervical cancer patients in Cameroon. And that is one of our pushing factors that took us to carry out this research. Next slide. Which was a hospital-based prospective study carried out from January to June 2024 at the oncology units of the Douala Geneva Hospital, the Douala La Cantine Hospital, and the Cameroon Oncology Center, Littoral Region, Cameroon. It was a very tedious study, but I'm so glad that we made it right up to this point where we are even presenting it at this beautiful conference. We had 92 confirmed cases, participants. We recruited 92 from the age of 21 right up. We did not put any upper limit. And our criteria, we looked at those that are they are diagnosed of cervical cancer and about initiating chemotherapy. Well, because of the benefits for participants, many would have loved to be part, but we didn't include them because they were not just, some of them were not taking just chemotherapy, they were doing combined therapy, and others were doing surgery and so on. So we were focused on chemotherapy. Questionnaires were used to document socio-demographic and lifestyle and medical history of our participants. And after collecting blood sample, the hematological profile was determined using an autoanalyzer, the Minway BC 500 and 5,108 mark. Next slide. So after the period of our research, I'm happy to present our result so far. I'll begin with the socio-demographic characteristics of our patient, which I won't take much time. I'll throw light on the striking part. Looking at our result, we realize that our the highest percentage of our participants were of 50 to 75, which is a very big striking point, telling us that cervical cancer is a menopausal disease or problem. And we looked at the stages at which the patients were before initiating therapy. We noticed that majority of our participants were already at the 3B stage, which is a big reflection of the unawareness about the pathophysiology of cervical cancer. Aside from the residents, alcohol consumption, smoking, which is there are risk factors, and I'm glad to say that our study is in line with the study conducted by Idris et al. In 2020 in Douala as well, giving similar results. Please, next slide. We took our time to do statistics on our results, and we wanted to prove indeed that chemotherapy has an effect on the hematological parameters. And we looked at five of them, four particularly the white blood cells, red blood cells, hemoglobin platelets, and we took the values of these parameters before and during a 1 month period of taking chemotherapy. And we realized that there was a marked decrease in the amount of particularly the white blood cells while they were undergoing chemotherapeutic treatment. We were really concerned about the particular white blood cell component, and that is why we looked at the neutrophils, because they are the main key components in immunity. So we realized that the neutrophils were highly affected by chemotherapy, making our results statistically significant with a p-value of less than 0.001. Please, next slide. This hematological character of participants before and during 1 month of cancer chemotherapy treatment, we were looking here at the different prevalences of the participants based on how the parameters were before and during chemotherapeutic treatment of during 1 month treatment. That is why if you look at it, we realize that I just want to point out some striking points. If you look at the white blood cell leukopenia, we realize that leukopenia was experienced during chemotherapy. And as well as we also realize that majority of the patients suffer of anemia while undergoing chemotherapy, and platelets were really not affected by chemotherapy. Please, next slide, because of time. We extracted the key components, as I was saying in the previous slide. We look at leukopenia, the percentage of our participants who had leukopenia before initiating chemotherapy and 1 month of chemotherapy, we realized that the percent has increased, and giving us, while comparing before and after, we realize that it is of great concern because of the significance proof with our p-value. We look at anemia, and we also, like I said, neutropenia, neutrophils were our main target while we're looking at the white blood cells. Anemia, like I said, up to 82.6% of our participants suffer from anemia while undergoing chemotherapy. Please, next slide. With everything that has been said, we could not present everything, but concluding from what we are just from presenting, it is clear that cervical cancer is mostly observed in menopausal women. And this is because the period where you contact the virus and when you start manifesting the symptoms of cervical cancer is very long, close to 15 years. And that is why we recommend that every woman seated here looking at me, you should take it as a habit of doing screening at least once or twice a year, because you might be in the asymptomatic stage of cervical cancer. Am I making sense? Cervical cancer and its chemotherapeutic treatment, based on what we have said, have an adverse effect on hematological parameters, causing, like I said, neutropenia. Thrombocytopenia is, though it was experienced, though not really marked, and anemia was seen. Like the next point, anemia was the most prevalent hematological abnormality in cervical cancer patients before and after or during a period of 1 month taking chemotherapy. Our findings support recommendations that hematological parameters should be regularly monitored in cervical cancer patients undergoing chemotherapy. Next slide. These are some of the references that we use in our study. Next slide. And I'm glad to say that on behalf of our team, that the work that we did, effect of chemotherapy on hematological profile of cervical cancer patient, has been published in the International Journal of Cancer and Tumor. Please, can we put a round of applause for the team? The next slide, as I step down, I will take out this time to acknowledge the people that worked with me hand in glove to see that this work was a mega success. My very own supervisor, Associate Professor Asongalem, who is a professor of pharmacology and the director of administrative affairs in the University of Boya. I have with me present here my co-supervisor, the person who has who took the work personally and ensured that this work will be a success and made it sure that it was presented here. No other person but Dr. Ebod Walters Ojong, please. He's present. Can we just celebrate? A senior lecturer in the University of Boya. And I have my co-authors, Professor Shishom, who is the Vice Dean in charge of Research and Cooperation, Faculty of Health Sciences, and our powerful HOD of the MLS Medical Laboratory Science Department, Faculty of Health Sciences, Dr. Ngemaya Moses. And I want to also acknowledge Wisdom Foundation and a political foundation with founding president, Mr. Lefford Divine, for their sponsorship of this study. And my sincere and honest thanks to CamDocUK for the privilege to organize something like this, inviting us to share our idea to the world. It's my greatest privilege, and I say a big thank you, thank you, thank you.
Thank you so much for your brilliant presentation. The next presentation will be done by Ashidi Aduni Ufeyan. It will be about association between serum ferritin levels and glycemic control in type 2 diabetes mellitus patients attending the Boya Regional Hospital, Southwest Region, Cameroon. You have the floor.
Thank you, Madam Chair. Thank you, the chairpersons, professors, doctors, ladies and gentlemen, all protocols duly respected. Good evening. I'll be presenting research findings from my MSc dissertation titled Association Between Serum Ferritin Levels and Glycemic Control in Type 2 Diabetes Mellitus Patients attending the Boya Regional Hospital, Southwest Region, Cameroon. Next. Diabetes is a group of metabolic disorders characterized by hyperglycemia and insufficiency in insulin production or action. According to the International Diabetes Federation in 2021, they provided reports that about 537 million adults were living with diabetes mellitus globally, and this value is on a constant rise, estimated to rise to about 643 million in about 2035. Diabetes reduces life expectancy by a decade. The most common types are the type 1, which is due to insulin deficiency, and type 2, which is due to insulin secretory defect in pancreatic B cells or insulin resistance or a combination of both. In Cameroon, diabetes prevalence has been on a steady rise, increasing from 2% in 1999 to 4.7% in 2002 and about 6% in 2018 in studies conducted by Bigna et al. In Cameroon. Glycemic control is therefore very pivotal in order to control and alleviate diabetes by delaying or preventing the onset of complications. Ferritin, which is an intracellular protein complex that reflects the iron stores of the body, has been reported to be inconsistently correlated with markers of glycemic control, that is glycated hemoglobin and fasting plasma glucose. A study carried out in India reported a positive correlation between HbA1c and fasting plasma glucose with serum ferritin. This result correlated with findings from Raoul and Salom in Egypt in 2018, who also reported positive correlation between serum ferritin and glycemic control parameters. Contrary to this report, some other studies have also reported negative correlations between serum ferritin and glycemic control parameters. So it is therefore important that we also evaluate, or this study made us to determine the relationship between serum ferritin levels and glycemic control in type 2 diabetic patients attending the Boya Regional Hospital. It was a cross-sectional study based in the Regional Hospital Boya from January to June 2022. We recruited 82 patients from method. So demographic fact parameters, lifestyle, clinical, anthropometric data was collected using a structured questionnaire. Serum ferritin, HbA1c, and fasting plasma glucose was measured using the ELISA and spectrophotometric methods, respectively. Results. The mean serum ferritin level of type 2 diabetes patients with poor glycemic control was high as compared to that of patients with good glycemic control. As we can see, we had 54 of our participants having a very high serum ferritin level as long as glycemic control status was not achieved. So those participants with good glycemic control, which amounted to a total of 30, had a mean serum ferritin value of 268.9, which falls slightly within the normal range of ferritin values. Next slide. In this study, we also realized that overweight, according to WHO classification, most of the participants were overweight. Few of them were obese class 3, and 23 of them were class 1 obese. Next slide. There was a positive correlation found in this study between serum ferritin and fasting plasma glucose concentration, which correlated with findings from Rahul and Salom in Egypt. There was also a positive correlation between serum ferritin levels and fasting plasma glucose concentration of females in type 2 diabetic patients. These results also correlated with findings from Rahul and Salom in Egypt. We also had a positive correlation between serum ferritin and HbA1c in the female type 2 diabetic patients, as shown on the figure. These findings also correlated with Rahul and Salom, and it was noted that the high serum ferritin levels could be due to the oxidative stress induced by hyperglycemia and low chronic inflammation, and also due to the fact that hyperglycemia induces or suppresses the action of the hormone epsidin, which controls the absorption of iron in the hepatocytes, leading to extra hepatic iron stores increase. Type 2 diabetes patients aged 61 to 70 were 3 times likely to develop hyperferritinemia compared to those aged 41 to 50 years, as these results also correlated with findings from Shubham and al. In 2018. So we observed that age was associated to serum ferritin level due to the low chronic grade inflammation that is being observed as we age. Next slide. So after all of these findings, we concluded from this study that majority of the type 2 diabetes patients attending the regional hospital had poor glycemic control, and their serum ferritin levels were observed to be very high as long as a good glycemic control status was not achieved. So serum ferritin levels also correlated with markers of glycemic control, HbA1c, and fasting plasma glucose. We recommend from this study that further large-scale studies, prospective studies, are warranted to confirm these findings and ascertain the patients which are likely to benefit from lifestyle or therapeutic interventions, so as to see if hyperferritinemia is actually a call for concern in type 2 diabetic patients. Next slide. Next slide. Immense gratitude goes to my main supervisor, Professor Asop Jules Clement, who is the Vice Dean of Research and Cooperation, Faculty of Medicine and Pharmaceutical Science, the University of Douala, and my co-supervisors, Dr. Achidi Adunai, who is an Associate Professor of Nutritional Biochemistry, the Department of Biochemistry and Molecular Biology, Faculty of Science, University of Boya, and also Dr. Ebodwater Ojong, who is a lecturer of Chemical Pathology, Faculty of Health Sciences, University of Boya. Here present, my mentor and father, who single-handedly held my hand and brought me over here. And I also wish to acknowledge the staff and the head of department with the Medical Laboratory Science from the Faculty of Health Science, University of Boya. And lastly, I appreciate and acknowledge CamDocUK for giving us the privilege and opportunity to present our research findings in this wonderful conference. Thank you very much.
Right, and last but not least, Dr. Ombede Ebega Julia. And she's going to be talking to us about the psychological and social impact of induced abortion in post-abortal women.
Good afternoon, everybody. Welcome to this presentation where I will present a piece of our work. My name is Ombede Abega Julien. The work was supervised by Professor Hale Ikani Gogori and co-supervised by Professor Yenshu Verbo Robert and Dr. Chunzo Emmanuel. on psychological and social impact of induced abortion in post-abortal women. It was a cross-sectional study done in Boya, Southwest region of Cameroon. For this presentation, we shall follow the following outline. Induced abortion is termination of pregnancy before the age of viability by a qualified personnel under a maternal request or a healthcare request. Induced abortion in general probably is underestimated due to underreporting, resulting from classification as maternal death to other causes than abortion. Main cause of induced abortion being the law restriction. This restriction also increased the practice of unsafe abortion with a high mortality rate of 25% in Cameroon. Induced abortion is prohibited by the law in Cameroon, although it has a special consideration as to save the maternal life in case of rape or in case of incest. But it's still done in high secrecy as a solution for unintended pregnancy with a proportion of 21% in Boya. But induced abortion is considered as a stressful event in woman's life, which can lead to psychological and social disturbance. Our main objective was to determine the type of psychological effect and social impact of induced abortion from the post-abortal woman in Boya. For this, we settled a cross-sectional study with a qualitative survey from the 13th December 2023 to the 5th April 2024. Our area of research was a hospital-based study conducted at Boya Regional Hospital Solidarity Health Clinic, 7-day Adventist Health Center, Munya Subdivisional Medical Center. The other hospitals were a little bit restricted. They were afraid of the law, so they didn't admit us. Our population of study was women who had an abortion. The inclusive criteria was all consenting women with a history of abortion, induced abortion, which has received post-abortum care. And we excluded all women with a history of induced abortion with a previous psychiatric condition. The sampling method was a probability sampling technique, which was associated with a snowball, conveniency, and accidental. The sample size was also done by the principle of exhaustiveness. We settled our questionnaire in 3 parts: the socio-demographic characteristic, the screening sexual and reproductive health, the psychological and social health state using a post-traumatic event scale. The data analysis was done following the quantitative data was coded into Excel and analyzed using a statistical package of social sciences version 27. The qualitative data was coded to age and occupational status and analyzed using inductive method. Continued variable was expressed as mean and standard deviations. Categorical variable was expressed as frequency, table, and chart. By variate analysis, association between dependent and independent variable was also done. The statistical significance was settled at p-value less than 0.05. Dear audiences, our result and discussions. Out of 35 cases of induced abortion, we had in 2024 7 cases. In total number of cases of abortion, 18, giving a prevalence of 38.88%, which was a little bit higher than the study done by Boyfriend and collaborator in 2019 in Boya, which had 21%. Talking of psychological response, we have the signs of guilt. The feeling of guilt reported by respondents were usually of short periods, usually following few days after the induced abortions, reported by those whom the induced abortion was done maybe 3 days or 1 week after. So it was a cleaner of 22 years old who reported, "I feel guilt of murder." And we have also the second one was anxiety, reported by a student of 20 years old, which said, I reject thought about it, but when the thought about it come into my mind, I feel numb. And we classify the psychological impact into three main response. The intrusion was the first one that we had. We saw that we have the uncomfortable feeling, which was at 57%. Guilty was at 28%, giving a total number of 51.4%. The acceptance of the situation was found at 91.4%, even though it was associated with rejection of thought about it at 82.9%. Feeling of numb when thinking about the situation was at 65%. All of them was in discordance with the Albongazem and collaborator research done in 2011 in Iran, finding that worry about the thinking of other people was their main problem. Worry about not being able to have another baby or to fall infertile was their main problem. The rest, they didn't care about it. The next one was hyperarousal, which we were having irritability. When you ask the question, the patient would just feel like, I don't want to answer, please leave me alone. I'm tired of you. So it was at 55.7%, and feeling angry when at the time that you are mentioning just the word abortion, the patient don't want to talk to you. It's finished, the discussion is over, which was similar to the study done by David and collaborator in 2018, which was also having hunger at 81% and also rage at 52%, and susceptibility to loss control at 59%. The last on the psychological impact was relief. Relief was also associated to refusal to go through another induced abortion experience, which was a little bit contrary to the study done by Brenda Major et al. In 2000 in United States of America, where majority of the participants were free and wanted to run another experience in case that they are still pregnant of unwanted pregnancies. So for the social consequence, we have social stigma, groups in three groups, familiar stigmatization, reported by a student of 18 years old who said that I received constant insult from my mom that I did. Congregation of church stigmatization, reported by a student of 21 years old who said, I was mocked and disgraced by others in my place of worship because they got to know that I was pregnant and I did an abortion. We have healthcare professional stigma coming from a student of 24 years old who said they consult me, and a housewife of 30 years old said the contrary by saying that they always remind me that it's what makes me sterile. For this, we group the social consequences in a table, taking all of their feeling about the society. And we had the three major one, feeling of social rejection, which was at 34.3%, feeling of social judgment, which was at 51.4%. We have also feeling of social regard, which was at 54.3%, which was the same which the study done by Median Moreno and collaborator in 2019 in Mexico, and different from the study done by Thomas and collaborator in 2022 in India, which found that healthcare personnel was the major cause of induced abortion in this state and frustration of women. For this, we try to find an association to see what can be the cause of the psychological impact of abortion, what can be the major induce of those psychological causes. For this, we went through a bivariate analysis using a chi-square with a p-value less than 0.05, in which we found that we had just three variables: employment status, monthly income, and method of induction. From this, none of them found to be associated to the psychological impact, which was different from the study done by Van and collaborator in 2017, who found that unemployment was the major cause of psychological impact. For this, I found that it was important to present my limitation from our study. The main limitation was our sample size, which was relatively small. We were limiting the generability of the finding to the entire population of Boya. Like I said at the beginning, the main one was the law. Everybody is afraid of the law. In conclusion, we had a proportion of induced abortion, which was higher at 38.88%. Secondly, most of women with a history of induced abortion had psychological intrusion, avoidance, and hyperarousal as predominant among post-abortal women in Boya. Thirdly, social stigma and healthcare professional stigma were predominant and associated to breach in the confidentiality of the procedure. And lastly, we found no factor associated to the enhance of psychological issue in post-abortion women. As a recommendation, our recommendation goes to 3 levels, starting from the healthcare personnel, that all post-abortion women should receive psychological support and follow-up. To the family, the parents, they should be tolerant and supportive in front of an unintended pregnancy or an induced abortion. To the Ministry of Public Health, to make free access to contraceptive methods for all teenagers to prevent further induced abortion. Thank you.
Merci, docteur Ombede, pour votre brillante présentation. Donc, nous avons suivi au total 1, 2, 3, 4 présentations. Nous allons faire un bref résumé. La première présentation, c'était celle du docteur Solange Bonsour-Loureux, qui parlait des modes de vie dans la prévention et le contrôle des maladies non transmissibles chez les adultes au district de santé de Bamenda. Il a retrouvé au total 269 personnes adultes dont la moyenne d'âge était de 38 ans. Les connaissances étaient moyennes et 34% de ces patients étaient inactifs sur le plan physique. Ils consommaient beaucoup de sucre et la recommandation principale était d'éduquer la population, surtout sur la nutrition. L'équipe du docteur Walter Ebok-Odjon, qui a présenté l'effet de la chimiothérapie sur le profil hématologique des patients atteints du cancer du col au littoral, on a retrouvé que la plupart des patientes qui étaient atteintes de ce cancer étaient des femmes ménopausées et le stade 3B était le plus retrouvé. Et on retrouvait qu'il y avait des effets statistiquement significatifs sur les globules rouges, les globules blancs, l'hémoglobine et les plaquettes. Et donc, il y a des effets secondaires de la chimiothérapie sur les paramètres hématologiques. Et la principale recommandation était le dépistage des cancers précoces pour une prise en charge précoce. L'équipe du docteur Berignou Bédé, qui a présenté sur l'association entre les niveaux de sérum ferritine et le contrôle glycémique chez les patients diabétiques de type 2 à l'hôpital régional de Bouéa, a retrouvé qu'il y avait une corrélation positive entre la glycémie à jeun et la ferritinémie, également entre la glycémie à jeun et l'hémoglobine glyquée. Et la principale recommandation ici était toujours d'améliorer la qualité de vie des patients diabétiques. Et la dernière communication du docteur Ombede, qui portait sur l'impact social et psychologique de l'avortement induit chez les patients après avortement. Elle a retrouvé une prévalence de l'avortement induit à 38,88% chez 102 patientes. Et sur le plan psychologique, on retrouvait principalement la culpabilité, l'introversion, l'évasion, l'hyperexcitation et la douleur. Et on retrouvait également une stigmatisation sur le plan social. Et ici, comme recommandation, il fallait un support psychologique de ces patientes qui ont fait des avortements. Et la recommandation qui allait au ministère de la Santé était celle de mettre à disposition des jeunes filles des contraceptifs. Donc, sur ce, nous allons passer la parole au professeur.
Thank you for that brilliant summary, Dr. Arlette. While the deliberations have been going on, Professor Ngachu, who is our conference master, has been going through all the presentations that we've heard today and also yesterday. And I believe it's only fitting that he'll come and announce the winner. And he will also then talk to us about, just give us a closing because we're unfortunately running quite late. I'm sorry we couldn't take any questions. We are going to let Prof now talk and we'll get the prize and certificate ready.
Right, ladies and gentlemen, professors, colleagues, students, nurses, and paramedical staff. I would like to thank you for persevering with us. We've come to the close of our seminar, and I'm sorry we did not have the opportunity to carry out questions in the last session because we are running extremely late. What I would like to say is regarding the abstract presentations, what an excitement. I had so much difficulty to select which is the winning abstract. And I might do a bit of assessment of what were the difficulties. Some of the abstracts were exceptionally clinical and had very good information. For example, the correlation between ferritin and glycemia. That was very, very clinical. And I would like to advise the people who have done that work if they can also look at the correlation between ferritin and fatty liver disease. It is very common. I'm sorry, I like to teach. It is very common that diabetes and fatty liver disease, they form part of metabolic syndrome, and they will go hand in hand. So somebody will have fatty liver disease with no diabetes. 10 years down the line, they will develop diabetes, and vice versa. And all of them have in common a high ferritin. So if you can work on that, check it out. So that was a very interesting research clinically. There's also the research paper on sleep disorders and stroke survivors, which I found it very, very interesting. The science, the statistics behind that work looked exciting, but needs reviewing. The work on chemotherapy and hematological parameters, I thought was quite interesting because it helps in our day-to-day management of patients. And the presentation on lifestyle practices and prevention of and control of non-communicable diseases, I thought that was also exciting in the community. What I, however, think I would like to give the prize of this seminar is one that actually might sound very simple, very topical, but I think it embodies the idea of doing something simple, economical, with a significant impact. And I would like to say the winner today is Mr. Boniface Takwe Njeko. This presentation actually talked about know your numbers. And it is very simple. You go out, you measure the blood pressure, you find a patient with high blood pressure, and you give a brief medical intervention. You advise the patient, this is what is wrong, this is what you need to do. You go and do it. And believe me, such interventions can make significant impact. You don't need any university degree to deliver that intervention. And even though he's mentioning it on hypertension and diabetes in the community, the same intervention is being used in patients who have alcohol-related problems. So patients who are dependent on alcohol, the mainstay of treatment is a brief intervention. So simple, tell them you are drinking too much and you will harm yourself, can make some people change their habits. So I hope I am justified in awarding our prize to Mr. Takwe. Right. Once more, let me seize this opportunity to call this seminar to a close. But before calling it to a close, I would like to thank all of you for having spent the last 2 days with us. During this seminar, we've had magistral lectures on topics like acute liver failure, endocrine emergencies, gastrointestinal diseases, neurological and cardiological emergencies. We have heard about the rising prevalence of NCDs and particularly those related to lifestyle modifications. We know that lifestyle changes are responsible for our demise, and I think if we're going to take something home today, is to make lifestyle changes for a better health outcome. We have learned about the healthcare practices in Cameroon for those of us from the United Kingdom. We've learned about health practices in Cameroon, and we hope we have been able to exchange ideas with you people about health practices in the United Kingdom. We hope that exchange will help to enforce some of the activities that you do, and maybe also to support you in making some of the changes that you might need to make a little improvement in the outcome of our patients. One of the highlights of our presentation was actually the medical training initiative. That program is supposed to be for postgraduate training, and we hope to actually press on with that initiative. We think this seminar is the first of its kind from CamDoc, and we hope we'll have future seminars, and we hope to see many more of you present, hopefully as consultants at the next time, or be more participant with more abstracts and more interventions. Thank you very much.
Yeah, before we finally close, we did say to you that you'll all be getting CPD points, 12 CPD points from the Royal College of Physicians. I hope all of you registered, because we're going to send you a feedback form through the email addresses you registered for the conference. When you filled in the feedback form, you'll get your certificate, all nice and shiny with your 12 CPD points, which you can use. So please, I urge you, if you did not register and just came in, do leave your email addresses so that that feedback form can be sent to you. If not, you will not get your certificate, and that will be quite a shame. So we've got them all ready, but we would like your feedback first on what we did well, what could be done better. This was obviously our first conference, and we would like to come back and do some more. and we'd like to know about the things that you want to learn as well, because of course, over 2 days, we could not cover every single thing. So I think I can call the conference to a close now. Are we having, there's some coffee, since we didn't have our coffee break, there's some snacks at the end, which you can take home with you like you did yesterday. And it was really lovely to meet you all. All our details are on the website with camdocuk.org. Everything you learned today, everything will be on YouTube. So have a lovely evening and take care. And it was nice to be back in Yaoundé. Sorry, CamDoc members, can we have a group photo by our banner? And then before we all disappear. I guess, yeah, we could do it here. Yeah, easier. Let's do it here. CamDoc members. Oh, are we having a, well, we already had it. Don't even. CamDoc members. Yeah, okay. Yeah, who is the camera person? Yeah, just, yeah, 7. Yeah. CamDoc members. Leo, if not, we'll just take with whoever is here. I think we'll... Who's taking the photo? Where's the cameraman? From you?